Very well, and yourself?
Thank you so much. I'm fine.
Yes. And are you all in basically you're able to be in the clinical setting or in the home office, or what's the situation?
Yeah, we are working now. I will be presenting from my office.
Yes, yes. It's very difficult, well, in Switzerland as well with the whole pandemic, and yeah, so mostly I'm working from home now.
We are trying to manage, but it's better than last year.
Yes, yes, that's for sure. Yeah.
So I have my colleague with us, Mr. Eric. He's my colleague at Sultan bin Abdulaziz Humanitarian City. He's one of our service manager. Hi, Eric. One of our speakers as well.
Thank you. Thank you. Welcome.
That's wonderful. I was just saying, it's just so amazing that we can actually have this conference and, you know, whilst using this digital environment. It's absolutely fantastic, isn't it?
Yeah, definitely. Yes. Yeah. With the current pandemic, providing such conferences to the staff, also to the audience, it's really adding value to them. Yes.
Yes, absolutely. Yeah.
So what time we are expecting to start? 11:30 or 1:45? Because
well,
the time with us 11, so for you 9.
For me 10. We're ahead from London, so well, it said the program's going to start at 9:30 UK time, so 10:30, 11:30, and I guess they may just do a trial if everybody is able to log on.
Yeah, good.
That was my biggest fear, that you're sitting here and you have no connection or it's not working. It's just like, oh no, please. Yes.
Oh, this is I hope everything will go smooth.
Yeah.
Okay, I will be around, but just I will put mute.
Hello, everyone. Can you hear me?
good morning.
Good morning. I think this is Amal.
Yes, good morning, Lina. Good morning, Ms. Susan. Good morning, Dr. Tariq and Dr. Eric. Welcome for our conference.
Good morning, Amal. How are you?
I'm good. Thanks for asking. How about you?
Very well, thank you so much.
Thank you.
Okay, I guess we are all gathered. So it is to me to wish you a very good morning to everybody from here, from myself, Zurich in Switzerland. And I would like to extend a very warm welcome to all participants, students and delegates for the Scientific Global Digital Gathering at the Healthcare Management, Nursing and Patient Safety Conference today. My name is Suzanne Rayburn-Burgess, and I'm the Director of Global Customer Relation Management at LAP, Switzerland, and I will be the chairperson of today's session along with Ms. Amal Ibrahim from Jordan. Firstly, I would like to tell you something about the UCG conferences. Utilitarian Conference Gatherings offers a wide range of events, meetings, conferences, workshops, and symposiums. We have a dedicated team who are aimed at acquiring the technologies, adopting the knowledge of business needs, and accelerate with the best ideas and strategies. Utilitarian Conferences Gatherings is a pioneer in the area of event management, collaboration. We are a full-service event provider specializing in the field of medical, clinical healthcare, life sciences, engineering, pharma, environmental science, engineering, business, agriculture, and food event services for academic and the industrial sectors. We stand out distinctively from our competitors for our commitment to quality, round-the-clock service, and unmatched price. We are able to provide you with the best event meeting experiences under one roof. We at the Utilitarian Conference Gathering make sure that you as a client choose the most appropriate event. I thank you now all for finding time in your very busy schedule to be here today. Today marks the major activity in the brief existence of the UCG conference, a moment where we are interacting and sharing experiences and reflecting on various areas. UCG 2021 is a remarkable event which brings together professors, researchers, and students in the field of healthcare, making the online conference a perfect platform for sharing experience, foster collaboration across industry and academia, and evaluate emerging technologies around the globe. We cordially welcome you to join us and witness the advancing in this field all together. The conference has attracted delegates who have come from all over the world, across the continents, and the subject of the conference is surely of global importance. UCG thanks all the individuals and organizations who have worked to make this conference a grand success. HNPSUCG Program Committee has put in long hours with many creative efforts, and finally, I would like to extend my appreciation to the participants of this conference. We hope you enjoy the conference and that your participation will contribute to our professional development and relationships. Please note in the further speech, the speech time for speakers will be 30 minutes. The speech time for keynote speakers will be 50 minutes. And please also be aware that certificates will be provided on April 10th, 2021. Now, swiftly, we will move on to who is going to be keynote speaker today at day one. And therefore, I have the immense pleasure of introducing our keynote speakers at the Healthcare Management, Nursing and Patient Safety Conference. First, we will hear Miss Lina Obaid. She's a quality nursing supervisor at Sultan bin Abdulaziz Humanitarian City in Saudi Arabia. Followed by Dr. Essam Ali, Director of Quality and Accreditation in a private hospital in Abu Dhabi in the UAE. Then there's going to be myself, Suzanne Rayburn-Burgess, and followed by Mr. Dr. Farouk Mirza. He's a consultant healthcare quality and patient safety, certified patient safety trainer at CPSI, Director Mirza Healthcare Associates Incorporated from Toronto in Canada. Then we have Professor James Jordan, President and CEO of Straff Tactic Incorporation in the US. Dr. Sarah Al-Dalal, Senior Health Service Specialist at DHA, also from UAE. Professor Tarek Ali, Professor and Consultant Physician, Internal Medicine at UAE, is a medical expert and lawyer and researcher in medical philosophy. Followed by Dr. Jorge Hidalgo, Head of Intensive Care and COVID-19 Unit at Belize Healthcare Partners Limited, Secretary General of World Federation of Intensive and Critical Care Medicine in Belize. Dr. Jamila Ali Al-Hinai, Project Director of NSRD 2040 of Oman. And last but not least, Dr. Jenny Mariam John, Healthcare Development Officer at Dubai Health Authority from the UAE. Thank you all for this introduction, and now it is my pleasure to actually start and begin with the sessions. I would like to introduce our first keynote speaker, Miss Lina Obaid from Saudi Arabia. And Miss Obaid will provide us with a speech using lean management approach in improved clinical team leader handover process in nursing services. A few words about her. Miss Lina Obaid has completed her bachelor degree in nursing science from Jordan University in 2007, followed by a master's degree in public health from the same university in 2010, and certified by the Jordan Society for Quality as a certified quality master. She is the nursing quality supervisor in Sultan bin Abdulaziz Humanitarian City. She has facilitated and led more than 20 performance improvement projects by using different quality methodologies. She's one of the keynote speakers at the yearly Nursing Management and Leadership course and Nursing Rehabilitation course. So please, Lina, handing over to you, and we are very, very eager to hear your keynote speech. Please, Lina.
Thank you so much, Susan. I'm trying to open my camera, but I cannot. Just a minute. Yes, okay. So, thank you so much for the introduction, for your kind introduction. I will be sharing my slide with the audience. Okay, I hope you can see my slide.
Yes, perfectly. Thank you so much, Lina.
Okay, great. So good day to all, and it's my pleasure being with you today at the Nursing and Patient Safety Conference that is organized by UCG to share one of our quality improvement report, which is using lean management approach to improve the clinical nursing practice within our facility. So first, allow me to introduce our lovely city to the audience. In Sultan bin Abdulaziz, the Humanitarian city is one of the largest rehabilitation facility and the best state-of-art medical rehabilitation in Middle East, with a capacity of 500 bed capacity and more than 20 inpatient nursing unit with outpatient services. So the city is driven by a person-centered care philosophy toward its patient, and it's strongly supported by leadership and evident in the development and implementation of services, system approach, and interventions. Among these approaches is acknowledging accreditation to continuously improve and contribute to patient safety and quality of care. And part from this improvement is our quality report, one example out of many other examples. So to move on with our aim from this report is to test the effectivity of lean management approach in improving the duration of clinical handover by eliminating unnecessary steps toward a more efficient, sustainable, and effective communication between the clinical team leaders in nursing units. So why we are selecting lean management or lean approach? Lean is a set of operating philosophy and method that help create a maximum value for patients by reducing the weight and waste. So it's emphasized the consideration of customer needs, employee involvement, and continuous improvements. So let us just speak about the clinical handover or the importance of clinical handover. Clinical handover is referred to transfer the information or transfer the professional responsibility and accountability for some aspect or all aspects for a patient or a group of patients to another person or professional group on a temporary or permanent basis. It is in fact a valuable and essential part on any healthcare organization. However, at our facility, the clinical team leader face a challenging role during the handover due to the prolonged process causing extra nursing hour beyond their schedule. So how did we identify such issues? Through our partnership with the National Database of Nursing Quality Indicator, the services were able to identify one of our area for improvements. During the RN survey of 2019, the 83% of the staff reported that they are working more than or equal 1 extra hour beyond their schedule of 1 hour. So at the city, utilizing all resources and tools to improve nursing practices and the process, one of the major aspects in any other healthcare organization as well. So moreover, improving communication process between healthcare providers were declared as one of the international patient safety goals by the Joint Commission. So a clinician should follow a well-communicated protocols that guide them for well-communicated and transfer of information. So before we move to the lean and the steps and the strategy of lean, I would like to show you a short video from Gemba Walk Academy. We'll introduce the lean concept to the audience, then we will proceed with our tool and the strategy of lean approach.
Hi there, I'm Ron Pereira of Gemba Academy, and I'd like to ask you a question. If someone asked you to explain what lean thinking is all about, what would you say? Well, by the end of this video, you'll understand and be able to explain exactly what lean is and why lean is beneficial for individuals in any sort of organization, no matter the industry. All right, well, let's begin with a definition. Lean is an operational excellence strategy that enables people and organizations to change for the better. Put another way, lean thinking organizations are constantly seeking out ways to continuously improve the way they work. Another common way to define lean is that it's the persistent pursuit and elimination of waste. Now, a few examples of this waste could be the waste of waiting, the waste of defects, and the waste of excess motion, leading to lost productivity and, in extreme cases, injury. And while lean is all about improving processes, its greatest value lies in the development of people, since in the end, lean is a people-based system. Yes, the many tools and concepts of lean are important, but if you neglect the people aspect, failure is almost a certainty. In fact, lean is often described as a system focused on creating customer value. Well, the base of the so-called lean house consists of concepts like teamwork, challenge, and Kaizen, which means to change for the better. Then there are two pillars that hold the house up. The first is continuous improvement, which represents the many tools and concepts of lean, while the second pillar, respect for people, represents the importance placed on the development of people. To be sure, you can't succeed with lean without both of these pillars firmly in place. Finally, from a definition perspective, it must be said that lean isn't only about attacking waste while increasing the speed at which products are produced. Lean is also very focused on improving the quality of our products and services, as well as the stability of our processes. In fact, many lean principles, such as one-piece flow, will never succeed without stable and high-quality processes in place. So that's how we can define lean. The next question we'd like to address is why so many organizations are using lean to improve their businesses and, more importantly, the lives of their employees and customers. And to answer this, I'd like to ask you a few questions. Have you ever experienced long waiting times at the doctor or any sort of service center? If so, how did it feel? Conversely, have you ever ordered something from your favorite online store and received the item later the same day? If so, how did that feel? Lastly, have you ever purchased something that was made and performed so well that you were forever a loyal customer? Well, obviously, very few people like to waste time waiting, and experiences like same-day delivery and extremely high-quality products are most definitely delighters. And as it turns out, many of the organizations practicing lean see results just like these without resorting to holding excess inventory or expediting or performing excessive visual inspection. It should also be pointed out that these same lean thinking organizations also reap many other benefits, including improved employee engagement and morale, reduced operating costs since employees are constantly seeking out improvements, and improved safety for everyone in the organization. Taken together, all of these improvements ultimately lead to increased profits and long-term success and growth of the organization. And with all of this said, one of the most exciting aspects of the work here at Gemba Academy is hearing lean success stories. For example, our friends over at the FedEx Office Manufacturing Network reduced accuracy failures by 30% when they transitioned from a batch and queue workflow to continuous flow. They also reduced the injury rate by 60% through the application of daily improvements in shift huddles. Next, the folks over at Franciscan Health in Indianapolis, Indiana, began saving more than $30,000 per year when a lean thinking nurse found a better way for endoscopy patients to deal.
Okay, thank you. So out of this video, just a minute to move the slide. Okay, so after this video, we can say that the lean in healthcare is the application of a lean ideas to minimize the waste with the ongoing process. So the finding promoted the team to formulate a core group to investigate and carry out a systematic and formal inquiry to discover and examine the fact of the incident. So the team or the core team started with a Gemba walk. Gemba walk is a Japanese term, which is reflecting to real place. or to be on actual place. Gemba walk, it's an opportunity for the staff to stand back from their day-to-day task to walk with the floor of their workplace to identify the wasteful activity. So the objective of Gemba walk is to understand the value stream and its problem rather than review results and make superficial comment. So the team went to the unit to observe and recognize the practices and the waste within the process. So there are 5 recommended golden rules of Gemba Kaizen or Gemba walk. First is to go to the process or to the actual place to see the process on reality, to observe and to recognize, and to look to the flow of the process. Then to take measures with you, because if you cannot measure it, you cannot improve it. So you need to have some measures. And to know or to identify the ways to find the root cause and to kill it by using or eliminating the 3M, and standardize to prevent the recurrence. So let me highlight the 3M, or to eliminate the 3M. What does that mean? Through Gemba walk also, the 3M is reflecting to a term of Moda, Mora, and Morai. And also the 3 terms were used together in Toyota production system. And I'm sure if we have an attendees with us, experts in Lean, they are aware about the 3M. The Moda is reflecting the wasteful activity, if there is any wasteful activity within the process or the practice. The Mora is reflecting the inconsistency in the system, and Morai is reflecting the physical strains. So when we are going to visit the unit to see, we need to look to the waste to eliminate it. If there is any inconsistency in the system, so we can avoid if it's happening sometimes or in some places or with some people, and to look to the physical strain. If there is like overburdening equipments, issues with the system, because physical strain really reducing the enjoyability and the effectiveness in addition to the efficiency of the staff. So the staff, when they conducted the Gemba walk, they were focusing on the 3M to see the duration of the handover, and this was the main aim for this projects. The type of waste, identify the waste, which is the MODA, the type of defect or gap in the process, and the common practices to see if there is any inconsistencies in the system or practices that the staff are doing. After visiting 50% of the unit and attended more than 12 handover process, the team found that the average in all units, it's between the 40 minutes to 60 minutes. So the staff really exceeding the time frame between, or the usual time frame of having the handover between 20 to 30 minutes to exceed up to 1 hour from their schedule. So after listing these findings, the staff went to the second tool of lean management, which is the value stream map. The value stream map is an important element in implementing lean approach. The goal of which are to maximize customer satisfaction, which is our staff, and minimize the waste. Value stream map usually are conducting after the Gemba walk, after attending the process in details with the staff, then coming to draw the value stream map to see the value adding or non-value adding activities by using a certain kind of waste. So again, before I proceed with the tool, to show you the tool or to display the graphical representation of the tool, I would also share with you one video from Gemba Academy as well, sharing with you the 7 deadly waste that is affecting any process within the organization, either in healthcare organization or in industrial organization. So let us watch together, then we will move to the value stream map to discuss more about this tool.
is Ron Pereira of Gemba Academy, and I'd like to welcome you to this course that's focused on dealing with the 7 deadly wastes. Now, in this first module, we're going to get things started with an overview of the topic, where we'll learn what the 7 wastes are, allowing us to then build on this knowledge in later modules, where our focus will be on finding ways of eliminating all forms of waste. Well, specifically, by the end of this module, you'll know exactly what it means for an activity to be value-added, non-value-added, or waste. And you'll also be able to identify what are commonly referred to as the 7 deadly wastes. Now, throughout this course on the 7 wastes, we'll be visiting RAM Technologies, a custom foam fabricator located in Washington. And while inside their factory, we'll do our best to demonstrate what each of the 7 wastes look like, while also showing what things look like when these wastes are eliminated. So let's go ahead and start things off by discussing the various elements of work. Now, when I say elements, I mean that any work or activity we do can be classified into one of 3 categories. First, we have what we call value-added work. Now, for something to be called value-added, 3 things must exist. The customer must be willing to pay for it. The thing must be changed in some way. In other words, we like to say that when value-added work is done, the form, fit, or function of a thing is changed. And finally, the work must be done right the first time. Now, if any of these 3 points are missing, the step or process cannot be said to be value-added. And while value-added activities are what we prefer to do most of the time, we won't spend much time or effort focusing on value-added steps as it relates to reducing waste. But I'll explain why this is later in the module. Next, non-value-added work is work that adds no value, but must be done to meet the customer's needs under today's conditions. Now, this is a minor area of focus in lean manufacturing, since it's harder to improve in this area, and there's less of this type of work than the third and final category, which is waste. Waste is also referred to as muda, which adds no value and customers are not willing to pay for it. Now, the best way to understand the impact of waste is to look at work from the customer's viewpoint while asking yourself, would I want to pay for this if I was a customer? Now, even some things that you would be willing to pay for may be done at a cost that's too high or with too many non-essential steps. Now, it could be said that eliminating waste is like defragging a computer. When you defragment a computer, you rearrange the data so that you can open up space. But when data is fragmented, there are useless bits that are filling up memory, much like the useless amounts of waste taking up space and time within our processes. By identifying where value-added portions are and moving or removing the non-value-added bits, you improve performance of your computer. In the same way, taking waste out of your process improves its performance by radically reducing the time it takes to fulfill a customer request. Now, as we discussed earlier, we prefer to spend most of our time doing value-added work. Unfortunately, when we look at the total lead time through a value stream, we find that a massive amount of muda, or waste, is stealing resources and time. Another unfortunate activity we often see companies doing is attempting to reduce the overall lead time by making the value-added processes more efficient. In other words, as an example, they work to save a few seconds or minutes of machine cycle time in order to reduce the overall lead time. And while this isn't necessarily bad, there's far more opportunity in reducing the waste in the process first before worrying about improving the value-added steps. With all of this said, in order to be able to attack this waste, we must be able to identify it. So let's spend the remainder of this module by discussing what we refer to as the 7 deadly wastes. Now, the first waste is defects, which is simply work that is less than the level the customer, both internal and external, has requested. Now, some examples of defects are rework, scrap, missing parts, wrong parts, and yield loss at startup. Now, as a point of reference, the waste of defects is also sometimes referred to as a waste of correction. Now, in this example, we see that our operator, whose name is Isaac, is struggling to understand his work instructions, and as such, scrap parts have resulted. Next, We come to the waste of inventory, which is any work or material on hand other than what's needed right now to satisfy customer demand. Now, some examples of inventory waste are excess raw materials, work in process, finished goods, supplies, and spare parts. Now, in an upcoming module, we'll spend more time exploring the different types of inventory we might have on hand, such as cycle stock, buffer stock, and safety stock. Now, in this example, we see Isaac surrounded by piles of inventory, making it hard for him to even know what to grab. All right, next we experience the waste of processing, sometimes called over-processing, which is when something's designed in such a way that uses more resources, such as space, energy, or people, than is truly required. Sort of like using a sledgehammer to smash a peanut. The waste of processing is definitely the hardest to understand and learn to see, since the most common root causes are a lack of understanding of customer needs. Now, some examples of processing waste are machines that are slower or faster than needed, equipment that uses more energy than needed, redundant work such as copying information, drilling a hole instead of punching it, and cleaning something multiple times. Well, here we see Isaac carefully measuring each piece of foam when, as it turns out, these pieces have already been cut to size and don't require such meticulous and time-consuming verification. Next, anytime there's idle time created because materials, machines, or information are not ready for people, we have the waste of waiting. Now, this waste is usually less visible than the others because it's often replaced by overproduction or busy work. So, in fact, when waiting becomes visible, it's important to keep people from working just to keep busy, since this busy work often does more harm than good. Now, some examples of waiting are people waiting for materials, an accountant waiting for information to close the monthly books, warehouse employees waiting on a forklift, or a nurse waiting on important supplies to arrive. Now, in this scene, it seems that Isaac has run out of work and is obviously looking for something to do, so he resorts to his newspaper and text messaging his friends.
Okay, so moving on with our value stream map, the idea from the video was to identify the seven or the waste, the deadly waste in any organization. So later on, after the value stream map, will show you again the kind of waste that the staff detected from the project or during their Gemba work. So the value stream map, as I have mentioned to you, it's like a graphical presentation will reflect the process. So the staff will start from the step of the process, then they will list the time of each step, then the waste in that step, and the reason for having such steps. So in the general, the value stream map will show you a step by step. Then we'll show you also the input and output of each process, the suppliers, customers, media used, and issue presenting during the process. So even within the green zone, if you can see that the staff calculate the time spending from moving from step to step. So during this Gemba walk, this is the after the Gemba walk, and this was the value map of one of the unit that the staff involved all patients while they are observing the handover of the staff, considering not only the flow of the patient handover, but also looking to the flow of the information, walk through the handover process from the first patient till the end patient, and draw the process from starting point till the end point. And it's once the team leader arrived to the shift till the team leader left the shift after endorsement. So the kind of waste that the staff were referred to during the completing their value stream map was using the 8 waste, which is the downtime acronym. The D is standing for defect. They're looking if there is any kind of overproduction, waiting time, non-adding value act by the staff, issues in transportation, issues in inventory, in the motion, employee underutilization, and the team added B as a behavior or reflecting the behavior related to the practice. So after that, the team identified 5 kinds of waste, which is relating to defects, waiting, non-value adding act, employee underutilization, and B, related to the behavior or the practice of the staff. So the process mapping in general, as mentioned in the video, also out of the value stream map that the staff built, is to identify the non-adding value activity. Is there any delay points in the process? Is there any duplication of the forms, lack supporting documentation for the staff, inconsistency in the process, and lack of understanding? So the baseline measurement that the staff identified after of the Gemba walk and the value stream map, that they need to look for the standardized practice. There was no standardized practice because the team leader, they were referring to the assigned nurse handover. So they were using the assigned nurse handover also for their handover, which is also causing more redundancy in repeating the information of the handover. Also detailed handover, which is unnecessary to be there. Many external interruptions affect the team leader handover, cutting the handover to answer those interruptions, and lengthy time of narcotic checking due to the high volume of narcotic medication at the narcotic cabinet. So the target selection of the team were to standardize the duration of the handover to have it within 20 to 30 minutes only. So that the team design a target for them for the handover duration not to exceed 30 minutes, and they have started list their intervention based on this. So before I went to the intervention, I need to highlight how to select the best error prevention tool. And usually we are sharing such prevention tool or hierarchy with our staff before starting the implementation of any projects. Looking to the best error prevention tool is really helping you to look to the optimum level or to reach for your outcome. So starting from forcing functions and constraints, automation, computerization, simplification, standardization will give you the highest level of effectiveness for any intervention. But if we keep our plan within education materials, be vigilant, be careful, rules and policies, you will not reach the highest level of effectiveness. And this was one of the key points during our intervention. We were trying to use the automation, the simplification, the standardization to reach the highest level of effectiveness as an outcome from this project. So the team after that planned their intervention, and they said that there are 8 areas that they need to work on it. First, the standardized sheet for a team leader, and to have a standardized sheet so we will not mix between the assigned nurses handover and the team leader to team leader handover, and to use a SPARC communication tool as a reference for us, standardize the role and responsibility, standardize the practice among all units for the team leader, and review the narcotic controlled medication list to avoid or to eliminate the non-moving medication or narcotic medication in the cabinet, and to use the 5S as a lean tool to rearrange the narcotic medication, eliminate any interruptions, and intensive education for the staff to be with us, more engaged, and focus supporting visit to the team while they are implementing the intervention. So the success of the project led to develop a standardized team leader handover sheet as is reflected to you by using the SPARC communication tool. So several sessions were conducted before building the sheet and getting the frontline feedback for their needs to be there and what kind of important information, in addition to use a SPARC communication tool as a reference, helping us to build this tool. So this tool is reflecting first the 2 kinds of supported information. First is reflecting the unit supported information, which is the number of admission, number of discharge, is there any vital issues that they need, it's related to the unit itself, plus the clinical supported information, which is related to the patient, for starting from the patient identification, situation background, assessment, and recommendation. So if we are comparing the two, the previous practice with the new form or the new practice, you will see in the previous practice, the team leader were using the assigned nurses handover, which is contained of 20 sections. So they are endorsing 20 sections for patients, while the new sheet or the new team leader to team leader, we have 5 sections only to be handed over in addition to the supported unit or unit supported information. Also, the staff were using ongoing team leader handover signage to do not disturb the handover while in the process. And the signage posted while the handover is ongoing to avoid any interruption for the team leader. Also, we have integrated another project with us, which is moving the assigned nurses to the system, to the bedside handover. So they are using the electronic handover for RN to RN bedside, so we'll avoid the merging between the two handover, while the team leader doing or providing their handover on the station. So
hello, Lina? We can't hear you anymore.
yes, I'm
Lina,
with you.
we can't hear.
Yeah. You can hear me?
Yes, all clear.
Okay, good. I will just, because I have shared again, so I'm trying just to, okay, I will be sharing my, my presentation again. I think it's a technical issues. Okay, I'm just trying to reshare my presentation.
Yeah.
Okay, I will share my screen. Okay, no, it's okay. It's okay. You can. Okay, you can stop sharing. I will be sharing from my side. My apology for this. Okay, thank you. And please let me know if you can see the presentation again.
Yes, you're back on, Lina.
Okay, thank you. Okay. I will just go to the strategy because we have stopped on strategy. Okay. So for our strategy, okay, moving to the strategy. My apology for this. Okay, for the strategy, the staff were thinking how to implement those intervention or the planned intervention and using a correct tool so they can reach the outcome of this one. So the best tool to be used is the BDSA cycle. So the idea of using the BDSA cycle, it's a four stages of problem-solving model. And the team decided to use this model in a 4 on or in a small scales. So the idea of having the intervention within a small scales is to tackle any issues within the intervention or while they are implementing the intervention and to solve it immediately. So allow them to educate the staff more and to be engaged more with the intervention. So they have started with the first BDSA cycle, and in the first BDSA BDSA cycle, the staff decided to start with a standard sheet, or introduce the standard sheet, standard the practice, and to have the focus supporting visit to the team. So during this phase, this phase, the project team members join the unit or join the clinical handover again by doing another Gemba walk to observe and examine the use of the new team leader handover sheet, noting the implementation of the changes and the presence of any non-adding value tasks so they can eliminate it in the second BDSA cycle. So after attending the 2 sessions of the clinical handover by implementing the action within the first BDSA cycle, the staff noticed a remarkable decrease in the duration of handover comparing with the Gemba walk phase. So if you can see here the difference between the BDSA cycle and the Gemba walk phase, you will see that the staff were having really a significant decrease by 40 to 30% from the Gemba walk average duration of handover. Still, the team did not reach the target of having the handover below 30 minutes, but they are still in the first cycle. So after that, the staff moved to the second cycle to implement, again, more interventions. So they already introduced the standardization of the role and responsibility of the team leader, eliminating the interruptions by using the signage, plus focus supported team were with them. The idea of eliminating interruptions not only by using the signage, we have also revised the assignment sheet to assign people to answer the phone calls and the call bill of the patient. So we will ensure we will not have any interruptions to the team leader while they are providing. So again, the team in the BDSA cycle were having a significant result, and they were able to reach the 30 minutes of handover and below while they are introducing those interventions. So after that, they moved to the third cycle by increasing the number of piloted units. So we went to other units, educate them about the other interventions, and start again engaging them with us in the third cycle. We have reviewed the controlled and the medication list to remove the non-adding or the non-moving medication, because they are checking those medications as it's not moving, and to reorganize the narcotic cabinet to have the fast moving at the beginning because of the high stock, and then the slow moving medication. So again, in the third cycle, the team were able to notice that they were sustained the improvement of 30 minutes of that duration. So after finishing the intervention or implementation, we'll move to the result or from the statistical wide. So to support the result of the project, the staff want to use the statistical analysis to see is there really a significant improvements between the pre-intervention and the post-intervention when it comes to the duration of handover. So when they are calculating really and examine the between the pre and the post from the statistical side, statistical data were used to support the outcome of the projects by calculating the p-value. And when the team calculated the p-value, they found that really the data is reflecting a significant improvement between the pre and the post test by having p-value 0.008. So also looking to the efficiency, and as you know, the team were looking to the efficiency of intervention and connected with the working hours of the staff. And all of us know that saving healthcare providers time equal to cost saving. So when they were calculating this or comparing with money, they found that saving extra 40 minutes of the team leader handover process will save 8,343 Saudi Riyal per month for that organization instead of paying to the staff every month. So this is really supporting the staff, supporting the outcome of the projects, that we are not only saving the working hours of the staff, we are also supporting and saving the cost of the organization. So moving to the limitation of our project, and any project is having a kind of limitation. One of the major limitation for us is the system for the team leader. The system were supporting us to move to the electronic handover for RN to RN handover, but they didn't support us to move to the team leader handover because the system is not support a group handover of patients. They are supporting the individual handover for one patient. And as you know, the team leader is not responsible only for one patient, is responsible for the unit itself, plus the major or vital issues related to the patient. And this was one of the limitation for us during the project, that we were not able to use the technology or the computerization, which is level 2 of the prevention tool, but at least we were able to use level 3, which is the standardization of the practice by using lean management. So lesson learned were also listed as part from any paper, that having a standard practice will really help the staff to avoid any variation between the units, and making the flow easier even for the staff. Engaging the frontline, getting their feedback, getting their needs will really improve us for improvements, such as using the survey to get the feedback and to see that this could lead to dissatisfaction somewhere. So solving the issue immediately and using the current approaches will help us for improvements. Using also leadership skills is very important. How to manage, or the time management, the assertiveness will help the team leaders to lead the unit in an effective way. Plus the teamwork also to avoid any delay on the process and patient care as well. So our conclusion from the paper was that the lean management approach is effectively improving the duration of handover by eliminating unnecessary steps toward for more efficient, sustainable, and effective communication between team leaders. Moreover, is supporting the hospital in saving additional costs that the extra work hours could lead to. We are encouraging all healthcare providers and settings to go through lean approaches and Six Sigma. All of us know that starting of lean management, the starting were in industrial companies, and recently the healthcare organization were using lean, while in fact our healthcare organization is a complex system and need more lean to eliminate any waste within the process itself. So after our project, we're really recommending lean approaches to be implemented in every single step at our process. So it will really save the cost and the time of our staff. So thank you so much. This is the end of my presentation. If there will be any question, please write it on the chat box or raise it immediately to me. Thank you, Susan.
Lina, thank you so much. That has been so uplifting and so interesting. Thank you so much for your excellent presentation. Now, please, I open the panel for any question to Lina about the lean management. Do you have any question to Lina? Well, I would like to ask you then a few questions, Lina. How was it received? Because I think it is also, you also said, you talked about the behavior. That was one of the points. And I can imagine that that is also a change of culture like it was before. And you can always see that there is especially this handover has a lot of also a social cultural background. How was that received? How did that impact on staff satisfaction? Can you tell us a little bit about that?
Yes, thank you so much for this question. Actually, building a culture of lean management, and it's not easy, even the quality culture within the healthcare organization, and changing the practice. It's really the integration between the quality improvements and the complex system at the healthcare organization. It's not easy. We are building another strategy to change the culture. Plus, Susan, you have mentioned really an important point, which is the staff perception and the resistance. If you are implementing a new approach, you will see there are a level of resistance between the staff. So you need really to engage them more, to have them more with you. So this one of the strategy within nursing services and even within our organization, we are conducting a frequent education to the team related to the lean and related to the quality improvement by also having the nursing performance management course for 3 days, engaging them, introducing to them the quality improvement tools, and show them some literatures that really reflecting the outcome of implementing or after implementing those tools. So building a culture is very important, especially if the organization or nursing services is going toward magnet recognition. Magnet recognition is really looking to the improvements and looking to how to use the strategy and tools to build a culture of improvement or excellence. So we have it in our strategic plan. So we are not waiting to have an issues to start with. We are trying to spread the culture, then find any area for improvement for implementation.
Yeah, I can also imagine that was just the start. I can imagine you were talking about your Gemba walks. Do you do that now? You were just talking about this handovers. Yes. Did it have an impact now on other areas? Do they do now a Gemba walk in how, I don't know, medication is administered or any of this? I can imagine that is like a vehicle and it just perpetuates itself.
Yes. We are doing, and we are encouraging leaders to do Gemba walk. Gemba walk in every single steps. We need to do Gemba walk. It's not necessary to be within the projects. Currently, we are also handling one of Lina projects related to the documentation, to look to the waste in the nursing documentation. And Gemba walk were the first step of attending each process, which is admission process, to see the documentation, discharge, daily, weekly documentation through the Gemba walk. So really, Gemba walk will help you to see on reality. We are not looking to the standard or looking to the perfect policy and the procedure or the perfect flow. We are going to the unit on reality to see what is the current practice. This really will help us to identify the waste in the current practice and to correct it using the proper tool and the strategy. So we are encouraging all to do the Gemba walking every day.
Yes, exactly. We also have a question now from Fatwa Abu Mustafa, and you're asking, was the electronic medical record used while doing the handover, and what was the compliance rate during the handover?
Yeah, electronic handover was separated the project from our team leader to team leader handover, because integration, the electronic handover within the nursing practice, it's not an easy, and it was over more than six months, and we are preparing a scientific based paper on this. Even if you go to see that, you will see that so many articles speaking about electronic handover, but we have a single paper through the nursing journal speaking about integration of electronic handover, reflecting the satisfaction and perception of the staff, of nursing staff. Because implementation of electronic handover, really, it's not an assembly process. We have introduced this as a new practice to the staff before even implementing this on HIS or in our healthcare information system, because the staff need to move. You have a huge movement from paper or the utilizing of sheet to electronic handover. So you need to train them on how to use the devices, how to use the system itself, introduce them to the content, review with the mother company about the content and meeting the standards. So we went actually through a huge project before integrated the electronic handover with our system now. After having this introduction to the staff over almost 6 months, with intensive education using application team. We were using application team because the integration were happening during the pandemic. So it was a little bit difficult for us, but we were having individual and focus visits as recommended by our literature reviews. So to go to the unit and to be with the staff if they were having any difficulty. After 1.5 years, I can tell you that we have a 100% compliance using electronic handover at our city. So this is really for us a great improvement, and we are planning to have it a scientific-based paper from our city.
Super. Did you just have it around your nurses, or were any medical or other kind of staff, like the physicians, physiotherapists, any other therapists involved, or was it just basically based around nursing?
Yes, the electronic handover built in the city through InterSystem or the healthcare, the mother company, from RN to RN, which is assigned nurse to assigned nurse, and the patient definitely involved because it's a bedside handover. But reviewing the content of the handover, it's accessible for all interdisciplinary, because our track care is designed to for other interdisciplinary to see the medical record related to this patient, related to their patient. So it's accessible to all. But when it comes to the actual part of exchanging information, it's between RN to RN involving patients.
Yes. Okay. Thank you so much, Lina. Excellent. Thank you for your speech. And now I think you can lean back and enjoy the rest of the day.
Thank you so much. It was my pleasure, really. Thank you. If there's any question from the audience, I think our email will be shared with them, or you can share with me any question later, and I will be really happy to answer them. Thank you.
Super. Thank you so much, Lina. So thank you all. And we would now like to move on to our next keynote speaker. It is Dr. Essam Ali from the UAE. And you will be talking to us about the emergency plan implementation. And a few words about you. Dr. Essam Ali is the Director of Quality and Accreditation in a private hospital in Abu Dhabi in the UAE. Please, Dr. Essam Ali, the stage is yours, and we are very excited to hear what you actually have to tell us today. Thank you so much.
Thank you very much, Susanna, and welcome to everyone in the conference, and thanks for giving me this chance and opportunity to speak in this respected conference. Let's start direct. Let me share. Okay. Okay. Let me start. I speak today about the emergency plan implementation for a hospital. Why we speak about these topics? Actually, the current situation for COVID, it take our attention to very, very important point. All of us in our hospital, we have already emergency plan. And we put this emergency plan and we put different figures in the emergency plan. In the emergency situation, we identify in the plan that there is internal disaster, like fire, like explosion, like hazardous material, like spill, or released any stuff dangerous. And there is external emergency, like minor external disaster, major external disaster. Minor external disaster like incident involving like small incident or accident for car. Major external like incident involving large number of victims. Disaster threats affecting the hospital or the community around the hospital, or disaster in other community nearby city or all over the city. Disaster due to war, which is affect all the nation or all the country. We first make emergency code. The first code for internal emergency code, and I will not speak in this in detail. There is red for fire, there is blue, code blue for cardiac arrest, there is code brown for hazardous. There is what if any violent person, code yellow for baby abduction, code black if there is any bomb, code green if there is internal disaster. All this inside the hospital, but outside the hospital we have only code orange. We will announce code orange, but does the staff know which level of emergency we have in code orange? Does it minor or major or it's a disaster threat affecting all the hospital or around the community, or the disaster in other city, and we have to, or we are involved, all this disaster coming now and affecting all the world. So first point, when we implement and for continuous improvement as a quality, we find that we need to classify even code orange. We have to classify it. We have to train the staff to tell them that this code orange, it's for minor, for major, for so. First, to our preparedness in the hospital to be ready. Does it's only just minor 3-4 victim, or it's major or whatever? We have to have a level for code orange. This is the first point. Second point, if it affects all the country, actually in all over the nation, emergency code, there is emergency code, and there is level green for peace, and there is everything safe. There is yellow, there is orange, there is red, but all this, it's only for threatening, or if there is war, or if there is terrorist attack of anything affecting direct the country. But if there is any emergency code for epidemic disease, no. In all the country, all over the world, there is no, and they cannot. Yani from WHO, when it start COVID-19, I was follow daily all the news. There is no code. Just they won't say that is it epidemic or not epidemic. Okay, if it's epidemic, it's in which level? Now, all over 1 year, we see that it's coming, sometimes coming very high, sometimes coming low or coming less, and after coming high again. We have to announce code from WHO that we are now in this code color. To can know in each code or in each level of emergency, we have to have some instruction for our staff, some instruction for our facility, for our hospital, some preparedness internally and also externally. Now the situation or the current situation that there is emergency committee and we're receiving the instruction from the emergency committee, and we have to start implement and we have to follow because this is the right till now. This is the situation and we cannot change, but the aim is to learn. It's continuous improvement. It's continuous learning. We know now and we saw what happened. So we have, for the future, we have to be more preparedness, especially that there is some countries and some community, they was not ready until now. Also, there is some countries, they cannot deal by proper way with COVID. For this, even now, the numbers also increase, even all the precaution, even also we start the vaccine, but still the number still increase. Okay, let's go to the plan. Who prepares the plan? Who is responsible to prepare this plan? The quality team, the infection control team, the HSE team, nursing team, and physician. Quality should, because they are responsible for implementation of this plan and monitoring and follow-up. Infection control, we will speak about their role, and also for HSE and nursing and physician. This is the main cornerstone, the two front desk for the facing this situation. The background for the situation. The healthcare workers are at the high risk of COVID because, as I say, the nursing and the physician, they are the first line which receives a COVID patient. So when we put the plan, we have to thinking very deeply how to protect this front line. The measure for to prevent transmission in healthcare facility is protect patient and healthcare workers. This is a first priority. Safeguard risk group. If any groups of patient like long-term patient or some group of nurses or in ER or in OT, whatever, or in IP. So we have to safeguard or to reduce the risk for the groups. Slow the demand of for specialist healthcare such as intensive care unit, ICU, or emergency, or whatever. Minimize the export of cases to other healthcare facilities and the wider community. In most instances, coronavirus are believed to be transmitted from respiratory tract infection, from person to person. There is by droplets, or either being, even now it's by touching or whatever. There is a lot of theory still now, and there's still the study, and every day we discover a new way for the infection, even by touching services for COVID. First, the rule for occupational health and safety. Additional measures that need to be taken when we have cases registered at the healthcare premises, way additional risk to the staff. The rule for the staff for occupational health. First, they have to measure the risk in each area, and they have to report to the quality what is the risk in each area. First. Second, they are responsible to guide the staff in each area, how to protect themselves, what to do, how to deal with this situation. If this happens, what we will do. So occupational health and safety, they have big role for this situation. They have to measure always the risk and continuous. It's in our hospital, we say that it's daily. We have to measure. Before, in the normal situation, maybe we make it monthly and we make risk report, risk assessment reports. But now we have to see daily. Every day there is something new. Every day we have to face some emergency situation. The occupational health and safety also measures should be measured and occupied with occupational safety and health services workers, taking into account all type of risk. All type of risk. We cannot neglect any type of risk. The safety and health community should be consulted. One in the place and the risk to healthcare workers and others. Other staff that belong to medically vulnerable groups, and potential mitigation measures need to be addressed in collaboration with the occupational health services or health and safety committee. This is the rule for occupation. As we say, it's day-to-day work. It's very important, and they are the first guard for reducing the risk in this situation. Second guard, we say infection prevention and control of infection measures, or the infection control team. Due to the likelihood of virus transmission by persons with few or no symptoms, healthcare facilities should ensure that physical distancing measures are implemented by staff, visitors, and patients, particularly in setting with widespread community transmission. Actually, the main mission for the infection control is the implementation of all the instruction, all the infection control instruction for all the patients, for all the staff, for all the visitors, to be sure that all the hand sanitizer is available, to keep the distance. They have to work all over the hours in all over the hospital, just to monitor and to control and manage all the implementation of all instructions for the infection control. The use of medical masks by healthcare workers for personal protection and source control should be strongly considered in a clinical area during all routine activities, as a measure for reducing transmission with a healthcare setting in area with community transmission. Actually, before the mask, it's very important, and we're giving instruction, don't deal with the patient without mask. So you wear the mask inside your clinic when you deal with a patient. Now you have to wear the mask everywhere and all the time. In the clinic, outside in the clinic, when you go around in the hospital, because there is visitors, there is another staff. So it's different now in this situation that medical mask, it's very important, it's very critical. You have to wear your mask all the time, wherever you move in the hospital. Standard precaution and in particular meticulous hand and respiratory hygiene should be emphasized. Before we will say and speak with infection control about hand hygiene, and we say we must and was follow, we measure the percentage, it's sometimes 70, sometimes 80% from the people which hand sanitize or wash their hand. Now it must be 100%. So must be, it's very restricted for everybody, for everyone to make hand sanitize and to wash his hand regularly. Third line for the triage. Actually the triage, now we will come for the front lines for the nurses. So starting from triage. Emergency service and the primary care staff, including physician, nursing, and administrative staff having contact with patients should be made aware of the current COVID-19 epidemiological situation in their country and globally, including known risk factors for infection. We have to follow up always what is the new from WHO, from other countries, from all the researches. There is new generation now in UK, there is new generation in South Africa, there is new generation in Brazil, and another fourth and fifth generation from the virus. So we have to know and we have to update our staff, especially the physician and the nurses. Clinical symptoms and signs of COVID-19. Every day we discover that there is some symptoms we didn't know before, and there is some patient have this symptom, specifically for the new generation for COVID. There is how we know that this one it's from previous generation or this generation or whatever. So we have also to update the researches for the symptoms from the new generation for the virus. Recommended IBC measures for infection control, procedures for reporting and transferring people under investigation and probably or confirmed cases. All the patients which confirmed COVID, we have to know the procedure and very restricted. We have to follow the procedure for transferring this patient from our hospital or from department to department to not be factors for spreading the infection. Liaise with the hospital employers to assess the on-site availability of appropriate PPE, personal protection equipment for all personnel at the point of care. Actually, this point in the beginning, it was a very big problem because suddenly we have to have for everyone, staff, medical or non-medical, we have to have, for example, mask or medical mask. We have our stock, and not only we, all the hospitals, they have their stock. But then suddenly we find that this stock, it's not enough. And when we start to purchase, it's not available because everybody buy mask, medical or non-medical, all the hospital. So we face some difficulty in the beginning. So this one of the first point, which I want to take attention for this one, when we have learned from our previous plan, and when we implement, we find some points like this point. So we have to consider when we put the plan to have enough and available PPE for all the staff, which is be enough for the medical and non-medical staff on our hospital. The great separate area in the emergency department for the assessment and management of patients with respiratory symptoms in order to spare PPE. When we receive the patient in triage and we see that there is symptoms for respiratory system, it's not necessary that this patient is positive COVID. So we not also confirm that he's negative. So we have to have area to separate, to isolate this patient and to perform a point of care assessment for assess likelihood of COVID infection, including the clinical presentation of the patient and review of clinical and epidemiological information, and the assessment should be based on the latest case definitions. We have to separate this patient. We have to tell them, to inform them that we have separate you for this reason 1, 2, 3, and this is what we will do, and we will make the PCR test to confirm if you're positive or negative. So you have to cooperate with us. So the patient must know what's going on. We must create a separate area in the emergency department or the hospital for swabbing, to have the swab for the patient for COVID-19, including the, to create a separate area in the emergency department in the hospital for swabbing for the patient, to have the swab and to transfer these samples to the lab to can receive the test as fast as we can, to can inform the patient. And also we have to map and develop policies for prioritizing stock of PPE. As we say, we have to make it available everywhere for all the staff, for administrative and for medical and non-medical. Also, we have to have for oxygen, including nasal cannulas and non-invasive ventilation devices. It must be also available in emergency area and in this area for isolation. If possible, provide for triage by telephone or telemedicine and online services to reduce the number of people with symptoms of COVID-19. Not everyone has symptoms for respiratory tract infection symptoms must come to the hospital. He can just tell by telephone that I have these symptoms, and you can tell him regarding to the severity. He can come or he can take this, because now, or as we see, there was very big problem to occupy all the patient which is coming. Everybody was panic. Everybody just has any symptoms for the COVID, just direct running to the hospital. So now we start as a private hospital and also the government, please, if you have any symptoms, call this number and we start to communicate and to see, is it severe and is it more suspected to be COVID or no? So to can come or no, I think this one just to reduce the number of patients and to can occupy all the patients which coming to the hospital. The personal protective equipment for assessment and collection of diagnostic respiratory sample, the recommended PPE for the clinical assessment of possible COVID-19 cases can be adapted as follows. Healthcare workers performing the first assessment without direct contact, the patient should wear a medical mask if available and keep a distance of at least 1.5 meters. This if you investigate or ask the patient, but if you take swab, you have to come very close to the patient. So the patient must wear, in this case, he must wear his mask, just only bring down the mask under the nose to can take the sample. Otherwise, I have to have shield in my face, I have to have mask, I have to have gloves, I wear my gown when I start to coming near to investigate any suspected patient. If possible, a physical barrier such as a glass or plastic panel can be used to avoid direct contact and keep a distance in the case of PPE is necessary. Collecting diagnostic respiratory samples like a nasopharyngeal swab can provoke coughing under or sneezing and therefore lead to production of aerosols. Healthcare workers collecting a diagnostic respiratory sample in enclosed spaces should wear a respiratory goggle eye protection, gloves and gown, as we say. A medical mask can be used in place of respiratory in the event of a shortage of respiratory and for drive-through or outdoor testing facilities. Actually, what we're doing now, or in Abu Dhabi and in UAE, all the staff which is collecting the sample, they wearing their PPE very proper way. They protected, they well trained, and also they have the face shield and the mask and the gloves, and they take the sample by proper way. In order to optimize the use of PPE, staff should be assigned to carry out procedures in a designated area. For example, a dedicated area for collecting diagnostic respiratory sample can be set up. In each hospital, and now there is a lot of points also to collecting the samples. So these samples, it's collecting in a specific place and well prepared, well equipped by PPE for all the staff. Management of possible cases. If any possible case, what we will do? The possible COVID cases should be isolated, as we say, or at least separated from other patients as far as possible. They should wear a medical mask if available, or at least cover their mouth with a tissue when coughing, and practice appropriate hand hygiene. Appropriate response routines should be set. Example, reporting to designated 24/7 response services, such as the local public health authorities, arrangement of diagnostic testing, and if appropriate, following initial assessment, arrangement for safe transfer to a designated acute care unit for further diagnostic evaluation. In this point, the second point, when we implement to find that facing problem as a staff in the hospital, that when we start isolate in the beginning, okay, when coming cases for COVID, we start about isolation, but how many proper isolation room in the hospital? Maximum we have 3 to 5 in the big hospital for isolation, but we find that we need more. It's not 5 patients only, no, it's 10, 20 for the hospital. So how we can isolate all this number? And in the same time, there is no time to prepare negative pressure rooms or isolated room by proper way. In this case, we start to use the normal regular room, and we start to close and we start to make the restricted precautions for the patient which we keep in this room. If it confirms that it's COVID, we start keep them in normal room till we transfer to another hospital or government by our ambulance or the government ambulance or whatever. And after, we start fumigate the room and again sterilize and put the disinfectant and clean by proper way the room with the patient there. So also this one, we have to put in mind when we prepare our disaster plan. This is the second point. There is a PPE enough for the amount for all the stuff, and second for the isolation. How we can isolate? It's very costly, and I not say for each hospital to make 20 or 30 isolation. It's useless in the normal situation. But in epidemiology, we have to be ready to can use the normal or regular room as isolated. So we have to know how to use the regular room to isolate the confirmed patient for COVID, and what we can do before and after to keep the patient in these rooms. Also for our ambulance, when we transfer the patient from our facility to another facility, also we have to prepare the ambulance. The staff, the paramedic in the ambulance must be educated and know how to deal with this patient. They must wear the complete PPE, and after they transfer to the patient, what they have to do with the ambulance, fumigation and sterilization and disinfectant, and they have to clean the ambulance. All this, it's our role as a management for quality or for infection control. We have to manage, we have to follow up for each and every case transferred from our hospital to other hospital. The administrative measures in this situation, appropriate training, as we say, for the healthcare workers and other staff, and regular update to ensure that emerging evidence and changing guidance are taken into account. Sure, here's the administration, because this is which the connected between our staff, the frontline staff, which facing the patient or taking over care for the patient, and the other administrative in the back line. There is a lot of information we have, as I said in the beginning. We have to tell them how many cases now nationwide, how many cases locally in our area, how many cases in our hospital daily. We have to know how many infected, how many PCR we make, how many patient, normal patient we receive. So all these patients we have to have. Also, we have to provide appropriate information and training to the worker recruiting for surge capacity, set up a hospital COVID preparedness and response committee, which is very important. We have to have committee to follow up all the situation in and outside the hospital. Be aware of the minimum requirement for designated units managing confirmed COVID-19 patient. All the staff adequate trained in the safe diagnostic evaluation and management of COVID-19, available of appropriate PPE and hand hygiene products, adequate laboratory support, appropriate cleaning, and we'll speak about cleaning now, and appropriate waste management procedures. Plan for surge capacity, estimate the needs in terms of patient beds, respiratory support, PPE, staff, and diagnosis. Also still for the role for administrative to ensure preparedness for a surge in critically ill patient, identify rooms for this patient. In addition, identify non-urgent outpatient visits for rescheduling or cancellation and elective inpatient diagnostic and surgical procedures. In this situation or in this point, we say we have to inform how many cases we have infected, how many cases normal, and if we can to manage and to control the number of normal surgery or elective surgery, if we can delete it or delay it or postpone it to another time. So we have to have from the administrative all the situation in the hospital. Thus we can now receive the normal patient, thus we can now make the elective surgery, thus we have now enough rooms to receive the patient or no. This is what I say, the data here, it's very, very critical and very, very important, and we have to share it daily with our staff. And as we say in the previous page, that we have to have committee to follow all this and to connect all this area together. Identify and designate additional separate units that can be used for diagnostic, evaluated, and treatment of COVID-19 patients. Define a strategy for testing, management, and follow-up of healthcare workers with respiratory symptoms in alignment to national, regional authorities. We follow now with the patient, but there is an important point. Our front line, our doctors, our physician, or our staff, we have to follow up with them. We have to have regular tests for COVID-19. If any one of our staff or in the nurses or the physician has any symptoms, we have immediate to separate him from deal with the patient. We have to make tests. We have to confirm, does he infected or not infected? Does he negative or positive? We have to follow up also, which is very important point for our staff. All staff with symptoms compatible with COVID-19 should be dispensed from their duties and isolated while symptomatic, and they should be prioritized in the national testing policy in order to be able to return to work as soon as possible once they are SARS or COVID free in accordance with guidance for discharge and ending isolation. For example, now in Emirates, there is by regulation or by law, every 2 weeks, all the staff in the hospital, medical, non-medical, they have to make PCR test and to see and to follow up. And immediate, if any staff in between have any symptoms, immediate he will isolated. Ensure that visits to COVID-19 patients are limited to the absolute minimum, and that visitors are aware of the need for hand and respiratory hygiene, including setup or cough etiquette. If possible, maintain a register of visitors for the purpose of contact tracing. We have to have, but everywhere in the hospital, some information, some instruction for the patient or for the visitors, how to deal, how to hand sanitize, how to control if he's sneezing or whatever, if he has any symptoms, what he has to do. And also we have to have our staff, as we say, all over the hospital to guide the visitors and the patient for the regulation and for the instruction to protect them and also to protect our staff, and also to educate and guide them how to do this instruction for hand sanitizing or controlling the infection from COVID. All the staff with symptoms compatible with COVID-19 should be dispensed from their duties, and ensure that visitors also and patient have the minimum education. Also, for the visitors, if possible, to reduce the visitors in this situation, only the very relative, or if the patient need somebody to be with him, it's okay. But if possible, we have to prevent or to stop the visitors from the hospital, just to reduce the risk for spreading of infection. For the patient management, with a small number of cases, patients should preferably be admitted to an isolation room. And this is what we say. If limited number, okay, we can control and we can put in our isolation room. But if more patient, this is what we say, we have to start use the regular room. We have to control and manage this regular room as an isolation room by the infection control team and our nursing staff. We have to start manage the patient if coming over the number of our isolation room. Health monitors and management of exposed staff. If the staff confirm it, we have to, as we said, we have to isolate him. We have to start treat him. We have to put him in inpatient or under observation to treat him and to take the time for isolation till he coming negative and complete treatment. In the beginning we say 14 days, but I think now it's 10 days till he coming negative and make another test, confirm that he's negative, to come back to work. Release from isolation, we cannot release any patient from isolation before confirm that he is negative. Whether his staff or patient, we have to confirm after making the test that he is negative. WHO recommended that patients are released from isolation 10 days after symptoms, once or plus at least 3 additional days without symptoms. So now we say that it's 10 days for isolation. After this, he will make the test. If he's positive, he will continue. If he's negative, finish 10 days, and after he will release from the isolation. Instruction for health care professional and healthcare facility staff. This advice is for, with what I make in my paper, just I read some advices for the professionals and for the frontline staff. This advice is for all staff working in healthcare facilities. Some hospital will be designated exclusively for the management of COVID-19 patient. However, the probability of exposure to the virus should be considered high at all healthcare facilities. The following precautionary measures are recommended. Staff who have contact with a patient should wear scrubs for the duration of the work. Clean scrubs should be provided daily. Staff should also be provided with and wear special shoes at work that can be left at the hospital if possible. At the end of that shift and after appropriate remove of PPE, staff should wash their hands meticulously. If possible, shower facility. If not possible, direct when he go home, he must take shower. Regular cleaning and disinfectant of electronic equipment, all your devices, your computer, your cell phone, you have to have also sanitized, because a lot of us forget that he catching the telephone or touching the computer or whatever, and after he finish and remove his PPE and just wash his hand or hand sanitize, he going again and he not notes that he was touching the telephone while he work or his computer. So he going and he touching the telephone. So we must take care for this important point, that as we sanitize our hand, we have also to have disinfectant for our devices, for the computer and for our cell phone. The following measure may be considered for staff working in the area of environmental cleaning and waste management. This for the cleaners. Cleaners should be appropriately trained in cleaning procedures and waste disposal and receive appropriate instructions. Actually, because these cleaners, it's low educated, so sometimes they're not aware completely by what they have to do. Sometimes he want, it's heavy work for him, he won't finish fast. So somebody must supervise him, must monitoring him, must see what he did, if he forget anything, if he clean by proper way or no. So we have to follow up always with the cleaners to see that they doing by proper way or no. Staff engaged in environmental cleaning and waste management should wear a medical mask, eye protection, goggles, gloves and gown. We have to teach these cleaners that always they have to wear goggles if possible, always they must have gloves, always they must have mask while they cleaning. If they have special gown, or better to be disposable gown while they work and clean. The regular cleaning followed by disinfection is recommended using hospital disinfectants active against viruses. We have to choose all the disinfectant what we use with 0.05% sodium hydrochlorate, dilution 1 to 100. So we have to look behind them which disinfectant they use, and we have to see also which concentration they use, and also for any ethanol or spirits, it must be not less than 70%. Staff engaged in waste management should be provided with and wear appropriate PPE. Also, when they transfer all the medical waste or all the regular waste, they have to transfer it by proper way to the proper place, and they have to wear proper PPE. For the laboratory test, also the laboratories, they have a very big role. All the specimen collected for laboratory investigation should be regarded as potentially infectious, and healthcare workers who collect or transport clinical specimens should adhere rigorously to standard precautions in order to minimize the possibility of exposure to pathogen. All the people, all the staff which transfer all the specimen to the lab, they must be aware for all the precautions and how they transfer it to the lab by a proper way. Also, we have very important point for long-term care facilities. Long-term patient, they stay long time, and you have to take care, and you cannot transfer, and you cannot limit their staying in the hospital. So we have to have a devastating effect, since the residents are already vulnerable due to their age and possible underlying health problems, meaning that there is a high likelihood of unfavorable outcomes from them. They have the high risk or under high risk for infection. So we have to control this patient very carefully, and we have to give more attention for this patient, and to protect them. We have to educate them how to protect themselves. We have to control by infection control team also around these rooms and by the nursing which care for the patient for long-term facility. Post-disaster assessment. We have to assess as a quality, as we say, when we put the plan in the beginning, it was normal plan. And when we start implementation, we find that there is a lot of gap. Every day and always we make assessment and we see where is the gap and we try to close it. In this situation, in this emergency situation, we cannot wait for the normal time or the cycle for BDCA. We have immediate action to can make the assessment. And as I said in the beginning, we have to make assessment daily to see if anything necessary to can make. And we have to have update for our plan. We have to update for our procedures. We have to follow up. It's not only in internal assessment for our plan or for our implementation. As we say, we have to follow all the recent and all the data and news from the outside, from WHO, from our government authority, for what's going on for the new generation, for the virus, for the vaccine, what's going on, how numbers infected around, and what we need to have, especially for the new generation for the virus. Does we need anything extra? Does we have to have any other procedures or no? So all this measurement, all this assessment, it must be very, very, as a very, very important, immediate, and very frequently, daily or weekly maximum. Final conclusion for this one, I hope to not that I not take time more. Keeping as a low as a possible of number of workers exposed or likely to be exposed. We have to minimize the staff which facing or in the front line which facing direct the infected patient. Design of worker process and engineering control measures as so to avoid or minimize the release of biological agent into the place of work. Organizational measures to limit exposure, such as a dedicated area for the reception of infected patient. Technical measures such as appropriate ventilation, physical barriers, and other use of appropriate work branches of for laboratory work. This point, it's very important that we have to have also enough oxygen and ventilation equipment for the patient. Training of workers, including in the use of PPE, disinfection procedures and waste disposal, the provision of appropriate PPE, ensure means of safe collection, storage, and disposal of waste by workers, including the use of secure and identifiable containers after suitable treatment. Ensure workers are provided with appropriate and adequate washing and toilet facilities, which may be include eye washes and or skin antiseptics. We have to put for hand washing everywhere and hand sanitizing everywhere, and we have to educate all the staff. Appropriate measures shall be taken by the employer to ensure that workers and their preparedness representative receive sufficient and appropriate training concerning for potential risk to health, for precautions to be taken to prevent exposure, hygiene requirement, wearing and use of PPE, steps to be taken by workers in the case of incident and to prevent incident. The training shall be given at the beginning of work involving contact with biological agent, adapted, take account of new changed risk, and repeated periodically if necessary. And this is a reference for anyone want have reference, we can share it. Hello. Yes. Okay. Thank you.
Thank you very much, Dr. Ali. It was very clear, and thank you for the insight in your daily work. Just one question: what do you think was the most challenging part of your plan that you have implemented?
In the beginning, the most challenge, it was educated for the staff, for the precaution which we have to do and they have to follow. Most of the staff, they was not aware completely by the actual situation and how serious and how dangerous this in the beginning. The second challenge, as I told you, the space available for the patient. We face a very big problem. When we have more patients, we have only limited number 3, only isolation room. As a normal for hospital, it was okay for us. But in this situation, it was a very big challenge. And as I said, the presentation, we start with a regular room as isolation. And in these cases, we start make very restricted procedures for the staff and under completely supervision from the infection control team, how we can use this regular room as an isolation room and how we can manage the patient inside this room. And also in the beginning, the PPE equipment, it was very big problem for us, not only for us, for everywhere. It was not enough. So we will start manage in this such situation.
Thank you so much. I think we can all relate to your problems, especially getting the PPA. I think that's a problem that we all have. I think everybody that's joining can
Yes.
sing a song about that. Well, thank you so much for your interesting speech. And also to please enjoy the day and stay with us, please, Dr. Ollie.
Sure,
okay?
I'm with you all the day and tomorrow and after tomorrow. Any question, anytime, I'm ready. Thank you very much.
Wonderful. Thank you. So now our next speaker is Dr. Maryland Abdel-Jawad. I hope I pronounced the name properly, from Jordan. And you will talk us through towards zero harm from medications through patient engagement. I think a very interesting topic in our time. And please, I will pass on the screen to you, Dr. Maryland Abdel-Jawad. Please.
Okay, thank you, Susan, for the introduction. And it's my pleasure to be part of this interesting conference. Can you hear me?
Yes, absolutely.
Okay, great. So before I start, I will introduce our hospital that I'm working now currently, which is the Abdali Hospital, which is a member of Clemenceau Network in Jordan, Amman, which is a 200-bed multi-specialty hospital, and with the mission to provide the best practice patient-centered care. Also, I used to work in King Faisal for the past 20 years in Saudi Arabia, which is one of 3 campuses of King Faisal Specialist Hospital with 380 beds. The reason why I'm mentioning King Faisal because I will share some of the initiatives that we did there. And my experience now in Abu Dhabi just 3 months. So we hope we do what haven't been done in Saudi Arabia will be also implementing in Jordan. This is the learning objective. We'll provide an overview of patient harm impact. We'll define the health literacy. We'll discuss how can patient play an active role in preventing medication errors and improve patient safety towards zero harm. We'll outline strategies to improve patient understanding, and we'll share with you at the end the initiatives for patient engagement. Let's start with this study, a new study from the US, which estimates that medical error was the cause of 251,454 deaths in 2013. This is the latest update study, and it's the 3rd leading cause after the cancer, and it's making most common cause of death. And out of this, there's another interesting study from the Canadian hospitals about patient harm. And out of the patient harm, they found out in 18 hospital stays, they have harmful event from the hospital stay, 37% out of them related to medications. If when I define the harm from the Agency of Healthcare Research Quality, it can be physical or psychological or injury, inconvenience, monetary loss, and or social impact suffered by a person. The harm, it might impact on patient, family, communities, and care provider. It might be direct or indirect. The direct, it might be mental harm, physical harm, or emotional harm. And the indirect impact, burden on families and community, and loss of staff time. And the impact on hospital, healthcare system, and economics, it might be direct also as additional cost to hospital and healthcare system, unnecessary care and medication, and ongoing cost of care and medication resulting from harm, the indirect longer length of stay and reduced access to care, cost to economy with lost productivity and unable to invest resources in other areas of community. So the increased cost of medication error, interesting that is not only related to increased treatment or diagnostic required, but it is also costly in terms of loss of trust in the system by patients and diminished satisfaction by both patients and healthcare professionals. The medications, it's really, we know that medications are really complex, and medication errors are the most potentially dangerous to our patients. And that's why it's very important to work together to prevent such incidents. How this can happen, the lack of patients' engagement lead to diminished patient satisfaction and quality of outcomes. And we have a lot of communication breakdowns that affect patient safety. And if you look on most of the central events, number one of leading cause of any incidents and preventable harms are lack of communications. Relationship continuity significantly really affects patient safety. And if we really walk toward patient-centered care, we need to have more patient engagement. And this is such for patients, continuity of relationship with physician and patients and practice staff represent not only a service and experience, but also an important patient safety concern. I always like to present this Swiss cheese module in medication management because I'm a pharmacist. And we know that there are many safety layers to prevent harm reaching to the patient, starting from the prescriber, coming to the pharmacy who verify the order, to the nurse who administers medication, then the last safety layer was the patient. The reason why I'm showing this because patients really play an active role, an important safety layer to prevent harm. But how this can happen when you teach them properly, when they are understanding their treatment and dosage, when they are engaged and empowered to speak up. So that's why it's very important to see where are our patients in this medication management. A patient needs to understand the treatment, and we should have an effective communication between the professionals where clarification of the prescription is necessary. As patients, as mentioned, can be really another safety net if educated effectively on their medication and encouraged to ask questions and seek satisfactory answers. If we look here about the sources of the confusion and why the medication errors happen, why patients are non-compliant, why patients don't know about their medication. We have a big problem in our medications. The medication, we said that it's complex. We have multiple names for single drugs, the generics. We have failing to instruct patients about medication taken at home that were not written for discharge, especially at the transition of care. And I will highlight about the importance of proper medication reconciliation. It switches to formulary versions when admitted. Not each hospital have the same unified formulary. So the differences in the brands and generic really plays a vital role in these incidents. Changing the dosage, strength, or frequency without sufficient understanding by the patient so as to why. If you change any dose or change any frequencies, you need to educate the patient. How many times we end up when we are interviewing one of the patients, he comes with a big bag with a lot of medications and he doesn't know what are all these were prescribed for. 40 to 80 medical information were given to the patient when we are forgotten immediately and half retained is incorrect. Do you expect that patient when you give them a lot of information, especially when he is discharged, that he will absorb all the information that he will give? Unfortunately, most practices in the hospital, they think, okay, discharge just 15 minutes before the discharge. But no, the discharging of patients, especially with the medications, you need to start the education at least a day before to make sure that patient understood what they are going to take at home. And physicians thought that 89% of patients understood medication side effects. However, only 57% of patients have really understood what are their medication and what's the expectation, how they work, and what's the side effects. Coming to the term called health literacy, and the definition of health literacy, it is the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. And some medication error occurs because patient misuse of the drug, because of poor understanding of the direction for proper product use. I have a lot of examples when we started implementing the medication reconciliation and doing medication history with the patient. You will be shocked and surprised that patient, whatever, even if it's written in the label, for example, take the medication 3 times a day. We had one of the cases that patient was taking 3 tablets once a day. When I asked her, why you're taking this? She said, I should take it 3 times a day. So I took the 3 as once. This is not a joke, but this is really what's happening. Instructions, when we give it to the patient, we should give it in a culturally sensitive format. We need to understand the level of how we deliver the language, what information I'm giving, how I'm giving it, that the patient understood the instructions. Only 12% of adults really have proficient health literacy. And lower literacy have more, will result in more admissions, ER visits, cause higher risk of poor health. I want to share this video from Dr. House. This is really funny and will continue. I wish I can see your reaction, because believe it or not, when I used this video 10 years ago, when it was released, after a week, one of the physicians came to me and said, Merlin, thank you for sharing this. I don't know why. He told me, you really alerted me to something. And I had a patient who came to my clinic today, and she was complaining the same as what you showed me in the video, that the inhaler is not working. And I told her, can you show me how you're using it? And the big shock and the surprise, she wasn't using it as a perfume, but she was using it without removing the cap. Imagine this simple step of removing a cap. You need really to go to that level to explain to the patient. Patients might need to shake well before use or before drinking. You might say that I need to shake myself. Another example, insulin pens. One time we had a patient who came to the pharmacy shouting, okay, what the pen you are giving to me? It's not working. And then we asked the patient, can you tell me how you're using the pen? And believe it or not, he was using it without using a no fine needle. And that's why it ended up having this big pulp in the top of the pen. So this is the level that you need really to, the small, simple, important points might be missed, and this might lead to the misuse of the medication. What patients really are also saying, we don't have that communication. The physician didn't tell me to take my blood thinner when I got home, when I was discharged. I have 2 pairs of heart, but I don't know why. So I thought that I need to just, one will be as good. So failure to adequately educate patients, failure to provide patients with understandable written instructions, and not listening to patients when therapy is questioned or concerns are expressed are really leading causes to all these incidents that might happen with the patients. So which categories or group of patients that are really at risk for medication errors? Patients on multiple medications, patients with another conditions like renal impairment or pregnancy, patients who cannot communicate well, patients who have more than 1 doctor, especially that if visiting this, and we have seen this especially in the Gulf, patients like to go shopping from doctor to doctor or ask another consultation. And here comes the risk in having a lot of duplications, interactions, and wrong instructions. Patients also who have not taken an active role in their own medication use, who really deny that I should take or what should I take, and not engaged in their medication therapy management. And of course, the children and babies, because of the dose calculations required. We need really to be careful when we explain to the families, the parents, about the doses, and make sure about mill and milligram, because here comes the confusion for the patients. We learned a lot from our patients and what they need. Patients need to tell them what's wrong in a brief way, and what do I need to do and why, and emphasize the benefits for them. For example, when you are explain or counseling about medication, make it brief and in simple way and direct to the point. What is it for? How to take it in clear way, and what is the benefit, why I should take it, and what I'm expecting, like for any side effects, what shall I do if I have this? Shall I stop it? Shall I come back to shall I call you? Shall I come back? Is my blood pressure not controlled? Is my insulin level, is my still is not managed? All this information, and remember, what's clear to you is clear to you. It's not necessarily clear to the patient. How we can do this? Remember, you need to use a plain language. Avoid jargons. Try when you are speaking with your patient as if you are speaking to the level of 6th grade, not exceeding the 8th grade. Limit your information to 3 to 5 key points. Be specific, because patient will not remember all the information you will tell them about. And be specific, but not general. Demonstrate and draw pictures and use models, especially with the devices. Don't assume that, okay, he understood. You need to show them, let them do that, and I will come to the teach back method. Let them demonstrate how they are using it. Give them also, you need to repeat and summarize and the teach back and confirm understanding, and try to provide them with the brochures, a drawing, or a short video that can they refer, so that if they forget, at least they have a reference. And be positive and hopeful and empowering. Inform patients of drug names, the purpose, the dose, and side effects, and management methods. Suggest reading for the patient. Make sure that he knows how to read the label and understand what's written in the label. Provide patient with understandable written instructions, and inform patient about right to ask questions and expect answers. You need to invite patient to ask. Don't let him just be silent. Let him be engaged and listen what patient is saying. Listening is very important. I'm not saying here you need to listen to understand that the patient really understood what you have telling him for the follow-up, and focus on need to know, not need to do. So for the teach back method, you will start with explaining. You need to assess for the understanding. If not, and if the patient needs more clarification, clarify and go back to the assess till both of you come to the concrete understanding that yes, both of you have the shared understanding of the information. For engagement and encouragement for asking questions, don't say to the patient, do you understand? Do you have any question? Do you expect the patient will say you yes? He will be afraid to ask that. So it's very important to have the way how you communicate with your patient. Tell me what you have understood instead of do you understand? I want to make sure I explain your medicine clearly. Can you tell me how we will take care of your medicine? Do you know now? Can you show me how you are going to take it? Written instructions is very important, and it has to have with adequate information, with a demonstration or draw pictures, as patients prefer receiving key messages from their clinician with accompanying pamphlets. They will feel more comfortable if they have that brochure. Or now if you want to go towards a paperless, you might have it like a scan. He can scan from the smartphone and have it in their smartphones. Patients with low literacy really tend to ask fewer questions. So that's why we encourage patients to bring one of their family to be an advocate with them and to help them remember if they forgot, especially with elderly patients. The pictures, the visual aids really help a lot, especially with the low literacy and visual learners. Most of the adult learners, they like to be visual learners more than just talking. And most health drawings really might be too complicated. That's why when you are showing, you want to use any visual aids, try to make it as simple, easy to look, not very congested, and not too complex. And ask the patient to want to show. When the patient told me to ask you to show me, and I can do it, show him and let him do it by his hand as well. This is just an example how to use an inhaler, and starting from the simple steps of removing the cap. Remember the case that I shared with you, that incident, and then how to shake, how to take, how to inhale and exhale. This is really very important points. Technology really help in patient engagement. And this is one of the studies where it shows that 67% of patients, they say technology they had the potential to improve their health. They will prefer to go to the hospital, that they will have an access to their profiles, to their medication list, to their medical records, to their all information, lab results. And that's why it's very important for each hospital or any healthcare facility to utilize the technology to be a secure technology, accessible, feasible to our patients. And this is just an example from my previous hospital, King Faisal, where they have an app called SBAHC. And in SBAHC, patients can access their medications, their lab, their medical records, their procedures, their even x-rays at any time in just a click in the app in their smartphones. There are a lot of initiatives how we can engage patients. And the first one that we really utilize the Joint Commission, the Speak Up campaign. Speak Up, its goal is to program to help patients become more informed and involved in their healthcare. It encourages patients how they can be engaged. And one of their initiatives about help avoid mistakes with your medicine. And we had one of these initiatives about for medication safety. We had the brochures in simple Arabic demographics and how to encourage them, how to ask questions as the physician, as the pharmacist, as the nurse, what to do in case of allergy, if this medication belongs to them or not, how to check the labels, to read the labels. Another initiative from the Institute for Safe Medication Practice Canada, and this is the latest one, and where they have it in simple way about 5 questions you need to ask about your medications whenever you have a visit to the hospital or to the pharmacy. Patients, before leaving the hospital, they want to make sure that they know about the changes, if there are any medications being added, stopped, or changed, and why. They need to know about the continuity. What medication do I need to keep taking and why? Maybe the doctor has stopped his medication, so I make sure that he had updated list of his medication. The proper use, how to use it, how do I take medication and for how long? This is very important. Monitoring, what monitoring parameters I need to do, how will I know if my medication is working or not, and what side effects do I need to watch for and I need to report, and my follow-up, when I need any test or any book any next visit or refill for my medications. The Saudi Patient Safety Center in Saudi Arabia, it really worked a lot in improving patient engagement and education. As I was one of the consultants in Saudi Patient Safety Center, so this is one of their brochures that was shared about how to be engaged in their medication and healthcare, about their identification to make sure that they got the right medication with the right that belongs to them. So for patient safety, you need to invite information sharing, use clear communication, assist with medication adherence. This is very important. Adherence might be really give you and alert you that if patient really compliant or not, if you are using it correctly. When patient comes to you, encourage to bring them their medication with them to see how they are taking it correctly or not. Identify any financial barriers. Maybe patient he didn't take medication because he didn't buy it because he has a problem as a financial issue. Health literacy awareness, cultural competent care, identify any needs, hearing or visual aids, engage care managers, and support health wellness, and facilitate safe transition. Safe transition, why I'm mentioning here? Because more than 46% of the errors happening at the transition of care upon admission, transfer, discharge, or visit to the clinic. And that's why the Joint Commission, they updated their medication management cycle to include patient admission and patient discharge as part of highlighting the importance of medication reconciliation. What I mean by medication reconciliation is the process of identifying what the patient is taking, and by taking the medication history and use that history upon admission, transfer, and discharge, and update that list. And if there's any changes or addition or deletion, with the intention is to improve the safety and prevent any errors from omission, commission, or duplications. Yes, we started with admission, transfer, and discharge. However, now there's a lot of the highlights on the ambulatory care settings and the home health care as well. So one of the best practices, you need to have patients participate in medication reconciliation. They need to know the importance, why we are doing this process. We need to encourage the patient to keep an up-to-date list. And now there's a lot of technology applications that help patients to keep an updated list of their medications. During the discharge process, the medical staff, they should ensure that patients are educated about any changes in their medication regimen. Really, medication reconciliation will help patients recognize they are responsible of their own health care and what happens to them. Again, from the Saudi Patient Center, because they know the importance of this initiative in preventing harm. And we know that even from the Institute of Care Improvement, when they start the 100,000K saving campaign and the 5 million campaign of saving lives, they found that medication reconciliation really help in preventing harm and saving lives. So it's a shift in culture from current, which is clinical expert and clinical and passive patient-centered health data, to having with the future of having more engaged patients with the technology that we have, becoming more expert and active in patient-generated health data to get toward best care patient-provider partnership. So partnering with patients to improve quality, safety, and patient experience is becoming one of the core values of any hospital. So medication, in conclusion, medication can really greatly improve health when used wisely and correctly. Remember, medication can cure and medication can harm if not used properly. So medication error is common and is causing preventable human suffering and financial cost. So we need to remember using medication to help patients is not a risk-free activity. We need to know our responsibility and work hard to make medication use safe for our patients by engaging them more and preventing patients from being harmed by medication and involving them to the fullest extent. Let them speaking up, listen to their requests and needs, and by this we can prevent being harmed by medication. So patient and medication safety start with every patient. And by this, I end my presentation. And we almost don't have any questions.
Thank you very much, Dr. Abdulaziz. And I do have to apologize. I didn't really introduce you to all our participants today, but you are the senior pharmacist in Jordanian pharmacy, and you're a risk management specialist. I do apologize that I didn't give you the full CV at the beginning. To the our panels, do you have any questions? And what would you say the role of the internet? Because I can imagine that we have now a lot of patients that Google what they're taking their medication, and Google knows best. What do you have to say to that?
They need to really be very careful. Not everything in the Google is trusted. They need to have for a trusted references. So not everything in Google is correct. They always need to refer to their, to validate and verify their information from the experts. And their experts are the pharmacy, their healthcare provider, physicians, or any trusted references like the Lexicon or the Medix, so not only just Googling by Google. And this will open another floor for the online pharmacies, the shopping. This is really serious. They need to be careful from where they get their medications.
Absolutely. Well, thank you very much. There's no other questions, or you've been very clear, and I think you reminded us all for best practice in how we actually have to deal with our patients. Thank you so much.
Thank you. It's my pleasure, and and good luck for the other speakers.
Thank you. Thank you. Okay, so we have our next speaker, and I'm not going to do the same mistake again. So our next speaker is Dr. Tapravanath Bhattacharya from India. I do apologize for my poor pronunciation of your name, I'm afraid. And you're going to tell us something about the job satisfaction of nursing. Yes, please. So can I please hand over the stage to you, please? Hello? Just a moment. Okay, I just got, I'm afraid I just got a note by the organizer that Dr. Bhatjahara from India has not joined us yet. So we would like to ask, just hang on. Would Ms. Sharifat Mohammed Kamal be able to do her presentation just now?
Can you just give me just about 5 more minutes, please?
Okay.
If because I was thinking I'm just 20 minutes past. I should be 20 minutes past that, isn't it? Yeah, if you can just give me about 5 minutes, because I haven't, yeah, 5 more minutes.
I'm really sorry about that. I guess there have been some technical problems coming over from India.
Okay, just give me about 5 minutes. I'll see if I can join you.
Wonderful. Thank you so much. Wonderful. Thank you.
We have to map and develop a ventilation.
I could reach over to tell you something about the weather in Zurich at the moment. It has been snowing, so I thought I'll brighten up the room a bit with some lovely Easter flowers.
Oh, happy Easter, Susan. Forgot to tell you.
Thank you so much. Yeah, it has been snowing today. I have to say we were all expecting a nice and lovely springtime, and it was warm and wonderful. And now the snow has returned back and has Switzerland in its claws. So there you go. And I've had the wonderful privilege today to also speak to people in Sharm el Sheikh and all around the world, and they were telling me how wonderful warm it is. And yes, so I think I am a bit of a outlier, I might say. Yeah. I can see Mrs. Sharifat Mohammed Kamal is getting ready, getting into the speaker seat. How are you today?
I'm fine, thank you. Just
wonderful. Thank you so much just for jumping in. That is absolutely great.
Yes, because I was looking at starting just couple of minutes past 12, but
yes.
It's of rearrangement.
You see, it's amazing what can happen, isn't it? Yes. Okay, you just tell me when you're ready.
Yeah, I'll be with you just a few more minutes.
Okie doke. I think in the meantime, I will have the utmost pleasure to actually introducing you. Mr. Sharifat Mohammed Kamal is going to talk about the medicine optimization in primary care and healthcare services. I think that also is quite a nice bridge over from our last speech that we had. Mrs. Sharif Mohammed Kamal, I hope I do pronounce your name correctly. You have complemented your pharmacy degree from Ahmadullah Bello University in Zaria, Kaduna State, Nigeria, and came to the UK to finish her overseas qualifying examinations at the University of Sunderland, and equivalent to an MPH pharmacy. You're currently working as a postgraduate studies in public health and independent prescribing, and you're specializing in HIV and sexual health, in medicine optimizations, minor alignment services, and patient-centered care. I think a very interesting topic, and as I said, is actually kind of a nice transition to the speech that we just heard. Okay, Mrs. Sharifa, I would like to hand over the stage to you, and thank you once again for jumping in. That's marvelous. Thank you so much.
It's all right. Thank you very much. Hello, everyone. Good afternoon from here in London. And I don't know, we're different timings all over the world. And I hope we are all keeping safe with COVID-19. And if you already have your vaccine, I hope people are taking their vaccines. At the same time, after you have taken your vaccine, I hope you're still wearing your masks, you're keeping safe distances and keeping the hygiene. Thank you very much for inviting me to this interesting edition of your conference. Unfortunately, we cannot meet face-to-face this time around, but virtually, I think we're still meeting. Today, I'm going to talk about medicine optimization in primary care and healthcare system. I am a pharmacist. I deal with medicine all my life of over 20-something years. So today we're going to look into how we can work together as healthcare professional and optimize medicine intake by our patients. I'm going to use some slides, and I hope I'm allowed to share my slide. Can you see my slide?
Yeah, absolutely great. Thank you.
Okay, good. So we're going to just go into medicine optimization, primary care and healthcare system. And this is going to, the aim of this talk is just to be able to see how we can work together, pharmacists, nurses and doctors, and support our patient with the use of their medicine. And this will ensure safe patient safety at the same time, ensuring we have value of the medicine that we take and we give to our patients. So what do you know? Do you know that 1/4 of the population has a long-term condition and 1/4 of the over 60 have 2 or more long-term conditions? And since we have aging population, the use of multiple medications known as polypharmacy is increasing all over the world. Is that people are taking medication from over the counter, or they're taking multiple medication for multiple clinical conditions. Between 30 to 50% of medicine prescribed for long-term conditions are not taken as intended. People take medication, keep them at home, and they don't take them as patients, as doctors, as nurses, as prescribed. So all of these things implies that something is wrong somewhere, which is why the word medicine optimization has been used in England for the last couple of 2013, and we've been working so hard in different practices, hospital and GP practice, even within the community pharmacy, to work around medicine use review and see how we can get the best out of our medicine for our patients. So I'm going to do a lot of references in my slides, in my talks from the NHS England, the Royal Pharmaceutical Society, and the NICE guidelines on medicine optimization. So medicine optimization. Medicine optimization looks at the value with which we deliver, making sure that the medication that our patients are having are clinically effective and as well as cost effective. So now we're looking at the patient. At the same time, we're looking at the management side of the health system. So it's about ensuring people get the right choice of their medicine at the right time and are engaged in the use of the medication with their clinical team as well. So why do we need medicine optimization? As I've said earlier, we are talking about safety here. So medicine optimization by improving safety, adherence to treatment, and reduction of waste. So we can ensure safety for our patient, we can ensure adherence for our patient, and even concordance, we can ensure that. And at the same time, we can reduce waste and save money if we have a very valid and highly implemented medicine optimization strategy in place. So what are the goals of medicine optimization? So if as an healthcare professional, or if as an healthcare system, what do we want to achieve? What are the goals? So the goals of medicine optimization is to help patients to improve their outcomes, take their medication correctly, avoid unnecessary medicines, reduce wastage of medicines, and improve medicine safety. What do we mean by all these goals? Improve their outcomes. What do I expecting? If someone is on high blood pressure medication or someone's on asthma inhalers, we want to see that when they start taking their medication, there's improvement. And they are not using 3 different medications for the same thing that are doing the same work. And take their medication correctly. We want to ensure that a patient that is prescribed to take his or her medication 3 times a day is not taking it 1 time a day. Or a patient that has been prescribed a medication has stopped their medication and we didn't even know about it. So we want to ensure that the patients are taking their medications correctly. Another goal of medicine optimization is to avoid unnecessary medicines. We don't want someone taking paracetamol and cocodamol together. And we don't want people taking diclofenac at the same time with ibuprofen together. So we want to be able to have efficient pain management strategy in place if you want to manage a person that is suffering from pain. So we want to avoid unnecessary medicine. Reduce wastage of medicine. Depending on the kind of health system that we have, whether here in UK, America, or where you are down there, we have to, as much as possible, reduce wastage of medicine. When patients are prescribed medication for 3 months, we want to ensure they have medication for 3 months. We don't want them to have extra medication where eventually it gets expired, they have to throw it away, or they are taking medication that is not even necessary for them. Because once we are able to reduce wastage of money, of medicine, we can save costs for patients, we can save costs for the economy, we can save costs for the government as well. So improve medicine safety. If we are able to have efficient medicine optimization plan in place, we can improve medicine safety. What do we mean by this? If a patient is taking a medication that is not working, if we have a efficient medicine optimization plan in place, we will be able to spot that this medication is not working, and we can have a system in place where we can review the medication. If we have a medicine review system in place, and we can change the medication with the clinicians, at the same time work with the patient to decide and talk about their medication, if it's working or it's not working. So polypharmacy, this will bring us back to polypharmacy. What is polypharmacy? Polypharmacy is the concurrent use of multiple medications by one individual. As we know that as we have age medication and comorbidity set in, people have so many diseases and they have to have multiple medications. So when we look into polypharmacy and we look into medicine optimization, we can see an interlink in there. So polypharmacy is most defined as the use of 5 or more medication daily by an individual. You can see here, some of our elderly patients ask this pop-up that they put their medication together so that they don't forget. So they know what to take in the morning, maybe 5, in the afternoon they take 2, at night they take 1. So people on this type of medication needs to be properly monitored so that we can have high outcome with their therapy. So, however, the definition of polypharmacy is still debated and can vary from 2 to 11 concurrent medications. Some studies are generally define polypharmacy as a use of multiple concurrent medication or simultaneous long-term use of different drugs by the same individual. So, looking at polypharmacy and medicine optimization together, we will be able to really take in and take out some medication that are not needed by that patient anymore. So, for example, if a patient is taking medication, he had a fall, an acute medication, is taking cocodamol, and is taking some amlodipine for his high blood pressure as well. So, if the patient is now better, the patient doesn't have any pain anymore, we should be able to during our medication review, while we're trying to see the patient, we should be able to take the cocodamol or the painkiller out because that pain is no more there. So, all of those things are the things that we'll have to look into when we're trying to optimize medicine in primary care. So what are the guiding principles of medicine optimization? So the Royal Pharmaceutical Society here has produced a good guidance detailing 4 guiding principles for medicine optimization. And this is readily available online. So all our nurses here from all over the world can benefit from this beautiful guidance from the Royal Pharmaceutical Society. And the aims are to understand the patient experience and so be able to use the medicine as safe as possible. So this particular document is available online, and all the healthcare professionals can access this, the nurses, the doctors, and the healthcare support team. And it's a very, very good document, and it has really, really supported us in practice. So this medicine optimization by the Royal Pharmaceutical Society guidance is aimed to improve outcomes and have 4 main principles. So the principle 1 is aimed to understand the patient experience. So, and this principle 2 is based on the choice of medicine. And principle 4, make medicines optimization part of the routine practice. And principle 3, principle 3 is to ensure that medicine use is as safe as possible. So I don't know how many time, I don't really have much time, okay. So if I need to just simply expatiate and explain each aspect of this principle in practice, principle 1, aim to understand the patient experience. We want to be able to know how the patient understand how the medication has come about. Did they really understand what the medication they're using, what is it for? Did they understand that, did they know when did they start taking that medicine? Have they changed their medicine? Did they have a track record of when they start, what has changed? What did they feel about the medicine they are taking? And if you look at the principle 2 of the medicine optimization strategy from the Royal Pharmaceutical Society of Great Britain, it says evidence-based choice of medicine. Can we evidence the medication the patient is taking? Did they just buy it over the counter? Is it a licensed medication? Is it unlicensed medication? So we have to be sure that this medication that the patient is using is evidence-based. And most of these things are based on patient-centered approach. We have to work with the patient to make a decision about the medication they are taking. It's not that the doctor will just come, you have to take it and just take it. It has to be a discussion within the patient and the clinician to agree on the treatment plan. And they have to understand the treatment plan. They have to understand the medication they are taking. So the principle 2 is so important to us, it's important to the healthcare system, and it's important to drug development in pharmacy practice, that there should be an evidence-based choice of medicine. So for a patient with asthma, we have to look at the guidelines of 8 different stages of management of asthma. If the patient is on high blood pressure medication, we have to look at the guidance that supports the medication the patient is using. If the patient is on COPD or the patient has got some maybe sexually transmitted diseases, so we need to be able to have an evidence-based discussion, evidence-based that supports the use of the medication the patient is taking. And principle 3 is to ensure that the medicine used is as safe as possible. We want to be able to ensure with the patient that the medication, the dose of the medication is indicated for the treatment that we're giving it for. We want to ensure that the medication is safe to take for that patient. As a patient got an allergic reaction to any of the ingredients in the medicine, so we need to be sure that this the patient doesn't have any allergy reaction to that particular medicine. For example, people that have allergic reaction to penicillins. So we have to document, we have to know, we have to ask, and we have to consult with our patient and ask the right questions when doing consultation. As there as a clinician, as there as a pharmacist, as there as a nurse. So we should document, we should ask the right question before we implement any medication for our patient. So has there any allergy reaction? Even with COVID-19, before we vaccinate, we have the question, have you had any anaphylaxis in the past? Have you had any reaction to vaccine in the past? This is part of pharmacy practice, an act of pharmacy practice that is very, very important. So we should ensure that whatever we are giving to a patient is as safe as possible. With COVID vaccine, we also ask patients, are you planning to get pregnant? Are you pregnant? Because we know as pharmacists that we don't have a robust data at the moment to support patients that are pregnant to have the vaccines. So well with other medications, we have to ensure that it's as safe as possible. So we have to ask the right question. And principle 4, make medicine optimization part of routine practice. So when we talk about medicine optimization, as I've said, is a sequential way, different ways that we have to put in place to support our patient that they are having the right medicine at the right time. So what we mean by when making medicine optimization part of our routine practice, we mean that it is a center of medicine use. It is a center of the practice, the hospital, the community pharmacist. Our patient, when they come in to ask for medicine, we are asking the right questions. We have been able to review their medicines. We have been able to tell them what the medicine is for. We have been able to ask them if there's any adverse reaction they've had before with any of the medication. We have been able to provide them the information to report on yellow pages or whichever way you have in your practice if they have any adverse reaction. We are able to give them an informed decision that whatever, just give me 1 minute.
Your telephone?
It's fine. So we have been able to
You're
So we have been able, thank you. So we've been able to make, ensure, let the patient realize that everything that by the time they come in, they have all the information to support them. So even when they get home, they have contact details or who to call or where to find on website or what to do in case there's a problem with their medication. In England, we have what we call medicine use review, which is now structured medication use review, where we look into people with chronic medical conditions and they're taking more than 2 to 3 medications, and we see how we can support them, how we can see what is working, what's not working, how can we move this around. At the same time, we have in place what we call new medicine service. New medicine service is for patients that are taking some medications that are highly, we call them highly monitored tablets. So anybody that's starting that medication, we review them within 2 weeks. About 3, they come in to see us, 3 times. We explain to them what the medication is, the likely side effect, if there's any issue, what to do. So in a week's time, we call them again to see how they are so that we know that they don't have, is either they are improving or the situation is not changing or they have any reaction to that particular tablet. In this process, we'll be able to spot if the patient starting a new medication has a reaction to that particular medication. And if we call them the second week, we want to find out from the patient, is the medication working? If they said yes, then we they go back to review with the GP. If there's a problem, we record it and send them back to their doctors for another review, maybe change the medication and things like that. And we always remind them if there's any adverse reaction to report that immediately. So those are the 4 key principles of the medicine optimization strategy from the Royal Pharmaceutical Society, and it's been implemented and it's very, very effective. So I would advise some of our clinicians here, maybe something you can borrow from, something you can read about, something that can support your healthcare system. So advice for healthcare professionals. What we can do, this is just my basic one, that what we need to be doing and what we can ensure we are able to do as clinicians is to make sure that our patients know what their medicines have been prescribed for. So we don't just want a situation where a clinician will just write a prescription and just give it to a patient. Oh, that is your prescription, go and get it from the pharmacy. We want a situation whereby you are giving a prescription to a patient, you are telling the patient, I'm giving you paracetamol for your headache. Take it 2-4 times a day. If it doesn't improve, go back, come back, do this and that. So if you are giving a patient for someone that have, I would say maybe just starting high blood pressure, for example, maybe amlodipine or something else, where we expect you to explain to the patient as a clinician or nurse that is monitoring a particular patient, maybe asthma as itself, that I'm giving you an amlodipine for your high blood pressure. This is a likelihood side effect that you see, but if you see anything that is not right, please call the doctor. We want the patient to know that this is my medication and I know this is for this. If a patient is given statins for cholesterol management, you want the patient to know that this particular tablet that I take every night, mostly take at night, is for my cholesterol. So we want the patient to understand what the medicine is for and why they are using that particular medication. Within this, we'll be able to have a very good outcomes from the use of our medicines. And the second thing I wrote here is make sure they are involved in the medicine use review and their care. It's the same thing I'm saying. They have to be involved so that they know what we are putting in as a clinicians and what they have to put in as a patient. With all this, if we work together, we'll be able to have a very effective, robust care for our patients. And what's the advice I've got for our organizations? We should empower our pharmacists to manage polypharmacy issues, medicine reviews, and medicine management. I don't know, whichever area we are in the world, we have to make effective use of our pharmacists. Our pharmacists are very educated and they have wide knowledge about drugs and drug management. So it's very good if we can put structures in place to use our pharmacists effectively. We can attach pharmacists to a particular, in England, we have specialists, decide to specialize in HIV and sexual health. We have our pharmacy that specializes in medicines. Some specializes in asthma, some specializes in so many areas. So when we have pharmacists that specializes in different areas, they'll be able to manage and the patient will be able to come to them all of the time to review the medicine that they are using and have a very effective outcome with the medications use and management. So when we look into medicine management, we know we have a lot of issues individually all over the world, drug management issues, stock, safety. We have to make use of the pharmacy for high good inventory. What I'm saying is abuse of medication. We should be able to manage medication if what is missing, why is it missing? We should ask that question. In a store, if you are managing a store within a pharmacy setting, and we want to ensure there's a safety within that particular setting, we have to be sure that we are stocking 20 packets of paracetamol. We have to be able to account for that 20 paracetamol. Where did it go? Who did we give it to? Which prescription goes out with that particular medication? So high inventory being able to account for what is going in and coming out in medicine management is very, very important for medicine safety and even patient safety as well, because we'll be able to monitor this particular medication that has been withdrawn from this, maybe there's an issue with the medication and it's being withdrawn generally. So we know if we have something in place that is monitoring what is going out, we know who that particular person was given that medication that needs to be withdrawn, and we can recall it immediately. So medicine management is a very integral aspect that every establishment, every pharmacy, every healthcare system has to put in place. And there should be a pharmacist there to be able to support what is going in and what is coming out. So with this, I'll look into control medications. Control medications are, morphines mostly, and they are mostly abused. And to be able to work on all over-the-counter medications as well. When we have a very high medicine management in place, we'll be able to control the level of drug abuse. At the same time, we have to support our pharmacists, train them, give them the power to be able to get involved in patient counseling and patient consultation. After every after you have given them their prescription or they have given their medications to their patient. An effective counseling and medicine advice to a patient support the patient. They don't really abuse the medication. For example, someone that have a chronic, maybe I would say even acute pain, and you give that person maybe cocodamol, and you continue to have that pain. Instead of coming to the doctors to explain that the pain is not going away, they continue to take more and more and more. And we don't know, it's a risk. The patient doesn't know it's risking the blood system, the S system, and eventually they get addicted. So all of these medicine management issues, medicine organization issues are very, very important to ensure patient safety within our system, within our patient, even within the hospital that we are. So those are the things that are so important for us that we have to look into. So make sure your system, your culture, your behaviors identify and support polypharmacy patients. So the way we speak to our patient, the way we counsel them, and the way we train our staff as well is very, very important so that we can support our patient and support the system that we work with. So keep the whole team. The whole team, when I mean the whole team, I mean not just the pharmacy team, I'm talking about the medical director, I'm talking about the doctors, I'm talking about the nurses, I'm talking about the healthcare assistants. Everybody has to understand what medicine is. Everybody has to understand medicine management, and everybody has to understand safety of medicine. It's very, very important for our patients. And
thank you very much.
Yeah, so thank you very much. And that is just, I'm very sorry. I know thank you very much for the opportunity. And this is just the last slide here. What are the areas that we're looking for research? And this will benefit some of us are in university, in clinical areas. There are numerous questions and research gaps in arena, in polypharmacy and in pharmacy really, that we need to walk through. So these are some areas of research that I'm sharing with you. And if you go into Royal Pharmaceutical Society website, and some of the NICE guidelines, all of these are there. And this will support the whole world and to be able to maintain safety within our organizations. So there's so many things in there. There's some evidence-based tool to help the healthcare professional to be more confident to stop medicine safety. What constitutes a high-quality medication review consultations by whom and where is the best place for structured medication reviews. So all of those things are areas of research. How are the healthcare professionals supported? How can we support them? How do we get engaged with our patient, the people, the community? We're in the area of COVID-19. Have we been able to support people? So all of those things are the area of research that we need to look into. What technologies are in place to support our clinicians? Do we have the right technology at the right time? Are we using the right technology for the right thing? So do we have enough equipment to support our healthcare professionals? What technologies do we need to help our patients or elderly patients? The dorset boxes, how do we support our elderly patients? So all of those things are the things that we have to look into as an healthcare organization to support us as clinicians, support us as patients, support us as leaders of healthcare system. So thank you very much for this opportunity. And I hope that with this lead to talk, I've not been able to really substantiate it, who will be able to support us as nurses, professionals in every day of our practice. Thank you very, very much.
Well, thank you. You certainly are very passionate about your subject. And I guess with the talk just before, it also shows very well the combination between patient education on this subject, plus also how to actually administer the drugs in the first place. Thank you so, so much for your interesting speech. Are there any other questions? Okay. So I guess you have been able to join us, Dr. Bhattacharya. You ready? So it's a pleasure to have you from India.
Suzanne, greetings from India. Wish you a very good morning and greetings to every other participant here online.
Yes. So please let me introduce you to our participants. You are a microbiology graduate from University of Mumbai and went on to complete medical education from the prestigious Armed Forces Medical College in Pune. Having contributed to the service for more than a decade with varied exposures, you went on to pursue a specialization on hospital administration from the same college. You have hands-on experience on managing a 1,000-bedded COVID makeshift hospital in Delhi during the peak of caseload in Indian capital. Your core area is to develop efficiency in the healthcare area of India and abroad alike, and confronting the two standards systematically. Well, thank you so much for joining us now, and we are all very eager to learn from you. So please, the stage is yours.
Thank you so much. I am talking about the job satisfaction of nurses. I am Dr. Taraprana Bhattacharya, resident of MD Hospital Administration from AFMC. The scheme of my presentation is I'll introduce the subject, go on to the small literature review. I'll define the project, what I have undertaken, the aims, objectives, methodology, what I have adopted, results, and conclusion. Going on to the definition of hospital. What is an hospital? The WHO expert committee in the year 1963 gave this comprehensive definition of hospital of being an integral part of a social and medical organization which provides for the population complete health care, both curative as well as preventive. The outpatient services reach out to the patient in its home environment, and the center being of that for a training of healthcare workers as well as biosocial research. What a comprehensive definition. Now, in this whole perspective, where is the nursing section? The nursing section, as seen this on the screen, the various domains of the healthcare quality, managing the environment, promotion of safety, which is the basic topic of this conference, evidence-based practice, technical competence, patient-centered care, positive interpersonal behaviors, and clinical leadership. In all these domains which we see, the nursing practitioner is of paramount importance. This factor, if not being taken care, the Pandora's box is open to all. Now, the hospital matrix. We all agree, the hospital being a tremendously vulnerable environment there present in the hospital, it's a matrix organization. The verticals, as we see, the acute clinical, surgical, medical, orthopedic, mother and child clinic, anesthesiology, heart, lung, diagnostics, all these verticals are connected with tangential connections. Now, where is the organization of nursing practitioners in this frame? Going by the non-Abelian model of structure, process, and outcome, we'll have the work environment on one side and the outcomes, the deliverables, which we notice in the healthcare organization. What do the nurses do? Work environment, the non-professional task, and the day shift, the patient-nurse ratio. ICU beds having a patient-nurse ratio of 1:1, and that in the smaller and the daycare and thereafter so on and so forth. The ratio is higher. Now, what is the process? The nurse has to look after the patient, his medicines, his immediate environment. Any let down, anything not done, what comes out is the burnout of the nurse, adverse events, and the patient safety level is compromised. The nurse turnover is a critical challenge for healthcare systems. This is taken from the following reference. Now, what are the factors? Major turnover factors include low salary, low nurse-patient ratio, end of contract, discrimination, bad accommodations. These are factors which account for the turnover of nurses. Suggested areas for improvement include motivation, administrative support, quality of life, and the work environment. Coming on to the study was to study the job satisfaction of nurses in a tertiary care teaching hospital. Objectives: to study the satisfaction, factors associated, and conclusions. I used a pre-validated structured questionnaire, study population being of nurses and nursing assistants in the hospital, the sample size of 201, and with a suitable size of alpha and beta. What did I conclude? The demographic data delivered that almost a quarter of the individuals interviewed was male and the rest was females. So predominantly female nurses. Education, it was the predominant group of graduated people, and about a quarter of postgraduates. Age, the major working group was of 20 to 40 years. And the marital status, mostly married. A single respondent was a widow. Now the results. More than half of the respondents were satisfied with their job criteria. The nurses' high level of commitment to hospitals does not remove the potential of turnover. Role conflict has to be dealt on very stringently by the administration. Motivation. Motivation, the factors responsible for motivating the nurses. If we go on to define the Maslow's hierarchy of needs, we go on from level 5 to level 1. What is it? The basic needs, physiological needs. From there on, we go on to the safety needs, security needs. Then we have the brethren, the idea of motivation, and the last is self-actualization. Significant differences in nurses' role conflict and professional commitment across 3 educational programs, that is, diploma, graduation, and postgraduates. hospital nurses in this study had a very positive feeling towards their working lives. This was all in my presentation. Any questions?
Do you have any questions? Anybody of you? So what were the major changes that you implement, or did you implement any changes after your study? Yes. What was the main reaction of your findings amongst the staff?
The main changes which we could apply was that the moment we started educational programs for the nurses, the motivation factor started rising. Second was the availability of leave. During the last year, the COVID pandemic had burnt out the healthcare workers so badly that like people were not getting leave, people were out of resources, and the areas where doctors and healthcare workers were staying, they were all like sort of banished. Their families had to suffer, like so on and so forth. Everywhere we could see it round the corner, and the news was flowing with similar incidents. But yes, the moment the hospital management stepped in, they could improve the motivating factors.
Yeah. So those are the main steps that you've taken to increase the level of satisfaction amongst staff. What about the pay? Was the pay something that was also a contributing factor, or how did that go about?
Yeah. In the private sector, it has been noticed that like nursing officers or nurses from from a specific community have left almost en bloc, en masse, about 20-25, leaving from a single hospital and migrating to another country for the purpose of pay. Yes. Being in the government sector, the problem is not that rampant because the pay is quite good. In the military nursing services, the dependence of the pay is just too much. Like it's a very good motivating factor for nurses. Like in the government sector, it's not a problem, but in private, yes. Pay is one. Second is education programs. Third is security for the family, because nurses day in and day out, being male or female, either ways, security for the family is a very good motivator.
How would you rate the connection between staff satisfaction and the effective on patient care? Do you see there that there is a connection?
In my results, I could find such a correlation wherein almost the satisfaction, staff satisfaction contributes to more than 75%. And it significantly contributes to the patient safety levels, patient satisfaction. It adds. I'll add on with like patients, the perception of patients and perception of the nurses. For example, there was a study done by Dr. Surekha Kashyap. Ma'am had concluded that out of all the jobs being done in the hospital ward, the nurses have more importance to the delivery of drugs to the patient, the delivery of safe deliverables, maintenance of asepsis for procedures, while the patients, you know, what do they perceive as the most important? They perceive the availability of warm, tasty food, the availability of clean washrooms, like the perception is so different. For a healthcare worker, the perception is something more, that they consider asepsis to be more efficient. They consider the hospital-acquired infections are higher on their priority. But for patients, what is the standard of their living? Happy patient is one who heals faster.
We've got a very interesting comment as well. That first of all, organizations have to learn how to respect nurses. And I guess, especially around the world now, especially the clapping about the nurses' workload has not been received so well amongst all the nursing community. What do you say about this? How do you respect the nursing?
And you know, Suzanne, the situation is so bad across the globe, The nursing faculty is not given that importance. The nurses have to be given importance in the hospital sector. It is very, very, very essential, because a nurse is the one who is considered as the patient's advocate. The doctor, the clinician, they'll say like what is to be done. They'll give the ideas, but the implementation of the same is the job of the nurse. Nurse cannot be neglected. The moment the nursing faculty is neglected, the whole system goes for a 6. If not today, if not tomorrow, maybe a day later, maybe a year later, but it is going to affect.
Have you got, would you like to share any secrets with us on how this is done in a good way?
For the secret which I follow very close to my heart is consider each and every individual as self. If there's an instance, there's a situation, if the same is applicable to me, if I am happy with the situation, then I can apply it on the person in front of me. If every administrator, if every clinician, if every healthcare worker does the same, in a due course of time, everything will change. And the change is here. We have to change and change for better.
That is a very, very nice closing statement. Thank you so much. Do you have any more questions? Okay. Well, thank you very much for your insight and your study. And I hope all the nurses are going to be very satisfied at your hospital and that you can actually be our guiding light for the future.
Thank you so much.
Thank you so much.
It's been great. Thank you.
Okay. Yes. So I would actually like to hand over to Amal.
Good afternoon, Susan. How do you do?
Very well, and yourself?
Thank you very much. Good afternoon, everyone. Welcome to the 8th World Congress on Healthcare Management and Nursing and Patient Safety Conference. I would like to remind all of you for some important points, which is speaker presentation time will be of 30 minutes. Keynote presentation time will be of 15 minutes. Asked and answered session is allotted after the end of each session. If you have any question, you can communicate it through the chat point privately, or you can put your questions on the chat box. So let us welcome our keynote speakers, Ms. Susan Rogrizis. I hope that I mentioned the name very well, from Switzerland. Ms. Susan has completed a master's degree from Aberdeen University. She has over 30 years of nursing management experience in different organizations and is now in the lead of digital standardizing nursing documentation through Europe. Her presentation While B, collect once, use many from nursing intervention to the relevant KPI in the EPR and beyond. I'm passing her the stage to deliver the keynote speech. Welcome, Ms. Susan.
Thank you very much. And I think it is quite a nice follow on from our last speak to actually show you to how we actually do a transition from the nurses' satisfaction into analyzing the data that we can collect from documentation. Therefore, I would like to actually share my screen with you. So my topic today, what I would like to talk to you about is, and also a way of proving the nurses' appreciation for what they're doing. And we heard this morning quite a lot about safety of the patient, safety also in terms of pandemic, how we can actually care for our staff, and how important that is. We also heard on reducing, in terms of the lean management, reducing the handover times. And I think what I would like to demonstrate in my talk to you is how this actually has been done now for quite some years, especially in Central Europe, in terms of out of the nursing documentation. Whom I work for is a provider of a classification, especially for a nursing language, and this is nothing new. This is nothing in out of the world or something that has not been done yet. And I will show to you basically on how one can actually use a standardized nursing language. We have established this course of action now nearly 40 years ago. We established now in over 750 institutions throughout, especially Germany, Switzerland, Austria, parts of Italy as well. And we're now looking at expanding to France, to the Scandinavian countries, and so forth. And we are available in 4 different languages, as you can see: German, French, English, and Italian. And of course, every country that would like to use our nursing classification can do that. I would actually like to start a little bit earlier than just jump in with a nursing classification. And I think if we want to have all this bound up in one topic, we have to see what's going on in our electronic or digital world, actually. And I think what we always have is this kind of wish in our clinical device that we have a massive amount of structured data. If you think when you're using electronic data, your clinical information system, where in the whole of this kind of computer world we use data, that is the ideal world. We have this kind of structure, and we have one little drawer for every information that we collect, so that in the end, ideally, we can analyze the data. But unfortunately, I have to say, and I think you can relate to that, that is also mostly the world that we envisage in this kind of clinical data set. We have a lot of information. If you think who is collecting what, are the physicians, the physiotherapists, the nurses, anybody who is actually in contact with the patient collects their prominent data. but in essence, it is also information that we ask the patients twice, 3 times, and so on, or it is actually somewhere hidden away in this whole clinical information system. And unfortunately, we can't, or somehow often there is no possibility to actually gather it back so that we can make best use out of this data. But moreover, we also have a lot of stakeholder in these data. If you think what especially nurses are gathering in information, there is, we heard it before, we have interest in terms of the financial data. We want to actually have a cost benefit out of it. Nowadays, a lot of it is actually related to the cost, the length of stay, and how can we now actually have all this under one belt, that we can have the satisfactory data analysis that we use.
Sorry, Ms. Susan, I would like to ask you if you can please enlarge your slides.
Sorry?
I would like to ask you if you can enlarge your slides, please.
Okay, is there something?
Yes. Mm-hmm.
Is that better?
Okay, that would be better. Okay, I will. Okay, Miss Susan, enlarge for option is in the right corner, please.
Mm-hmm. Is that better?
Actually, we want to see all of your slides. So you can press the option on the right corner of your PowerPoint slides. No worries, we will share your slides. Next.
Okay, yes.
Okay, yes.
Next.
You can start, Mr. Susan, when you finish, but please say next, so we can go to the next slide.
Yes, you can actually just go on to the next one. Okay, sorry about that. That's typical. The keynote is not working. Just you have to go back, please.
Go back a little bit, please.
Can you go back, please? Okay, yeah. So we have this kind of all use of different data, the stakeholders I was talking about. in that case, we have the medical colleagues who are interested in our data, as we often ask the patient relevant information about his health status. And as you know, we may see them first, and then our medical colleagues take over, and they might ask them often the same question. We have the financial part of it, that we want to know how much, or is this kind of patient or this setting of patient, is that relevant to us? Is that something that, pending if we're a non-profit or a profit organization, is this something that we actually want to care for? Are these kind of the surgeries, the operations, the inpatient that we would like to treat in a hospital, so that we get the revenue that we would actually like to have? And in that case also, when it comes to staffing, of course, the nurses, as usually in a hospital, as the biggest setting of staffing values, we also have to see, do we have the right nurse with the right education in the right place at the right time as of the patient? So what we have here, basically what we have developed, is out of the nursing documentation within a clinical record system, this attitude that the nurses can actually document what they're doing on the patient, but at the same time we take those information out and we share it in the end as a clinical analysis tool. So if you could go to the next one, please. Now, what am I talking about if I say a standardized classification? If you look maybe in your own hospital, you have a lot of paperwork, or you have a lot of different information, and it is all, how are we going to take this or retrieve this out of the clinical documentation? And as it is Easter, I have this bowl of wonderful chocolates here, and they're all mixed up. And usually this is the situation which we find in our clinical information system. So it is so important then that we up and foremost have them grouped in different kind of structures. So please, I will just say please, and then if you could go on. So we have first to have this structure of the nursing activities. With nursing activities, I mean this is all the intervention that we nurses do on a patient on the bedside, embracing the full spectrum of our activities. And secondly, please. We need to have this planning and proof of the implementation. So basically, as we heard before, also in this kind of handover, if we have a competent planning system, there is also a very easy approach to see what is planned with this patient. We can actually look into the future. We see what this patient needs. Also, you can imagine that we have patients that may undergo a very standardized procedure. So this is also something that we can have planned in terms of a checklist. Do we actually have the right measure for all the patients in place, or does the patient actually need any additional help? Also, from a legal point of view, we need to have this kind of proof of execution, that we can actually in some way really prove that we have done these issues, because as you know, this is more and more also a problem, that this legal side, are we actually really fulfilling our duty, or have we actually implemented or executed the issues that we were asked for? Next one, please. And Also, in the last sense is that we don't want to actually have all this done once or twice or 3 times. We don't want to have different forms that we have to fill in, but we want to do it once, collect once, and therefore all the other stakeholders that we have should please just use what we have already documented once. Please, if you could go. So what I'm talking about is that we have a documentation of nursing interventions, and also this is not just on one side, but we also have to see that within a hospital or hospital groups or whatever, that we actually have this standardized language for all different settings. So I'm talking from the inpatient wards, from the IMC to the ICU, to long-term care, secondary care, but also into nursing homes, into the primary care setting, that we can actually have the same kind of language also to do an additional benchmark to see also in terms of quality assurance, what does happen from one setting to the other. And also not only for the nursing group, if we want to calculate costs, you can imagine there's not just a nursing actually working on this patient. We have a lot of other professional groups like the speech therapy, nutritional advice, dietitians. Then we have the whole social services. So if we want to actually really calculate the effective costs, we have to embrace the whole package and not just looking at nursing. So the last setting in, please, is the application that we are looking primarily at the nursing process, but also very importantly that we can actually have this kind of individual planning of patients. And many of the institutions use their pathways where the patient actually has in a dedicated, standardized way that we know very well. He comes from for something minor, the problems, he's a healthy patient, and he just needs, according to a pathway, his treatment in nursing, etc. So we want to actually honor that, that we can actually have these pathways very well laid out beforehand, so that it is very easy for the nurses also to go through the documentation in a standardized way. So in the next slide, I will actually like to show you this on a theoretical basis. We're talking about the classification of these healthcare activities, which is more or less the overarching process of it all within an electronic patient record system. We have the case data. The case data, that of course can be the medical record. The case data could also be what we know with what kind of treatment the patient comes in. Then we have all the additional information from the institution. This often is the internal standards or regional standards that nursing in itself have to adhere to. And of course, then the classifications of the individual groups. You know very well that nurses have one language, the midwives use a little bit of different terms, maybe for the same issue. And also with the physiotherapists, they take over many workload from the nurses and vice versa. We always have the issue of the weekends. A therapy, is it then conducted by the nurses? Is it conducted by the effective physiotherapist? So we also have to embrace this kind of different classification and different languages of each professional group in this kind of standardized documentational framework. And then, of course, something which is very, very important, and we heard it already this morning, is the actual working hours or the labor time of each occupational group. And this may vary from hospital to hospital, especially from country to country, on how many hours the endurance of a shift, endurance of how many working hours within a week, within a month, because that is also the framework. Well, if we talk about having a cost value of our nursing hours or of the occupational groups, we also need to know how much do they actually work in order to calculate all this. So this has an influence on the patient documentation. And here I'm, of course, not talking about the patient documentation on paper that only works in a digital environment, where we can actually summon all this and embrace in one big framework. Out of this, what we can then see is the whole workload measurement. So we want to see at the end of the day how much time has been spent with the patient, how much individual intervention have been done with the patient, so that we can have these kind of KPIs, this analysis in the end, which comes from an entire different area than what we are actually used to, so that we can prove to all different stakeholders what nurses actually are doing. And I can tell you, not long ago, it has been about 20 years ago, we had this comment of a politician who said the nurses aren't doing anything else, they're just sitting in their office and drinking coffee. And I think that was one of the most befriending statements ever, and now we can actually prove what nurses are actually doing. So if you please, the next slide, please. Now, if we talk about a structured approach to a nursing classification, which can actually be used in an electronic patient record, what we need is also a framework of classifications, not just like a regional or even house internal individual level, but also that we are able to make a connection or a linkage to languages or classifications that are well known and also well recognized by the WHO, etc., and other institutions. So that is very important if we want to actually have a patient documentation that is not only usable for internal purposes, but also in terms of a benchmark, or like we are here today, that we can share this data also on an international level, actually. So as you see here, the nursing classification that we use at the moment is mapped to ICF, ICMP, and many more classifications that you may know already. So next one, please. Next one, please. Yeah. So one thing that we have done, and I think especially now with the whole analysis of the COVID pandemic, that we have mapped our nursing classification with the terms of SNOMED. And you will see here some examples of this, and you see how close the two languages actually present themselves. And I think being able to work within SNOMED, with ICMP, sometimes for the staff at a level that they actually document or what they actually use on the bedside, it is a language that may somehow is a bit not in a content that one would actually use in a day-to-day basis. And I think what we try to do is take this kind of very scientific approach of these languages and turn it into a classification that is far more, I might say, to the heart of a nurse. This is more like in a language that we may also talk to one another, that we may also just record, or just from a historic point of view, that we may also do our recording, might it be in an open text session or whatever, on paper or in a digital environment, so that we can actually understand each other a little bit more, or it's easier for them to work with than with a more scientific standardized language. But the advantage of this, of course, is because the classifications in itself, like with SNOMED or with ICMP, they're so close. So basically, we can map one classification to the other, so that in the end, when it comes to the analysis point of view, we can actually draw out or exercise all the analysis data that we may need for a SNOMED analysis in terms of COVID, for instance, but we could also have a lot more more detailed analysis in terms of the nursing outcome from the classification that we use, which is more in terms of KPIs within the nursing setting in itself. So let me just, the next slide, please, tell you a little bit, or just let's actually go into the practice of this whole session of nursing documentation. When we look at what nurses are documenting, or when we go to the theory of the nursing process, it usually starts with an assessment. Then we have a nursing diagnosis. We have an aim. What do we want to achieve with this patient at any given time, or with his disease, or the problem that he presents ourselves in the hospital? And after having this determined together with the patient, we heard it before, we have this kind of reporting on the bedside, and we then determine all the nursing care activities which are necessary to achieve our goals in terms of getting the patient better, or basically that he can be stable, or whatever environment that we have processed in terms of the aims of his stay. And so basically from this kind of planning side, we then go over to the execution of these nursing activities. And of course, to round it all up, we have to evaluate. And you all know that nowadays, with like what I said in beginning of my talk, that the cost factor is more and more important. We have to have the best ratio. So the evaluation of what we have been doing, is this what we actually have done with the patient or on the patient? Was the right treatment, the satisfaction of the patient, etc., plays an enormously role now in the nursing care process, so that it is actually a cycle that then starts again if we have not achieved what we wanted with the patient. So this all is actually now implemented in this kind of nursing documentation cycle. And the next slide, please. What we have is we concentrate on the activities that are actually done at the patient. And I tell you, if you think, and I think you all can relate to this, what we as nurses, or anyhow in the hospital have to have done now on paperwork and all different kind of forms that we have to fill in. So what our aim is to really just focus on the patient activities, what is actually done with the patient. And you can imagine that there is so many other things in this whole of treatment. We have all the issues that we have to fulfill, that the service is actually going on, and from the planning, we heard it before, from the handovers, the team meetings, we have a lot of research that we have to do, but that is all one thing. What we, in the nurses documentation, what we want to focus on is really the activities that we do on a patient. You see this here. It's the time that we spent on the patient. It's the procedures like the washing, the whole medication. It's the whole time spent with him, with the relatives especially. So that is the model what we have. On the other hand of all this, is also very important. You see this in this orange slide as well, that we have, or we can only, if we have a shift of 10 hours, 10 hours is what we can actually allocate to the patient. You can do overtime, but in an ideal world, it is those 10 hours what we can divide within these 3 different factors. So when we go further, I can show you an example of what this classification actually embraces, please. Next slide. And now this is what I would like to show you when I was saying about the actual language in this nursing classification. What you see is that we always provide a definition, because not every intervention is so clear in the title. Maybe there are some that you actually have to read a few times, that you actually really have to know, is it the right idea? Do I have the right idea? And I think that's also, if you look at what nurses are documenting in their environment. Sometimes it is maybe not quite the right expression used, especially we heard it before, if you have a lot of foreign nurses, the language might be a real problem on how things are written down. So with the standardized intervention, you have a certain amount of quality assurance as well, that the right title is given to the right information that has been done on the patient. Also, what we're saying is that the level of detail on somehow, if you find in your documentation, is it really the right level of documentation? Yes, we have to have a legal framework, and yes, we have to document quite a lot really, but at what level do we actually want to have our documentation at? And what we advocate is that in the framework, when we have a clear definition, we have a clear idea what is included in this task as well. This framework, if there are any clawback questions or any legal questions with it, you have this kind of framework of explanation, of definition, where you can have a look at what does it really entail. Also, and now we can always now move into the section of the analysis. What you might find in the title, there is this D9, this number. And this is the clue, I might say, in this whole documentation. If I was talking about the standardized and also automatic documentation of nursing interventions, this is to every intervention is a matched time frame. And in the 80s, when we started with this classification, what we have been doing is really going along with the nurses with a stopwatch, and that was the first attempt to really time how long does a nurse take to have a bed, do a bed bath, to do toilet training, to do mobilization into a wheelchair, so that we had a first understanding on how much time do we actually use for an initial task on the nurse's workload. The next slide, please. Now, in this documentation, this is a slide from a clinical information system. I can also tell you that we work together with, in the whole of Europe, with about 30 different clinical information system providers. And in every clinical information system, the implementation of this nursing language, or how it is used in the end for the documentation, looks a little bit different. So this is the slide where I would like to show you all the different groups. You remember my slide with the Easter eggs, and this is how it actually now transfer in a practical setting. What you see are the groups, like the movement, the personal care, nutrition, because when we want to document something, we either have the possibility to actually go into these groups and share any of these intervention. You see this kind of personal care now is open, and you see a selection of possible intervention that I would like to do as a nurse. So in this stage, what you can say, you have the patient, you've done an assessment, and going back to the nursing process, it is also possible to actually have these individual nursing process blocks, so to speak, interlinked with one another, meaning that if I have a standardized assessment, or the house uses, the institution uses its own standardized assessment, that I can actually have a linkage between the assessment to maybe a nursing diagnosis classification like ICF or NONDA International, and then to the intervention, so that the nurse is guided through this nursing process. And here you have this transfer into the clinical information system. So here you can either choose what you are going to do with the patient individually, and you can actually cross on what your task is going to be. So please, the next slide. And to plan, we have to have the nurse, of course, and this is very important for another analysis. We use usually an individual login, so this is already locked, so you know it's a nurse. It's a nurse with a bachelor degree, it's got a master's degree, it's an auxiliary nurse, or whoever it is. Then the interval, that is how often is it going to be done? Is it once weekly? Is it twice daily? Or how often is this going to be done? Now, I don't know. Yeah. And in means and objects, this is basically, do I want to have some other materials attached to it? Do we have standardized medication that we use? So this is all basically in one overview in this kind of planning cycle on what I do with my intervention. So the next one, please. So you see this, which is now actually filled in, and you see for this performing a partial body wash, because this patient allegedly was a very heavy patient. We even used 2 nurses, and you see she has been added on our screen. We have changed the duration of this partial body wash from an approximately 15 minutes to 20 minutes. And what we can add is that we can say in this case, the patient displayed a lot of pain, or you can add something like the patient likes to be showered with a special type of body lotion or whatever it is. But you see in this kind of planning stage, you can actually have any kind of relevant information on the patient there, so that in the end, in the clinical information system, you have all the relevant data there. So the next one, please. Now you ask yourself, I was talking about this time issue and that we were collecting the data right at the beginning with the stopwatch. Nowadays, now in 2020, we don't do that anymore. What we do every 2 years, we have this very big study going on, and we collect the data from, now it's over 20 institutions, the one that we're actually doing at the moment. And we take 6 months data and take all the different intervention and have those analyzed on a statistical data to see what is the mean, how long does a nursing intervention take in different settings, because you can imagine that especially if we stay with the bed bath given, it is probably different if you're in a reconvalescence setting or in a surgical environment, or let alone in a old people's home. So you have this kind of different settings. So this gives us also an evaluation and a validation of the times that we provide with each intervention, that we are in the right way of providing not only the nursing language, but also the measured and validated time frame to go with every single intervention. So the next one, please. What I would like to show you now is really now the KPIs that are used in the institution who work with our classification. And this is an example of institutions that work with DRG, the diagnosis related groups. And this is an example of very simple, something tonsillectomy, and this is the cost versus length of stay. Down at the axis, you see the length of stay, and on the vertical axis, you see the cost. Now you can do that as the whole of costs, or you can just break that down on how much the nursing care costs. And to calculate nursing care, now if you know what is the total of care given in, because every intervention actually has a time frame attached to it, you can easily divide that by the cost of the nursing staff of every unit, and you know how much 1 minute of nursing time actually costs. So now you have this kind of chart where you see especially the outliers. And if I may ask you to show us the other slide, please, which is more of a complex situation, and you see here the long layers, the outliers, and if you go into the individual cases, which of course you can with a statistical tool, those are often cases who require a lot of nursing care. Might they have developed some kind of delirium, or they have been multimorbid, but nevertheless, whatever they required as a medical care, it is also basically they may have been bound to their bed, they may develop a high fever, they couldn't get out of bed, so the nursing interventions, they may have just been planned on giving assistance, but all of a sudden they had to provide a bed bath for the patient. But now you see that the time spent from the nurse with the patient has increased, and if you calculate costs, you see what kind of difference that makes. And also it is in terms of preventing these kind of patients to happen, or situations to happen. You see, you have a different kind of charting than if you just have some kind of gut feeling that we know we have patients who require all different kind of nursing attention. And if I may show you the next slide, please. This is now the actual analytics tool that we use, which talks of the productivity. And I know in healthcare setting, this is a bit of a difficult topic, talking about productivity. We are not really in a manufacturer mode here, but also productivity in this sense means nothing more that we can actually spend most of our efficient time in nursing with the patient. And you can imagine we talked about documentation. So we document everything with the standardized classification, what the patient requires. And then we have like two elements of it. Either the nurses does not document the whole setting or the whole intervention, which is a lack in terms of legal side, because could be that many of the interventions got forgotten, but they have been done. But also we would actually have the possibility that a lot more has been done, and we can ask the question, is it necessary? We heard before with the lean management over the whole, is this something that is really required or not? And also all this is actually done on the backdrop of the nursing workload. So we are taking these 8, 9, 10 hours, whatever a shift is, and compare it with the minutes that have actually been done on the ward. And you see here on this kind of archway that most of it is in the green area, so that the balance between what was required from the patient and the workload that was actually there from the nursing staff was more and more one-to-one. And in the next slide, please. There is a different analysis. Now you see it in terms of every day. And we all know we have this kind of weekly changes. We have maybe days that is full surgery going on. We have the weekends. We have maybe days where a big physician visitation is going on. We learned about waiting times as well before. We learned about also maybe the staffing level has not been appropriate planned to the issues that had to be done on this particular day. So you see that very well. So from a managerial point of view, you see this, oh, what is going on days where I have a lot of unproductive time or overproductive time, red or yellow, so that I can really go ahead and work with these kind of graphs and data to optimize the service. And if I show you that in the next graph, what I mean, please, the next slide. Now this looks on the first glance maybe a bit overpowering, but it is actually very easy to read. You see on the bottom the blue lines and the red, that is nothing else than the beds which are occupied, and the green mountain range, it's very nice, it's Switzerland, the green mountain range is the workload, or basically that is what has been done on the patient. And you see there's a little bit of a dimple, that is a weekend. A lot of patients went home on Friday, we all know that, and on Saturday, Sunday, the workload was a bit reduced. And on top, what you see, that is actually the available nursing time at each day of this month. So you see that actually the planning of this ward was not too bad. You see it, that basically they are more or less in accordance, so that at any time there was enough staffing there to deal with the workload that has been there. And also you see that the occupancy of the bed also have been more or less the same. Now you can imagine that if you have a chart like that and the green line crosses the black lines, or there is somewhere that the work time or the available work time of the nurses is not in any shape or form near this wonderful graph here, that you actually have a problem, and which costs the hospital a lot of money, as you can imagine. And so the next slide, please. What we do is we have the workload of each patient has also been categorized in different kind of, in 9 different kind of categories, ranging from a patient that actually only needs about 960 minutes per stay, to a patient that actually has 120 hours. So you see that basically the range of patients, and then of course, you know, you can only determine that at the end of the stay, because this is all calculated then retrospectively. But what you see is that how many patients did they have, and how intensive, and I don't mean intensive as in an ICU, but how intense their needs were on this kind of setting on this ward at any time. And you can imagine that just because a patient comes in for a hip replacement, depending on his age or his needs, this can really range from somebody who is basically happy to mobilize themselves again after 2 days, and you have maybe the 90-year-old patient who has who is bed bound for a week and therefore just had very little steps. Now this is also a different kind of occupancy rate, it's a different kind of attendance rate, attention rate of the nurses to the patient. And therefore, if we go to the next slide, please. What we can actually also see is the skill grade mix. When I talk about all these different settings, which is also very important that we have at any time the right person with the right education, with the right in the right setting. And that is what we find is also very important in terms of cost savings, or also staff satisfaction and patient satisfaction. And just one click more, because that should enlarge it, please. You can see it a little bit better. There you go. Thank you very much. So we have also this kind of monitoring setting. If we have a ward manager and she is responsible for all the managerial tasks, so we have the people, the colleagues who are responsible for the education of the students on the ward, and then we have the bachelor degrees, etc. There is no really benefit in this, that a manager starts cleaning the bedsides or whatnot. So what we monitor with that, and you can imagine now, if I plan and execute my interventions with my personal logging, of course, at the end of the month, I can also see who, with which educational background, did do which intervention in the end of the day. So if I go ahead and actually, next slide, please. Analyze the situation that I have on my ward. And this is what we have done here in this study, that we looked at the patient situation, because not every patient or not every patient situation really benefits from the same person who cares for them. Maybe somebody has to be in charge, that is clear, or has to be the person who actually does care plans, who actually does the overseeing of, or has the responsibility of the patient situation. But in the end of the day, who executes, let's say, a bed bath, or gives the patient, helps them with mobilization, etc., can be somebody else. So we did analyze the patient situations and came up with this chart that is just an example of one ward, to see that if you have, for instance, a ward where you have many stable patients, it requires maybe less nurses with a master's degree, less nurses with a bachelor degrees, more to a normal with a nurse with a common degree. Or of course that changes if you have a ward where you have patients with high risk, where the situation of the patient, the medical side of the patient, can change very quickly, where you actually have to foresee also the pathway that he may slip into another situation, and you need the trained staff who actually is able to foresee, or actually then react in the right moment to do this. So moving on for that, I would just like to show you another analysis to do, please. This is a chart where we can actually monitor the individual interventions that are done on the ward. So you can imagine, if you have a clean professional documentation, whatever it has to be done with the patient has been documented and retrieved, so that you can not only have a time measurement attached to it, but you can also count how many times certain interventions have been done. Now, this is very interesting, because what everybody can relate to a situation, let's say a surgical ward, what do you expect would be number one issue on a surgical ward? Is it maybe mobilization? Is it administration of drugs? What would you expect? And you can imagine if number one would be finding a nursing home, or administer giving liquids or something, then, or just documentation, then you may have to ask yourselves, is it really, are they really doing the right intervention for the sum of patients on this ward? And this also, you can imagine that is once used for quality control. Therefore, I can control, are they doing the right interventions? Are the right people doing the right interventions? But also, if I have internal protocols, like internal standards, and I have a standardized, let's stay with the hip replacement, if that is standardized in terms of on day one of the surgery, this is the plan that we do it in this way. Day two is the next stage the patient is going on, so that you could actually now in the analysis have a certain controlling, are these interventions really done, or are they doing something entirely different? Also, with this kind of charting, what we can do is, if you have, especially in large hospitals, what I find quite often is that when wards are full, or now especially in times of the COVID pandemic, that patients are put not on their surgical ward, but let's say put on a medical ward or a pneumonia ward, and the staff is not really trained in looking after this kind of standardized procedures. Are they doing the same interventions, nursing side, as required? So you have this kind of excellent quality control in terms of not just the time charting, but also the issues of interventions. Yeah, next slide, please. Unfortunately, fortunately, I am at the end of my speech, and I hope I was able to give you a good overview what is done or what is possible in an electronic patient record. That is now, I would say, in Central Europe, state of the art, to have this kind of analysis, and also really reduces the time that especially nursing is using on filling out all different kind of papers, so that they can actually extract all the relevant information, whoever has an interest in the nursing data, and use it for their own purpose. Thank you very much.
Thank you very much, Ms. Susan, for this very, very informative topic. Are there any questions, please? If you have any question, you can write it in the chat box. Well, I have two questions for you, Ms. Susan. First,
yes,
you told about the clinical information system used documentation on different countries. In your opinion, what do you think the advantages and disadvantages for this using digital documentation? And what will be the recommendation for the future version of this documentation?
Yes, thank you. The advantage is certainly that we can actually use a lot of time in having just one core set of information. And I think that is really the key here, that we have one might it be an overview where we can fill in our information, also visible according across all the different professions. If I've been at the patient first, I may already asked about his setting at home, about his problem, and the physiotherapist doesn't have to ask the same questions again, or the physician doesn't have to ask the same question, and vice versa. So this kind of fundus of all information is gathered in one particular tool. And also, if everybody actually uses the same standardized language, it is so much easier to then extract all different statistical data. I think nowadays we have so much requirements. We have to deliver on a national level all different kind of data, but also now with COVID, we may want to participate with SNOMED. We want to tell them on basically on how many, how much, etc. But what's also always gets a little bit missing is the time of the people who execute it. In this case, it's the nursing, isn't it? That we can prove what we're doing really. And before in the speech, it was all about also the appreciation of the nursing staff. And I think with this tool or system method, you can actually prove what we're doing. It's not just something that we're telling and saying, oh, it's a heavy workload, but we can actually prove it in saying, look, this is how intense patients are, and they require so many hours in nursing care, and this is the staffing level that we have, and we have, usually it is not enough staff to cover what we actually need in terms of nursing care on the wards.
Yeah, go ahead.
And you're sorry?
Yeah, go ahead, please.
Sorry?
Go ahead, please. I'm listening.
Okay, I think that's really the benefit, and also on another point of view, especially we're here now from so many different nations, but we all care for a human being in the end of the day, and there are so many approaches to that, and it would be really interesting, and I think that's our next task, to then compare what we're actually doing with the patient to find the best possible way forward, the best possible pathway also, because there are, just in the countries that we work now with, there are so many differences also in terms of how patients are treated by nurses, what is deemed necessary by nursing staff, what has to be done with patients. And I think that is also something, this benchmark, to really start comparing on an international basis. I think that would be also amazing to see.
That will be amazing. And regarding COVID-19 situations, patients, how do you cope with this regarding documentation?
I have to say the colleagues actually love it, because the big advantage is if you plan, if you're clever planning what the patient requires, or you can actually, if you have internal pathways, you can plan that in advance, so that the administrational task is actually reduced. Because in the following days, you just have to go over, you have to say, yes, I've done that, or I have to change a little bit the time maybe, or 1 person, 2 person. And the feedback that I get is that they now have done pathways, of course, for the COVID-19 patients in terms of different varieties of it, and that they find it quite also a help, because it can show them also in terms of a guideline. What do I need to do? Did I really have embraced everything? They find it quite a help. Yes, and of course, when it comes to negotiating with, in Switzerland especially, the health insurers, it gives you a really good analysis to negotiate with the health insurers on how much a treatment costs in terms of COVID, because that here before.
Okay, we have one question from Prof. James Jordan. He's asking, has this data uncovered supervising critical success factor for a successful outcome?
The data actually, yes, there are some surprising finding in it. I think that is also a very nice or nice side effect in terms of clinical trial or research, really, because now, as you can actually prove or have this kind of deep insight what nursing is actually doing, this has really found some kind of findings that nobody really was expecting, because there are many tasks that nurses just on the go on a daily basis that are never really either recorded or not have been added with much value. And now also these kind of tasks came to light, which I think is really helped with the appreciation of the nursing staff and what they're doing. Yeah.
Thank you, Ms. Susan, any questions, please? Actually, we don't have any more questions. I would ask, to ask everyone to enable their camera to capture the group photo of the Healthcare Management, Nursing and Patient Safety Conference, please. Okay, thank you very much. Let us resume the session sharing and learning after lunch break. It's actually when we will return back after 30 minutes.
Well, thank you so much and have a nice lunch break.
Thank you. Okay, good evening, everyone. Our next speaker is Dr. Omar Al-Omari from Sultanate of Oman. Dr. Omar is a registered nurse, has completed his PhD from Curtin University in Australia in 2011. Currently, he's an associate professor of nursing. He has served in different administrative positions like the assistant dean of undergraduate studies in the College of Nursing at Sultan Qaboos University in Oman. His speech will be about pediatrics of smartphones, addiction among Oman University students. So I'm passing him the stage to deliver the speech. Welcome, Dr. Omar.
Good afternoon, everyone. I hope you enjoy your lunch. Okay, today, inshallah, I'm going to present a pilot study about the predictors of smartphone addiction among Oman University students. I'm going to present on behalf of my colleagues, Dr. Sulaiman Al-Sabi, and Ms. Cherry Blade, and Ms. Khulud Al-Damiri, and the Associate Editor, Dr. Atika Khala. Okay, as all of you know, the technology invade our life. Now, no one can imagine his life without smartphone. Basically, the smartphone, we use it for everything in our life. We use it, especially in the COVID-19. As a student, they access their Moodle, Blackboard, websites, all the educational material through their smartphone. A plus to the traditional use of a smartphone that the young people that usually do, like they surf the internet, they socialize with their friends using Facebook, Twitter, and all of this kind of social media. Therefore, now the smartphone is part of our daily life activity. To give you an example of how much the smartphone takes place, for example, let us take Sultanate of Oman. Sultanate of Oman is almost a small country, and it consists of around 5 million population or people. The majority are young. There are over 7 million mobile phone connections. Imagine we are 5 million people, but there is 7 million mobile phone connection, which means 2 million extra. Out of this, 4.66 million people are internet users. What I mean here, they use their mobile phone to surf the internet through their mobile data, plus they use the internet as a regular internet user. Can you imagine which almost 11 million, which is 200% extra of the regular number. Of course, we take in our account that we have children that they already do younger than, for example, 10 years old or younger than 6. They don't know even how to use the internet. Of course, the majority of the Omani population are youth. So you can imagine how many people are using the mobile phones. Now, what drives this study? Basically, the negative consequences, the negative health consequences of using the smartphone. Of course, the consequences, they divided to different aspects. At the level of physical aspect, the people who are addicted on smartphone or use screens heavily, they have dry eyes, carpal tunnel syndrome, repetitive strain injury, wrist, neck, back, and shoulder pain. Of course, associated with the migraine headache and thumb, index, and middle finger pain. At the psychological level, people who use the smartphone, they always have a difficulty in sleeping. They complain of insomnia, as well as they have certain mental illnesses like stress and anxiety. Therefore, the aim of this study was to study and to explore the predictors of smartphone addiction among Oman universities. Of course, this is pilot study. Some people will argue, of my colleague argue me, this is more of associated factor more than a predictor, because the word predictors is always associated with the cohort study, longitudinal study. I would agree with that, but we use the team member agree to use the word predictors of a smartphone addiction. This study was one of the preliminary study. There was only one study, the extensive literature search, which conducted in Oman in 2016, and it was only a prevalence study. Just they check the users of the internet, of the smartphone users, and the addiction scale. Method, we use a descriptive cross-sectional design, basically to examine the relationship between, sorry, this is wrong, between smartphone use and the associated factor. The participant, the convenience sampling technique was used. The inclusion criteria was to be able to read and write in English. The survey was delivered using the English language. All here Omani students are competent in English. There is a foundation year for all students before they join their regular study in Oman. And there is another condition: if people or students would like to bypass that foundation year, they need to score at least 6 or 5.5 overall in the IELTS. So most of the students who join the university are competent, regardless of their background, humanity or science background. Of course, they need to be registered in university, and they should have a smartphone. The exclusion criteria, we agree on only one exclusion criteria, which is if the patient diagnosed with anxiety or stress by a general practitioner. This was asked by a direct question: if he ever visited the psychologist or the psychiatrist doctor, and if he officially diagnosed with anxiety or stress. Of course, we use survey to conduct our study. We use a solvent formula, which is almost a very popular formula to test the prevalence of things, which is N, which is the N small is the number of sample, N is the total population, over between brackets 1 plus N, also the population, times square of the E, which is the marginal error. With the calculation, we almost have, of course, we picked a Sultan Qaboos University. Sultan Qaboos University is the only public university in Oman, and all, regardless of the people, of course, in Oman, the education is for free, and all the students who complete their secondary school, they are eligible to apply for Sultan Qaboos University. Therefore, you will find a mixture of all students who belong to different governorates in Oman who can join the Sultan Qaboos University. Applying the formula, we end up that we need almost 391 respondents. Basically, we circulated 600 survey, and we received almost 404. As I mentioned, this is a pilot now. There is a second step, which we are going to circulate this survey to all the students around Oman. But the COVID-19 issue, it has its consequences, because we believe that this study, of course, conducted before COVID. But we believe now, during the COVID, the results will be skewed more, and we will have more rates of internet addiction and smartphone use, especially because of COVID. Therefore, we decided as a team to postpone the project till the situation becomes better. Ethical consideration. This study was approved by Ethics Committee of the College of Nursing before the data collection began. Of course, this is the code. Of course, we are adhering to the Helsinki and Belmont Declaration ethical principles, which all of you know. Permission to use the survey, of course, we have 2 surveys used. The DAS survey, I will talk a little bit about it shortly, and the SAS, the Smartphone Addiction Survey. The permission was obtained from the originator of the surveys. Measures, we use some demographics data: gender, age, cumulative grade point, average, parents' level of education, of course, for the mother and the father, and the place of living. What we mean here by place of living, again, as a part of the service that government of Oman, which deliver to their students, we offer to the student to live inside the campus who join the universities, especially the girls students. So you will find students who are living in campus and students who are living off campus, and we decided to compare between them. As we said before, we are going to use different types. We use the depression, anxiety, and statistic scale. I like personally this scale. This scale developed by researchers in University of New South Wales in Australia in 1995. This scale, why I like it, because basically it is 42 items. There is another short form of this scale, but we use this 42 items. Basically, this scale measures 3 different constructs, which is measuring stress, depression, and anxiety. The scale, each 14 points measuring independent construct. Of course, the scale consists of 4-point Likert scale, in which 0 meant does not apply to me and 3 apply to me very much. So the student, the can score in this scale is between 0 and 42 as a maximum. Of course, this scale is reliable and valid. Cronbach alpha for this scale was, for the anxiety scale was 89, and for this scale is 93. The scale is very or widely used across all the cultures. Of course, there is also a translated version of the scale, and as I mentioned, it is available in public domain. The other one is the smartphone addiction scale. Again, there is 2 versions of this scale, the scale, the short version and the long version. We again use the long version of the scale. The survey was developed by Wan et al. 2013. It consists of 33 items divided to 6 subscales, which are daily life disturbances, positive anticipation, withdrawal, cyber place-oriented relationship, overuse, and tolerance. Respondent can answer on a 6-point Likert scale. Again, the score range between 33 to 198. Later, what we face in this scale, there is no cut-off point in this scale. Usually, this scale is on continuum. A greater scale indicate more serious smartphone addiction. And as a researchers, we were thinking to use the intra-quartile to divide the student to 3 or 4 groups according to the quartile range. But still, this is only thinking a process, and we are going to do to see what we are going to do in the actual study. The plan for data analysis, we use the SBSS version 23. Of course, we use descriptive variable. We use for the continuous variable mean and standard deviation, and for the categorical variable, we use frequency and percentages. We run the diagnostic test for the inferential statistics. Since our participant, the number is more than 100, and we run the normality test for the participants. All our dependent variables is normally distributed. Hence, of course, they are independent as well. We run the independent t-test to study the differences in mean between dichotomous variable like gender, for example, and the SAS score. And for we used ANOVA test to use the differences in the mean between variable which consists of 3 levels, like for example, level of education, 3 levels and more. And again, the dependent variable SAS. SAS stands for smartphone addiction scale. Of course, for the 2 continuous variable, we use the Pearson correlation. Again, after that, we conduct our bivariate analysis. After that, we take, of course, we build our regression model. We build our regression model based on 2 facts. Based on the theoretical background, we study the previous literature and we check which variable can predict the SAS, the smartphone addiction use. At the same time, we use the statistical model. What all the data which were significant at the level of bivariate, we enter them to the initial model. Then we start using a stepwise model to reach to the final parsimonious model. Of course, again, all the assumptions were measured, like the dependent variable were normally distributed, multicollinearity were tested as well, the residual also for the expected and residual dependent variable were also checked. All of this we did. So we find, and there was, of course, a linear relationship between the dependent and the independent variable which have which they are on the continuous scale. All of this kind of assumption we checked before we start our regression model. Result, by the way, were very interesting. Our participant age were 21.3. Of course, the range of participants were between 18 and 26. The cumulative GPA, again, 2.7. The GPA range between 1.7 to 3.9. Cumulative GPA in Oman is ranging between 0 to 4. Basically, the maximum is 4. Smartphone addiction scale, which was 83.9. The lowest score was 33, and the highest was 165. None of our participants reached to 198. Anxiety was 22, stress was 22.7, depression was 22.3. Of course, the intention of this study not to measuring the different level of anxiety, stress, and depression. Another study is going to test that. Therefore, we kept everything at the scale level in order to enter them to the model. Gender, we have 35 almost participants, male student, and the rest is the female student. The place of living, we have 54.5, they are living in campus, and rest is off campus. We have almost 84% of our participants who are single, and the rest they are married. Here is very interesting finding. We study at the bivariate level. We studied the relationship or the difference in the mean score between the characteristic of participant and the SBAHC score. For example, we run the independent t-test to check whether there is a significant differences between male and female in regard to smartphone addiction scale. As you can see, almost they are similar. All of the value, all of this B value here is more than 0.05, which indicating that all the demographic variable there basically was not interfering in the smartphone use. Which later in the discussion, I will discuss this, which is there is some articles or previous research incongruent with this results, and other previous study find different results. I will come to this later. At the Pearson level, we conduct the Pearson to study the relationship between the continuous variable. As you can see, the relationship between a smartphone and the stress was very significant, between smartphone and anxiety, depression. So between smartphone, stress, anxiety, and depression, the relationship were very significant. At the level of cumulative GPA and age, there was no significant relationship, basically. I am, of course, focusing here on smartphone because our smartphone is our dependent variable, and we are going to build our model to predict this dependent variable. Okay, we, as I mentioned, build our regression model. All this data which were significant at the bivariate level and the data which were theoretically significant, at least, we enter them to the model, and we start using a stepwise model to exclude all not significant variable to reach to a decent model. As you can see, we end up with a good model. F was 36.611, and the model was overall significant. The adjusted R square is 26. So basically, our model is expecting or predicting 26% of the variability of the dependent model, which is relatively good in nursing, because you know the human characteristic is very complex, and always whatever you try that to encapsulate all the independent variable which predict the dependent variable, always there is a unique human characteristics. Okay, this is the final model. As you can see, here is the word stress is just missed out. As you can see, the only significant predictor in our model which predict the using of smartphone addiction was stress. Anxiety and depression was not predictors for our model, or they were not significantly predicting the using of a smartphone addiction, which is very interesting. Of course, we asked also our students if they are preparing for the exam at the moment. And again, this one was not a significant predictor for our model. So basically, here our model is saying that when the stress increases, the smartphone use is increasing. It seems smartphone use is a coping mechanism to release student stress. In another direction, as we said, our study is a cross-sectional study. So our study is unable to really know which one the dependent and which one the independent variable. It is associated study in a way or another. So we recommend, as you will see later, to conduct a cohort study to see whether the stress which is responsible of using the smartphone use, or the smartphone use which is responsible for causing stress for participants. The discussion, stress was a significant predictor of our smartphone use among university students These findings were consistent with the previous research. Many research found that the significant relationship between stress and smartphone use. But as I mentioned, which one proceeding, which one, here is the issue, and therefore we recommend to use more cohort longitudinal study to study this relationship. The average score of our smartphone addiction scale was 83.9%. Again, this is a very interesting that there is a study conducted in the same place at Sultan Qaboos University in 2016, and the same results were reached. Therefore, there is consistency. The number of smartphone use did not increase across the student, and this is interesting need for future research to study this. But of course, there is inconsistency between our finding and other findings in different area. Our students and their counterparts, some students in other area using more and other using less. We believe, again, there is a need for a multi-country study, which is using the same survey and to study where the student basically spent their online surfing the internet, maybe the activity that they spent using the internet, where they basically spend their time. And the other issue is to have to use the same tool, which in this method we are standardizing the tool that we are using, and it will give us a better idea about the situation in the Middle East. Several factors come to play to explain the differences between the current study finding and the previous research. One of the suggestions is Oman has a wide internet coverage. The internet plans are relatively cheap, and more than half of the university students are living on the campus. When we say they are living in the campus, which means the internet is available for everyone for free. But again, we need more qualitative research to explore this issue and to see where basically our students are spending their time. There is another interesting result at the level of socio-demographic variable. Our study did not reveal any significant differences between males and females. There is certain study they are in line of our study, but again, there's other study which they found the female are more engaged or more significantly engaged or addicted to the smartphone. Culture, which play a role in usage pattern of purpose of use, maybe play here a significant role. Again, our study was only studying the prevalence, so we recommend another study to see the impact of culture on using the smartphone and basically where the students are spending their time when they are using the smartphone. Our recommendation, we have different recommendations that come up with this study. The first recommendation, to establish or initiate a campaign to increase the student awareness about the negative effects of using the smartphone. And always I believe and always I advocate for that, we need to have an elective course at the level of university which discuss the youth health issue, and one of the important health issue that should be integrated and included in this course is the using of the smartphone use. Lastly, we need to offer a counseling for students. We need to increase the student awareness. We need also to shift our student attention to more of activity resources. At the same time, we need to encourage our students to visit the counseling student center at the level of university. So maybe they will be able to help them to overcome the problem of smartphone addiction. Limitation, there was an inherited limitation for this study. One of the most important is the type of this study. It is a cross-sectional design, which is this study unable to establish a causal relationship between the study variable. There is more study are required like a cohort or longitudinal study or at the experimental level design to establish a cause and effect relationship. At last, our conclusion showed that a significant positive correlation was found between smartphone overuse and stress among the university students. It is important again to promote healthy ways to use a smartphone. We are not against using the smartphone, of course. I'm sure my colleagues here support this, but again, we also opposing overusing of smartphone, and to develop awareness plan target this issue. Students should supported in reducing their level of anxiety, of course. And lastly, thank you all, and I'm happy to answer any of your questions.
Well, actually, thank you, Dr. Omar, for this informative topic. Really, it was a wonderful session. Now, I would like to ask my fellow colleague if they have any questions. Please, you can write it on the chat box, please. Or you can raise your hand. Actually, we have one comment from Prof. James Jordan. He wrote that in the US schools or have students use focused software and comments on its value in this situation.
Maybe some context.
Maybe someone is typing now.
Can you hear me? This is Jim Jordan.
Yeah, go ahead, please.
Oh, okay. So maybe some
ahead.
context to that question, because the phones in many of these schools, a lot of the students are taking notes on them, using them for their internet. So they're actually using them for their schoolwork. So that's the positive side. The negative side is the distraction. So there's been a whole bunch of little apps and software that have been launched in the US that you turn it on and you can't get to social media and you can't get to some of these other particular software packages. And I have to admit, as I was writing my last book, I used it myself because I would get distraction. I'm wondering if that could be an interesting variable in your next level of investigation.
It's very interesting, Doctor. We are using it when we conduct our exam. It's a way of, proctoring our student. But yes, unfortunately, it is not available for all the students all the time, because mostly the software need to be paid and universities do not support this. But I agree with you absolutely. We can conduct an experimental design to see what is the impact of using such programs on reducing the level of the smartphone addiction and level of anxiety. Absolutely, it is a very nice idea. Thank you so much for you.
Any more questions? Okay, I have one question for you, Dr. Omar, regarding the addiction using for software or the mobile phone for the Omani's university students. In your opinion, what do you think is the main reason for you for this addiction?
We need to agree on this. World is moving. We belong to the previous generation where we think that we can live without our mobile phone. But this new generation, they cannot imagine themselves without using the mobile phone. This is one of the most important things that we need to put in our heads when we approach these students. But at the same time, we need to teach them when and how to use the smartphone. We have certain students who are using games, for example, for 24 or 12 hours continuously. We need to find a way to convince these students to not use their smartphone. Even sometimes when the lecturer is playing, you don't see them. They all of them over the moon checking. There is a term that we are using it called nomophobia. Nomophobia is when you're using the smartphone, basically. For example, when you are connected to the Facebook, a student always, they are curious to see what is happening to their post. They need to follow up when they post something in Twitter or Facebook. They are very curious to see how the other student will respond to this post. So they are like the likes, basically, that all of the hearts that they collect. So we need to accept this as an academician, but at the same time, we need to increase their awareness to control this desire, this appetite to use more and more smartphones.
Thank you very much, Dr. Omar. Our next speaker will be Mr. Eric John Berzolia. I hope that I have mentioned the name right, from Saudi Arabia. Mr. Ulrich is a nurse leader who is affiliated with Sultan bin Abdulaziz Humanitarian City in Riyadh. He had his Bachelor of Science degree in nursing in 2006 and finishing of his Master of Arts degree in Nursing Administration and Leadership from Philippine Women's University. I am passing him the stage to deliver the speech. Welcome, Mr. Eric.
Thank you very much. Just to say thank you to the UCG and to the rest of my colleagues here who have participated and currently is present in this conference. It is a privilege for me and a pleasure to present to you one success. A success story of which maybe we can learn something from, and we can progress with this particular story as well. I will be sharing my screen with you. Can you see my screen? I'm sorry, Miss Amal, I cannot hear you, please. Is my screen?
Okay, yeah, I can see your screen. We would ask for you to enlarge.
I think there is a problem with the connection. But anyhow, if I'm clear, let me start this with presenting to you as what Miss Lina Obaid, one of the keynote speakers in the morning session, had mentioned to you, that we came from Sultan bin Abdulaziz Humanitarian City. It is a big hospital in Riyadh, Saudi Arabia. And we are currently employed here, and thus this particular success story happened. These were some pictures of our institution. Yes, we are a 500 plus bed capacity hospital that is most of a rehabilitation facility and a medical center. It's situated in just north of Riyadh and about more than 1 square kilometer in size, if we talk about the campus in its size and location. We are accredited by various organizations, Joint Commission International. We have CARF, the Commission on Accreditation on Rehab Facilities, SBAHC, ISO, Ottawa College of American Pathology, and Center for Excellence for Bariatric Surgery, as well as we are working on our plane tree as well. So our department, Nursing Services Department, in the onset of the pandemic, had already visioned that what about if we will be receiving patients who are COVID-19? We visioned and we worked on a plan to make sure that we are competent and ready enough to receive patients, may it be referral from the government or patients just coming in because of the pandemic, or we will be having our own outbreak of ourselves. So we aim to replicate, if not exceed, our excellence in rehabilitation nursing, as our primary service is really rehabilitation, and thus we want to progress and we want to excel as well, or exceed the excellence that we are showing in rehabilitation nursing to COVID-19 patients as well, but in a safe and secure environment. So what we did was we need to ensure that we field nurses who volunteered to be part of the COVID-19 team. It's very essential and a very key point that we must understand that these are volunteers who selflessly devote their time and their effort in order for them to take part in this endeavor. We ensure that they are confident to care with the competence and updated knowledge and skills. We made sure as well that there is an available PPE and all other equipments and consumables that they will be needing. It is a 24-hour, 7-day service every week. And then we made sure about this nursing model of care, COVID-19 specific one. Sultan bin Abdulaziz Humanitarian City, its nursing services, as I mentioned, has this specific volunteers, 72 strong nursing team. I have I'm leading the team as a nursing service manager, and I have 2 head nurses with me. There are 42 inpatient staff nurses, nursing assistants, ICU nurses, ER nurses, paramedic, and ATS. We also define the care areas. We have cohort system wherein we have dedicated inpatient units to take care of the positive symptomatic patients. If need be, we have a dedicated COVID-19 ICU. We also have quarantine locations for those patients who are positive yet asymptomatic not to put the or place the burden or the work in the inpatient unit. So there is a separate quarantine location of it's a 3-story building with roughly around 140 beds in capacity to isolate these patients. Also, we are catering this. We did cater for patients for monitoring or those that are waiting for PCR swab result that cannot isolate themselves at home. We also did the screening and the visual triaging. And as I have mentioned, we added negative pressure rooms and stuff like that. But also one important thing is that we have a dedicated staff accommodation that we can isolate those our staff, our own COVID-19 team, so that they can be separated from the rest of the city or the hospital staff. So what is a model of care? Model of care, it is what defines the way health services are delivered. It outlines best practice care and services for a person or a group, for services for a person, population, group, or cohort as they progress through the stages of condition, injury, or event. It aims to ensure people or the patients get the right care at the right time by the right team and in the right place, of course. So in considering things that we consider in our development of the model of care are as follows. The availability of the resources. We know that it's pandemic and we may have certainly faced a challenge with procurement of needed consumables and PPEs, but our leadership and the organization made sure that aside from the PPEs and the needed equipment, we have the space as well that is ready to take care of these patients. We utilize cohorting of COVID-19 patients instead of just localizing them per negative pressure rooms. We also had followed the MOH or the WICAYA guidelines from the Ministry of Health of Saudi Arabia. Also, we have from CDC and the WHO updates. We also referred to the publication of research studies and the practices that are being practiced at that particular time in countries all around the world. We also have to ensure that we take into consideration specialized patient needs. We are a rehab facility, major service is rehab, so we need to make sure that we might be able to receive patients of such nature. So age and rehab program specific conditions are also taken into account. Also, the presence of disabilities. There might be COVID-19 patients who may present to us with disabilities. Along with that is the staffing and scheduling. Okay, so number of nurses are required. How many are those that we require? Duty hours. Will it be 4? Will it be 6? Will it be every 8 or 12 hours? So we studied everything and we took into account the first. We implemented 6. Then we are now into 8 hours. So during COVID-19 pandemic time, in the highest peak of it, we have an 8-hour shift but we really ensure that there will be 24 hours of rest in between those shifts for all of our nurses that involves in the direct patient care. We also made sure that the accommodation is available, also the food and other provisions, other necessities for our COVID-19 team, because they will be isolated from the rest of the city workforce. They will be only catering COVID-19. This is to ensure as well that we will not be the transmitting infection if we do have as carriers, because during that particular time, a lot is still unknown about the disease. And then the nursing equity tool, which is one of the highlight of the whole model of care. The nursing equity tool I will be discussing later. But it is a part of the whole concept of this SBAHC, or the Sultan bin Abdulaziz Humanitarian City nursing model of care. We want to make sure that we render the best patient experience in the city, as what we call Sultan bin Abdulaziz Humanitarian City, through giving high quality, safe, efficient, and empathetic nursing care, taking into account the infection transmission risks and the length of exposure for both patient and nurse. Nursing actions are focused to promote overall health of the client. Is not only treating the signs and symptoms of COVID-19, but also lessening its impact to patient's function in route to improving patient outcomes in rehabilitation. So along with these key points are as follows: the best patient experience. We have to make sure that we are following the guidance for the correct COVID-19 care. We have the concept and integrated it in the rehabilitation nursing into our care plans. We have to make sure that we have delivery of safe and high quality care, because we need to make sure that even though the patient is in isolation, we are still giving the quality care that he or she deserved. Infection prevention and control measures and filters were adhered to. We have established a buddy system in donning and doffing of our PPEs. We cohorted dedicated care areas, and we have the anti-room. We're in a 24-hour coverage. It means to say, along with the dedicated care areas, is that all provisions, may it be food for the patients, linens, fresh linens, or medications, all of the things that are necessary yet can be kept away from the care areas are being supplied by the anteroom on a daily basis and when necessary. So it's a 24-hour coverage manned by our competent nurse assistants. We also have shower rooms and laundry services for the patients and staff. Lessening the impact of COVID-19 means optimizing patient outcomes. So an example of this is mobilizing patients, giving them the exercises for the range of motion, so that we can prevent the development of HOs. So that is just but one example. Isolation of COVID-19 team, this is also, as what I've mentioned, is important. We have made sure that we provide them with their needed accommodation, with the food, other necessities, even internet. We have provided it to them. We also added more negative pressure rooms and HEPA filters. As I mentioned, even if it's so redundant, availability of PPEs. We have hospital to hospital and the Ministry of Health referral system, wherein we can directly transfer patients who need, for example, ECMO. A patient who would be needing ECMO, we can contact the Ministry of Health, and then put into their priority list our patients. But this we can also transfer to a specialized hospital, the Prince Mohammed Hospital, wherein they're catering for those infectious diseases cases. We also made sure that the waste management is also catering for this, is also being adhered to, as well as up to the standards wherein we can be able to ensure everybody that we are taking care of our waste. Our enhanced contact tracing, when our own outbreak occurred in our own facility, I will be discussing that as well later. We had readied a backup list of staff whenever it's necessary. Aside from those that were activated, we have a backup list of volunteers as well. And we made the diagnostics accessible, X-rays, lab works, all of that. We made sure that as part of our team, they are also COVID-dedicated staff. So even portable X-rays are being are catered in the care areas, as well as lab works, the ESRs, those CRPs, those blood investigations that are needed in the COVID-19 care. Our own efforts to flatten the curve. In the early onset of our efforts in this pandemic, we were following the MERS-CoV guidelines. This is well known all across Saudi Arabia as we have limited epidemiologic data of the disease. We also have followed the visual triaging, and not only this, these are just some of those that were relayed to us by the Ministry of Health in their own circulars. We have managed the management of our own internal outbreak, wherein we had enhanced 3-clustered contact tracing, meaning the index and his contacts will be in the first cluster. Then we will be also assessing as well the contacts of the first contacts, meaning that will be the second cluster. And then calling again those that are contacts of the second cluster contacts, wherein if they are symptomatic, we will also be calling them, monitoring them, and along those lines of traces, we made PCR swabs and just make sure that everybody is safe, just to to stop the spread of the infection. The provision of PPEs, I know it has been long since ruled that we will only be needing for what do we call it? The precaution. It's not airborne. It's droplet precaution. But our institution made sure that the care providers are safe and added hazmat suits into our PPEs, also N95s and the face shields and stuff like that. So we were facing the battle complete and ready. Kudos to the administration and the leadership of this organization. Also, updated and daily guidance from the Ministry of Health. So we have our dedicated IPC team and the physicians, the infectious disease consultants, who keep on monitoring our compliance with this. And also, Ministry of Health has been sending their own staff to monitor us. Sustaining this, we have our own screening stations and telehealth nursing. Apologies for the spelling. Telehealth nursing, wherein we are calling patients and monitoring them. If need be, we will be sending our own nurses there to, especially those in quarantine facility within the campus, monitoring them and relaying the results to the physicians. We have intensified education, advertise all of the needed measures in order for all of the people, all of the employees and the staff, clinicals or not clinicals, to understand what COVID-19 is. Also, the IPC control team and their hot and cold zone activities, meaning they divided the tasks between hot zone, meaning those are direct contact to the patients. Cold zones would be the one who took over the contact tracing from us during the onset. So cold zones, all of these activities are thankfully being carried over by IPC team up until this day. The screening stations and triaging, as I've mentioned, we have lean documentation, our own HIS system or the inter-system. As I mentioned, we are a rehabilitation facility. Our main service is. So more of our documentation, we're leaning towards making sure that it is appropriate for rehabilitation, like the functional measures, all of those stuff. Toileting, we have all of the documentation in our care plan. Previously, we're focusing on them. But during this particular time, we made sure that we leaned out those documentation and still adhering to all the standards of the accreditation and the governing bodies, leaning those out to make sure that we will only be limiting the documentation, but essentials are there, and those that are needed are there, making sure that it is just that the appropriate documentation for our staff to focus on the task at hand. Also, I've mentioned the equity tool of nursing, and also the support and recognition for the frontliners by the management. They provide us with psychology support, psychologists and the people experience department were calling us during our isolation and making sure that we are upbeat and we are really feeling we are not stressed during that particular time. It also helped that we have in between 24 hours of rest in between the shift at least. So the nursing equity tool, as what I've mentioned, is one of the highlights of this model of care. What is the purpose of this? The equity tool, as what our colleague just mentioned in the previous presentation, it defines the number of competent nurses required for each shift in relation to the number and severity of COVID-19 patients. It ensures fair distribution of workload amongst nurses on shift to empathetically care for COVID-19 patients, meaning with this use of the equity tool, we are able to predict how is the workload. We can define how many staff we are going to activate or send on shift, and then divide the workload among them. Also, because the goal here is to make sure that all of our patients will recover, and that no one in our front lines will acquire the infection. Concept is simple. We have to efficiently deliver safe, high quality, and empathetic nursing care to every patient at the right time by utilizing the resources appropriately. If it need to have more resources, need to activate more staff, then we will do. This is the concept and why we had the equity tool. Patient care provision in the most efficient manner and lessen each time of exposure. We believe at that particular time, and even up to this date, that if we limit the exposure while rendering appropriate and empathetic and high quality care to to each patient, we are also lessening the chances of infection. We only have activated the right number of fully competent nurses. This is a picture of what our Acuity tool was. So with regards to this, you might be able not to clearly see, but it is a tool for us to depict what are the necessary activities that we are entailed to do, providing the care to our patients. So this will give us a summary at the end on how is the scale of it. Is it exposure time is more than 15 minutes to 45 minutes? So this is the Acuity tool, and it will tally up at the end, stating how many staff that we are going to need and how can we divide the workload between them. During the start of the pandemic, during the conceptualization, the risk register assessment of receiving COVID-19, we were already predicting that we will be receiving patients who had disabilities, those that are for rehabilitation. Indeed, we received them, and these are some of the diagnosis of these patients. We have traumatic brain injury, left above knee amputation, multiple sclerosis, stroke, transverse. These are just some of those patients that we received who are with disability. So that made like caring for COVID-19 patients more complex. Yet we've managed. Here are also some of the nursing diagnoses that we have seen and we have planned for or took into account during the whole COVID pandemic care. Our nursing our nursing care provision is not limited to what I've mentioned. It also involves interdisciplinary collaboration and referrals. Meaning if the patient needs to acquire a physical therapy evaluation, other physicians evaluation, like for example neuro, we do the referrals, and our facility is providing them. So we also ensure that patients involved in the provision of safe environment of care, we involve them in the treatment. We use effective therapeutic communication to cater for their preferences, as effective nursing process utilization of the ADPI. And with that, having that in mind, during the active COVID case phase of the patient, all of the things that I've mentioned before were really adhered to, like measures to solve the COVID-19 signs and symptoms. May it be independent nursing action, dependent, collaborative, those actions, we all did them. Transmission prevention measures, providing patient education, all of those stuff. And when the patient recovered, meaning revealed negative result of PCR and is ready for rehabilitation, we did this. We continued the preventive measures for that patient not to have the infection. And we made the measures, we applied measures for optimal level of functioning, skincare and wound management, patient and family education, all of that stuff. FIM, as I've mentioned, the functional improvement measures for bowel and bladder. There are some patients who develop incontinence, and bladder training, bowel training, and stuff like that were also there. One example of this is that this particular patient is during her time when she was admitted. She was a 60-year-old female who is independent, ambulatory. The known comorbidity is only to have diabetes mellitus. She was COVID PCR positive in admission and was admitted in the inpatient, and then stepped up to the COVID-19 ICU. She had pneumonia, RDS, cytokine storm, bilateral pneumothorax with tracheostomy, septic shock, history of septic shock, multi-organ failure, ventilated, NGT fed. She needed ECMO. And then she progressed, and when she revealed negative PCR, slowly weaned off transferred to a regular ICU, weaned off, and then transferred into the inpatient rehab unit. In the rehab unit, this patient was admitted. She had the effects of COVID-19, brought quadriparesis with mobility and self-care impairment. She was ambulatory when she came in, but she had quadriparesis. Functional assessment, bed rolling, modified independence. These are some of the carryover skills that we have provided here, provided this patient, particular patient, 24-hour service. She was then continent, became continent after the trainings, both bowel, bladder, although she was placed on diaper just for her convenience, on mechanical soft consistency food before she was on NGT. She improved a lot. Muscle power, bilateral hand function, improved bed and sitting balance and transfer techniques, improved performance and self-care. When she was discharged, she was walking. She was crying when she saw us because there is another set of nurses and other team who took care of her. So when she discharged, she went back to us and she was really crying. And she was happy about the progress, about her success. So these are just some, but certainly not limited to our interventions. These are just the focus of care pertaining to the rehab program. That's what I've mentioned. So the optimum lung expansion is there, making sure that the oxygen supply is there. Patient is having his full lung expansion so that the oxygenation is ensured. Mobility, as I've mentioned about the range of motion exercises, even while in COVID unit. The prevention of secondary complication, pressure injuries and other related conditions. We also have interdisciplinary collaborations for psychology, dietitian referral. So we have our only lymph edema program and bariatric program. So these are just easy referrals that we can provide. I mean, we have bladder training, the pain, safety, collaborative approaches includes drug administration. These are just some goals, roles and responsibilities are here. So these are just some of those notes that I took during that particular time, and the responsibilities that were required from the nurses. For the sake of time, I will just proceed. So how did we turn up? How did it resulted? How can we say that we took or render our part in flattening the curve? So this is the data that we have. Its impact for the patient and the family that we served, we had a recovery percentage rate of 95.8. The total initial swab revealed positive was 311. These are just small in numbers in comparison to other hospitals, but the recovery rate and the way is just worth noting. The total PCR test done in this facility was 3,085. ICU admission is just down to 1.6%. Mortality is just but 0.6%. Our contact tracing at this particular time, 4th of April, we still have pending interview of 6. I think by now it is finished. High-risk contacts, these were part of all of those contact tracings that we have. The impact into the organization is this. Percentage of COVID-19 staff who got infected, those that are with us in the front lines, is only 0.04%. Percent of COVID-19 who were competent, number of COVID-19 competent staff, we have 102, but we have only activated 72 of them, all volunteers. Percentage of staff who received the competency, all of them. We have still a backup that we never activated because those that are with us were enough at that particular time. But all of those backup or activated, they're all competent. It impacted as well the awareness of clinicals and non-clinicals about COVID-19 and employee vaccination status for the time being. Clinical staff, we are up to 25% already who have it's different. I mean, these are just the first doses. 25% of our population already had the first dose from the clinical staff. Non-clinical staff, 5.47%. Yeah, there is just the registration part and the booking part. I think it is being worked out right now. But 23% of our total population already completed the immunization, and most of these employees or staff, they are direct care providers. So this is very important as well. And the advocacy for the immunization part is an addition to reaching herd immunity. Our result, our contribution in flattening the curve. The red will define our cumulative cases, the positives. The recoveries are in green. It's clearly stating there. And also the active cases as of the time being is flattened up to 8 as of the moment. So we made our share in flattening the curve in our own small way. This is a part of our dashboard for April 4, 2021. These are just but a sample of what our dashboard is looking. Okay. This model of care in this COVID-19 success in Sultan bin Abdulaziz Humanitarian City was also nominated and took part in the National Patient Safety Award here in Saudi Arabia, and was one of the nominees for the award. So because of the success, it was also nominated, as I mentioned. Key points to ponder before I end my presentation. Pandemic will be over with our adherence to the IPC measures and our participation for the herd immunity. It will be over. But the threat of another pandemic is real and imminent. We have learned a lot from this situation. So coming from, as a nurse leader, the longer the time of exposure is, the higher the likelihood of contracting the virus. We should plan the care and the movements or the activities efficiently. We utilize the necessary technology for this, the use of mobile system, even the use of phones to communicate, even for the patient and the staff on duty, or to the family because they will be on isolation. The earliest time rehabilitation is considered, the higher the probability of improving to optimum level of functioning. Nursing care planning should always involve the concept of rehabilitation. It decreases impairments, patient length of stay, and the overall cost. It promotes best patient experience. A patient involved in his care who had a positive patient experience will be more motivated to turn his disability into his ability. So this is just a tribute and acknowledgement to those that serve with me. Every day is a realization. We walk and work amidst the presence of selfless and brave souls. Credits to our volunteers. And thank you. And with that, it's just a privilege and an honor for me to present it to you. I'm ready to accept or answer any questions that you may have. Thank you.
Thank you, Mr. Eric, for this wonderful session. Really, it was amazing for sharing with us your facility health coping with this nursing model. I have one question for you. Prof. James is asking, could you share a little more of your journey during this time? What parts of your initiatives are due to adjusting existing process to accommodate COVID? And what parts of your recommendations are previously unknown gaps that will become insular post-COVID?
Our services were to answer the question, Dr. James. Our services were mainly rehabilitation, but yet we are also catering for acute cases, but not that much. We have a surgical center for excellence as well. But during this particular time, as rehabilitation is not the rate of occupancy during that particular time also was affected. Patients are more wary, and they were quite not confident, let's say, to be admitted. So our census really dropped, and that paved the way for us to allocate the right resources. We were still ready to receive them. There are still units that were functioning. We just isolated one building, actually 4 units. It's a building and another unit too, because one building is 1 unit, 3 units. Isolated them, meaning not physically yet. We have isolated all of the entrance and exit. We have utilized unilateral direction, one entrance, the other exit is another one. So we have, for service-wise, the services that we provide as a rehabilitation facility still was ongoing at that particular time. Yet we have to allocate some staff, some resources, because we were having less of what we previously were catering. allocate them to the COVID-19 program. To answer as well, what parts of our accommodations are previously unknown gaps? Can I have a clear question, Doctor? If you can rephrase.
Sure. I think we're learning because of the speed that we have to process folks, that there's support processes or things that caregivers need that aren't there when they need it, delaying the time and to deliver. And I think later on in the conference, people are going to talk about some lean methodologies. And so, there's a thoroughness, speed, and closure aspect of lean. And this COVID has increased the need for our systems to be flexible. And in some places, we're discovering that the processes to support the clinicians were either not there or were inadequate. And now because of the crisis, all of a sudden it's getting attention from leadership to be solved. And I didn't know if...
I think I'm agreeing to you, Doctor. Totally, I'm agreeing to you. One example of this is that our intersystem, our HIS, or our health information system is running on modules. And if we are doing documentation for rehabilitation, we have leaned those documentation out. As I've mentioned in my presentation about FEAM scoring, we previously were doing that because we are to assess and reassess every week for the patient. But at this particular time, rehabilitation was also taken into account. Yet the documentation part of the rehabilitation were taken, or were just as part of the module, just to make sure that we give the appropriate time for the real documentation needed for COVID-19 care. So this is just one example of it.
Thank you.
If I answer your question.
Yes.
Thank you, Mr. Eric, and thank you, Prof. James. Actually, we have to move fast. Sure. Now, our next speaker will be Ms. Carol from UAE. Ms. Carol is currently completing her MBA HCM while she has obtained her MBA from Swiss Business School and Bachelor from the University of Tennessee Center for Health Sciences. Recently joined as the Outpatient Service Manager at American Hospital in Dubai, UAE. Professional background, 32 years experience in obstetric and women's health, and participated in the commission of Danat Al-Emirates and Emirat hospitals in the UAE. She also served on Sidra project in Qatar. She's a member of the Association of Women's Health, Obstetric and Neonatal Nurses. So now I'm passing her the stage to deliver the speech. Welcome, Mr. Carol. Ms. Carol, sorry.
Great, thank you so much. It's a pleasure to join you today. I am going to go ahead and see if I can share my screen so we can go ahead and get this going. Sorry, I'm trying to make it full screen for you guys. I'm going to speak with you today about something that's very near and dear to my heart. It is about obstetric bundles. There are a lot of patient care safety bundles that are available in multiple topics and areas of healthcare. But because women are still actually dying from childbirth, even in the 21st century, and it's at alarming numbers, we need to truly focus on this. And there are things that we can do to prevent, because a lot of these deaths are preventable. So if you're not familiar, I would love to share with the rest of the world, and especially in the UAE, to talk about getting care bundles started. So what is an obstetric bundle and why do we need them? Well, this is from IHI, and it's their definition. It's a bundle is a structure of improving care processes. And it's just using evidence-based practices. We're making them outlined. When you perform all these steps and processes in a certain sequence, they have proven time and time to have actually saved lives and improved patient outcomes. Because we're going to focus today, there's multiple, like I said, multiple topics in healthcare, multiple topics within women's health and obstetrics. We know these three are still the leading causes of maternal deaths in the world. So there's postpartum hemorrhage, severe hypertension, and venous thromboembolisms, and a lot of these are still preventable. So just bear with me. This report was from 2015 from WHO, and I know they were doing some more research and trying to update their data from 2017. But every day, approximately, according to WHO, 830 women die from preventable causes related to pregnancy and childbirth. 99% of the maternal deaths occur in developing countries, and it's estimated that 303,000 died during the year following a pregnancy or childbirth. Most of these deaths occurred in low resource settings, and most could have been prevented. And we're going to talk about those measures today. This is UNICEF's report, just a quick slide, just indicating the complications with pregnancy and childbirth. And we still want to, you can notice in this slide that hemorrhage still takes up the majority of the complications that we're still dealing with. So basically when an emergency happens, and we know in obstetrics they can happen in a matter of seconds, are you ready? And are we prepared in the event of an emergency? So the way we can prevent some of these maternal deaths and morbidities is make sure that we have these deliveries attended by health professionals, our doctors, our nurses, and our midwives. Make sure we have proper equipment and supplies. If your facility is one of those facilities that doesn't have a lot of resources, when you recognize that there's a problem, that we actually go ahead and make those referrals in a timely fashion. So some of the complications that can occur is the ability to perform a C-section in a timely manner, antibiotics availability, life-saving drugs, blood transfusions, and the ability to perform other surgical procedures. And it's not always hysterectomy. We're going to talk about some of those today. I love checklists, and bundles are really great. They provide you checklist. And that way we just, in the event of an emergency, when everybody's excited, the adrenaline's flowing, it's nice to have a clear outline of step by step so no one forgets what they're supposed to do. We always, always, always in our practices want to use evidence-based processes. And these have been, there's multiple studies, and you can see in my references, and you can research this as well. They have these evidence-based processes do decrease the morbidity and mortality. So what these bundles also do is it provides guidelines with step-by-step directions. So it's very clear as to what needs to happen. So where do I find these bundles? Well, the IHI, the Institute for Healthcare Improvement, is a great, fabulous resource and organization. AIM is the Alliance for Innovation of Maternal Health, and that's associated with ACOG. There's A1. I also know that WHO has bundles as well. And also out of the UK, the Royal College of Obstetrics and Gynecology, they have bundles. So there's plenty of resources to be able to access this. So you can organize some of your departments and plan for emergencies within your own institutions. If you're not familiar with IHI, they've been around for over 25 years. It is based off ways to improve our healthcare, to improve patient safety, save lives, and also better outcomes. Because we're here to improve and protect our patients, not to cause harm. Also, the Alliance for Innovation on Maternal Health. This is a collaborative group in the US, and some of the bundles and some of the initiatives that they've done have actually reduced at least 1,000 deaths, mortalities in the US during 2014 to 2018. So let's take a look at what a bundle looks like. So first we need to be able to recognize that a patient is at risk, and we need to recognize when the emergency is actually happening. So first, we need to do our risk assessments on our patients. This is going to begin basically from the obstetric clinics and offices before they even arrive to the hospitals. We want to use universal active management of third stage of labor. This is for every patient that we have. Every inpatient department should have a blood bank, and make sure that you have a massive transfusion protocol, an MTP. Then you need, I have set these up in other institutions, set up for a postpartum hemorrhage or a hemorrhage cart, and we'll go over what that entails and what's included. Have a hemorrhage team and education and drills for those that are involved. Make sure on your response with every hemorrhage that you go through the checklist, and we're going to break down the different stages and categories so we know what to respond at what point. We also need to remember, don't forget the patient. It is a very scary thing when the patient begins to bleed. The medical team gets all excited and we get very active, and sometimes we forget to speak to the patient that's laying in front of us. And sometimes, you know, the family, we want them out of the room so we have room to work, and they're not, and it just causes a lot of anxiety. So just try to always make sure we keep that good communication with our patients. Take the time to lean over and let her know that we're doing what we can and that we're supporting her, and also make sure at least one person on your team will at least just address the family and make sure they're okay. Also, we need to support in our institutions the culture of bundles and debriefs. This is not to be a culture of blame. It is to be a culture that we can sit around and how we can explore and diagnose and figure out how we're going to move forward. So in the prenatal part of the pregnancy, then we need to do a risk assessment. So if they have a suspected previa, accreta, increta, procreta, we know that they're already at risk. Pre-pregnancy BMIs, these are from ACOG, these slides, and basically some BMIs, when you do through the research, even patients over 40 BMI are at risk. They're clinically significant bleeding disorder, whether they already have low platelets, other significant medical surgical risk. It just depends. You know, the patients that's had multiple C-sections are already got that scarred uterus, and that puts them in another high risk. So when your patient walks in, labor and delivery, we can easily, and we can make this a checklist, you can easily look and decide when you go through the obstetric history, if they have a prior cesarean or any uterine surgery whatsoever, then that automatically is one risk factor. If they're multiple gestation, which we always know these patients are at a higher risk for bleeding, if they've had the grand mole tips greater than 4 births, where they've had a history of a postpartum hemorrhage or any obstetric hemorrhage, if the babies, those large macrosomic babies, the obesity once again, or if they're already anemic. These are patients that automatically need a type and screen. Different institutions have different rules about blood work upon admission. Most places are actually doing the type and screen, the CBC, and checking the platelets prior to or upon admission. Some institutions don't. So at least on any of these patients, at least have the type and screen so we can verify that blood type. Our high-risk patients are the ones that have the placenta previa, the low-lying placentas. The suspected accretas, those are definitely worrisome to have to be aware of. If your platelet count is less than 70,000, if there's any active bleeding, any known coagulopathies, or if you have 2 of the high risk or the medium risk risk factors, then they automatically put them into high risk categories. Those patients, we need to go ahead and do a type and screen. In the intrapartum, during our labor and delivery course, additional things that can prevent or can lead to more risk for the hemorrhages is chorioamnionitis, which we can monitor closely with the blood, with the temperatures and the vital signs, etc. Prolonged oxytocin, when you've got those long inductions and you know those uteruses are going to be super lazy. Prolonged second stages and magnesium sulfate. So make sure, once again, those are typed and screened and that you have reviewed all the blood work that's going to be recommended for collection. The high-risk patients are the ones that start with the active bleeding during the labor. If they have 2 or more of the medium risk on admission, or that develop during the interpartum period, go ahead and type and cross them. The universal active management of the 3rd stage of labor, as we go ahead, generally in 1,000 cc's, whether you use LR, normal saline, or they go ahead and we always put an average of 20 units in to start off with, 20 units of Pitocin, Syntocin, oxytocin into the back. And you're basically going to titrate and open that up after the delivery of the placenta or at that time to get that uterus to go ahead and contract down. You're going to titrate that infusion rate as the placenta is delivered and as we're rubbing that fundus to seed. Make sure on your blood bank that you have a massive transfusion protocol, and make sure that you have a functioning emergency release plan and have the ability to obtain 6 units of PRBCs. Now, I know living in the UAE and at different facilities, some blood banks, they don't have much more than 4 units on hand. So what you need to do if you're in that situation is then you need to collaborate and work with your blood bank people and find out, so where are you going to get the additional units if we need it? How long does it take you to go from this hospital to that hospital? And how long does it take the driver to actually bring it back? And then we have to process to administer it. These are things you need to keep in mind, because if you're going to activate a massive transfusion protocol, if you start to have a hemorrhage, you need to be aware, and the physicians need to know, I have this much blood available on hand now, and I know it's going to take them 2 hours to get me the next 4 units. So just please be aware of your resources around you and work with your blood bank and see how you can make this work safely for our OB patients. Have a mechanism in place to obtain platelets and additional products in a timely fashion. So basically, if you do the activation on an MTP, basically all you need to do is, it's just like any other code, any other process. If you're going to activate it, you should be able to pick up the phone and you should be able to call and say, activate the MTP. Or you can make one phone call and say, I have a hemorrhage, and then they should automatically know what to do. So the blood bank number needs to be available. You should have a policy in place. Know what the emergency release, like I said, how much you can get immediately, how long is it going to take you to get additional products, and what are the additional products? We're going to look at what the American College of Obstetrics and Gynecology, ACOG, has to say or recommends on this. If you don't have these products, then you need to work with other physicians, your hematologist, and your blood bank, and decide how can we best serve our patients. Make sure that, so how will the blood be brought to labor and delivery? This needs to be outlined in your policy. We need to assign in an obstetric hemorrhage roles and responsibilities. I often refer to this as, you have to think of it as like ACLS. You're still going to have designated team members that have specific roles that they need to do. We need to practice closed loop communication, and it needs to be clear and concise. It is an emergency. I know adrenaline's high, just like in a code blue. But if you know the steps and you have someone going through the checklist and you practice an organized delivery of these steps, then you save time and you save lives. How will additional drug products and platelets be obtained? We've already discussed that. And how, working with the lab. Okay, if I need to do this, They need to know when you call and say, I have an obstetric hemorrhage, and you pick up the phone, that your blood is going to take priority, just like an emergency coming in through the ER. So you can read over this on when you review the slides. The anesthesia will draw the labs and run it. We know how the team works. Anesthesia is managing airway and managing the lines, and then also the nursing team is running. And like I said, you need to be good communication with your lab and your blood bank. So what they recommend in this massive transfusion pack is to have 6 units of PRBCs, 4 units of fresh frozen, and 1 pack of platelets. So basically, this is going to give you the outline of the transfusion rate, and I'll let you review that with your own on your own time. What I'd like to focus on is also having these hemorrhage carts available in the units is so nice, because everything is right where you need it. You need to have all your instruments and your emergency things, consumables ready to go. And on the cart, it's mobile and can go anywhere. Then in your medication fridges, you need to have a little box of the medications that you need that are specific for hemorrhage, and they're not mixed in with the floor stock. So what's recommended in these carts is to have the vaginal retractors, a weighted speculum. Everything we have, we need long instruments, because we need to be able to find, in case it is a laceration, then we need to be able to reach wherever it is to correct it. We need an intrauterine balloon, banjo curettes to do those curetages. Make sure you have good lighting so you can actually visualize when you're trying to do your inspection. You can actually visualize and see if you can see where the laceration is, if it's a cervical or some vaginal sidewall that's bleeding. And also, because we don't use the balloons very often, make sure that there's, believe it or not, make sure your instruction book is right there, or a sheet that will give you just quick instructions. For cesarean or laparotomies, we just need that hysterectomy tray. Your sutures, we're going to run over those. You can use your intrauterine balloon there as well, and using the B-Lynch and other suturing on the uterus to help control bleeding, so we can try and save that uterus and not go straight to a hysterectomy. So the recommended medications for the hemorrhages is to have your oxytocin, syntocin, pitocin in pre-mixed bags. You can, here's your solution and the recommended dosaging. Usually they come in 500 with, you can get them with generally about 10 units in each one, or 20, you can add additional. You want 2 ampules, so you can do either a quick IV push, or you can go ahead and do your IM injections. The Hemabate, your carboprost, make sure you have at least 1 available. I know it's expensive, but have it available. Cytotec, that's sometimes a little tricky in this part of the world, excuse me, to be able to have these drugs available. But I do know that if you work with the government responsible people for the approval of these medications, generally, I'm finding it easier now that we can actually have them available. And your 1 ampule of methergin. So basically, when this hemorrhage checklist begins, we're going to call for assistance when you notice it's happening. And then you need a designated, like we said, we will have assigned task and people with certain responsibilities. So you have your team leader, you're going to have your recorder, just like in ACLS or a code, your primary RN that knows the patient's history and knows what's happening, who can give a quick, brief report when someone walks in the door as another team member comes in to help. Announce what your cumulative blood loss is, and to say it out loud. I now have this, I now have 500, I now have 1,000, I think we're going into 1,500, and our blood's changing. Everyone can know in their head what stage they're in on the hemorrhage, and everybody can anticipate and move forward. We need someone to constantly monitor the vital signs, and then to determine what stage that we're in. So quickly, we're going to look at the stage 1. On the initial stage, you want to make sure that this is your normal, this is your blood loss of greater than 500 or greater than 1,000 right at delivery. So they can still have normal vital signs and normal lab values. So we just want to make sure we have a nice IV line in. Generally, what we usually do in the US is put 18s in everyone that walks in labor and delivery. Trying to, some of the places I've been, I tried to make sure that I get all the 22s off of labor and delivery because there absolutely serves no purpose to have a 22 gauge IV on someone. So we just need to make sure we have IV fluid so we can give fluid boluses. Initially, we want to make sure when we notice we have get those Foleys in. We want to keep those the bladder, the uterus can contract. And plus, remember, there's about 600 or 700 mLs pumping through the uterus per minute. So they can quickly bleed out and become unstable soon. So that's why we want to go ahead and start to hydrate them. And we want to massage those funduses and those uteruses to see if we can get them to contract. We want to make sure that we're starting with our medications. And you can see on the right of the screen, these are your medications and dosages. You can go ahead, if you anticipate, call the blood bank and have them type in cross-match 2 units if you see that this is continuing and not stopping. And then we have to figure out why. Why is she bleeding? Does it have to do with her tone? Is there trauma? Is there laceration? Is there retained products that we need to go in and remove? Or is there some coagulopathy happening? So we need to first determine what it is, find the problem, and then fix it. If they continue to bleed, where your EBL is up to 1,500, or you've used 2 uterotonics, you still have normal vital signs, but you know you're losing a good bit of blood, then go ahead and mobilize help. Place that second line. The second IV line should be 18, 16. Generally, over the course of my experience, we put an 18 in when they walk in the door. Every single OB patient gets 18. And then if at any point we expect a hemorrhage, the second one's a 16. So, and that way we want to have clear access where there's no doubt that we can completely run the fluids in and the blood in quickly if needed. Go ahead and draw your stat labs, prepare the OR. If your OR team is not in-house, then you need to call them and have them come on the end, or at least be on standby depending on what their location is and how long it will take for them to get to the hospital. Go ahead and get 2 units of PRBCs, and depending on your facility, if you agree or have the ability to get 2 units of the fresh frozen. And then we need to escalate our therapy and goal of hemostasis. On the infrared and balloon technique, remember, we're going to make sure you have your ultrasound machine available on the unit. So anytime this starts to begin that you have a problem, you need to make sure your cart's there, make sure your medications are there. You can go ahead and get your ultrasounds available. It's just having everything planned and ready instead of running around in 5 directions, trying to find it and nobody can remember where it is. Inflate this balloon with 500 cc's of normal saline, and then you're going to, or water, sterile water, or saline. Use vaginal packing, and then with retraction, we always, once the balloon was inserted, we would pull back and tape it down to the patient's thigh. And then periodically, as the nurse checks, she will put more tension, pull tight on the catheter and tape it down to keep it nice and secure. You can do it through a transabdominal approach, which is very rare. And this talks through the steps on that as well. Surgical management, other than a hysterectomy, I had actually had the privilege of assisting with this in the US. Learning to do the different stitches on the uterus to help save the uterus, learning to do the ligation if needed, these are great techniques that anything we can do, like I said, to preserve the uterus. If all else fails and to save the mom's life, of course, we go on and perform that hysterectomy.
Carol, can you wrap it up, please?
Yep.
It's time.
So here is stage 3. We'll let you look through. We just got to move forward. The only point is keep moving. As you know, things are changing. Move forward, move forward, move forward. Get your checklist, have someone call it out as things are happening so you don't forget a step, you don't forget the medication and the dose, and then always do the debriefings with the staff and with the patient and the family. So we know that these steps actually save lives, and there's a maternal, there's a great research out of California where they were able to decrease 20% of their maternal deaths because of implementing small steps in organized bundles. So here's the references. Thank you very much for your time. And it's been a pleasure being with you this afternoon.
Thank you very much, Carol. This was so interesting. I was asked to take over again because, Amal, I guess your microphone is not working properly. I could listen to you so much longer, so interesting and so hands-on. Absolutely fabulous. Thank you so much. May I ask, do you have any questions? Just a short question to Carol, because we have to move on time-wise. Is there anything you'd like to ask Carol? Okay. And once again, Carol, thank you so much. Yeah, okay. So we then move on. Amal, I hope this is okay that I take over. Apparently you were breaking up so much with your microphone. So I was asked, obviously the lines are better from Switzerland than from where you are at the moment. Our next speaker is Miss Salma Al-Halafi from Saudi Arabia. Hello, Salma. Hi. And you're presenting us with a topic, reducing rate of blood culture contamination or at tertiary hospitals in Saudi Arabia. Yes. And Ms. Salma Al-Halafi is a highly analytical, innovative and responsible individual with a track record of troubleshooting, problem solving, quick thinking, and utilizing strong analytical, organizational, and communicational skills. So please, Salma, the stage is yours.
Thank you so much, all the team and all the organizers, to give me this chance and to speak up about our experience in leading and handling a quality improvement project in one of the largest university hospital in Saudi Arabia. I would like to share my presentation. Okay. Is the screen working?
Yes, we see your slides. If you can put it on to presentation.
Yes.
In presentation mode, that we see. Yes, excellent. Thank you so much, Salma.
Thank you. So the first, let me explain the terminology. What's blood culture? Blood culture is one of the lab tests which is injected the blood into the bottle media to determine the presence of microorganism, whether bacteria or fungus, in the blood of our patients. The main purpose of a blood culture is either to diagnose the patient or to prognosis the treatment for our patient, or for the therapy to determine the proper antibiotic use for the patient. Contamination, we mean a growth of the organism in a blood culture bottle were not present in the patient blood stream. So why we are measuring and we are monitoring the blood culture contamination rate? Because we are following the College of American Pathologists accreditation and standard of microbiology, standard MIC 22630, which is about the blood culture collection Sterile technique for drawing and handling a blood culture are defined and made available for individual responsible for specimen collection and practice. So we're starting implemented these standards. As a part of our monitoring, we collected our data and we draw it using a statistical control process. As we see, the average across 6 months was 4.6, which is above the benchmark, which should be less than or equal to 3%. So the team do further analysis based in department, and we found that a number of contaminated sample was highest in adult emergency, followed by surgical ICU. And then we aggregated the data based in department, and we found that almost emergency and ICU has it's almost the same rate, 33% to 36%, and compared to the inpatient, which was 30%, and outpatient was 0, because usually we are not receiving the patient with a bacteremia or fever. So why we are thinking about the blood culture? Because blood culture contamination as a part of quality and patient safety. Because contaminated blood culture will lead to false positive result and will increase the length of stay. One study found that 254 patients with a false positive added 1,372 extra hospital days. It will causes unnecessary treatment. We may give a patient a false antibiotic or a wrong antibiotic. There is a waste of resources and a cost, which is additional patient hospital costs with 1,270,000 per year. Our aim of this quality project was to reduce the blood culture contamination less than 22% after 6 months, but the team were adapted to the vision to achieve a zero contamination. And first, we started formulated our team. I has the honor to be a project leader and working with the other team. We formulated a multidisciplinary team from every department. And we did a flow chart to assess the differences between the current process and the ideal process, and we found that there is a missing step in compared to the ideal process. Then the team do a brainstorming and root cause analysis of process. So we found that many causes was defined, and the highest rate was of the causes was related to the process itself in compared to the other causes. Then the team set our measurement and how we measure our improvement process, our outcome, and our process, and the balance of our improvement. Then we set our plan and our action plan. We set our activity and who's responsible, the time frame, and how we measure our output, and the responsibility to increase the commitment from our team. We started as a team to review the guideline for the hospital to interpreting the contaminated sample, and we developed this guideline with our microbiologist at King Khalid University Hospital. Then we set our core team from the highest rate of contaminated sample department. From the emergency and ICU, we are involving the service manager to involve the leader and the head nurses, nurse coordinator to help us to educate the nurses, and the IB team also. Then we start reviewing and updated the blood culture collection policy and the procedure. Then from this our policy and the procedure, we come up with 4 products in parallel with the content of the content of the policy. So first we come up with the poster. We post it in every department and every unit to increase the awareness and let our staff to be aware about the process and the impact of wrong collection blood culture contamination. And then we develop a small checklist composed of 5 items to increase the self-dependence and let the staff to be monitored themselves while they are collecting the sample. Then we developing our auditing tool, and then the last one with the help of our IB team. We help the 3 competency assessment, the one for central venous catheter, for pediatric umbilical artery catheter, and the last one for peripheral IV cannulation. Then we start to our testing phase. We choose the emergency department and the ICU department to let the staff, to motivate the staff and created such kind of competitive culture between them. We started our BDSA in both area. As we see, the pre-intervention stage, the rate was high. Then when we started the first BDSA, which is awareness with the poster, the rate started to be decreased. The second BDSA, we conducted the training for all the staff, and the rate started to be decreased. The third one, we implemented a checklist and IV trolley in emergency, while in ICU we could implement the kit because the area was too quiet and the team has the ability to prepare the kits by themselves. Then the rate started to be decreased more. The 4 BDSA, we found that we need to improve supervision during weekend and night shift because all the contaminated sample were reported during weekend and night shift in ER department, while in ICU also we found the same. The 5th BDSA is coming from the defined cause that we need to improve the auditing, and we need to provide assistance, especially in the area of emergency, and we need to remind the group through WhatsApp group about the progress and how the rate. BDSA number 5 in ICU department, the team was defined. There was one contaminated sample due to they have a difficulty in how to deal with the psychiatric patient. So we did a session and we discussed the team and how we develop a protocol in handling a psychiatric patient. The 6 BDSA, we found that there is a 5 contaminated sample due to a central line collection sample, so we did an education for the sample for the staff, and in ICU we created a physician champion because the sample was collected by a physician, especially the contaminated sample was due to arterial line. And we found that after we implemented all these 6 BDSA cycle, the rate has been decreases. And when we compare before, as we see in here, a control chart, the rate before we started to implement it and compared to after we implemented the 6 BDSA, there is a significant improvement in the total rate of blood culture contamination all over the hospital. So we reported our process measurement as a one number of reported back contaminated sample from every department. We found that there is a decrease also in number of reported contaminated. Also, adherence to documentation of a checklist was improved by 100% with the auditing process. For our balance measure, we found that 98% of the staff was satisfied with the improvement, while 2% of the staff was unsatisfied because they feel the workload had been increased. After this improvement, we are celebrating that we are achieving zero contamination in adult emergency in CICU, BICU, NICU, and then CCU during our testing phase. After that, we approved and released our testing policy in all over the university medical city. Then we start to spread our implementations from East Building and then to the medical wards and then surgical ward and then pediatric Obaid and then to the other hospital, which is King Abdulaziz University Hospital. The rate started to be decreased and the sustainability had been continued. We learned many lessons and we have many limitations. We learned that involving a frontline staff has a critical successful in the project pathway to reduce the resistance from the staff and to accept the change. The key aspect of this project was providing a frequent feedback to the nurse staff and to the key person and feel their value in discussing the causes of contamination and know what is the real cause and let them to be safe to speak up in what's happened with them. And implemented a clinical guideline and promoting evidence-based practice will lead to reduce the hospital cost. The limitation of our project was unavailability of special prepared collection kits. Our conclusion that testing policy change with a simple and rapid cycle PDSA in both Department Emergency and ICU result in significant reduction in blood culture contamination rate at university medical city. At the final, I love always saying this that teamwork makes the dream work. I believe in the strength of our team and their ability to make the significant change and achieve zero. And we achieved this dream work to come up with a zero contamination. Thank you. That's all.
Thank you so much for that wonderful talk. It has been so interesting. And you've been talking a bit about the resistance that you faced. Can you elaborate? Has that now overgone? Now they see those fantastic results? Or what is the situation now?
Yeah, we still continue our intervention as implementing the checklist, as provide a frequent feedback, continuous education for our staff, and we're providing an education to every new staff with the IV team, especially in the nursing. The process is still sustained, even it's not a zero, but still we are less than 3%, and we are working within the international benchmark.
Wonderful, thank you so much. Are there any other questions, please, to Ms. Salma Halafi? Okay. Well, thank you once again and enjoy your exceptional work. Absolutely fantastic.
Thank you so much. Thank you.
Okay, so we now move on to our next keynote speaker, Dr. Farouk Mirza from Toronto, Canada. I had the pleasure of meeting yesterday already from Toronto. How are you today? Your microphone is still mute.
Okay, how is the weather?
Oh, it's snowing. It's snowing. As I promised you, it's snowing.
Yeah, we have a nice sunny day today here.
Wonderful, wonderful. Okay, let me introduce you, please. Dr. Farouk is basically a surgeon specialist with qualification and experience in healthcare quality, risk management, and patient safety. The key area of your experience includes training of healthcare providers in a wide range of patient safety initiatives, leading multidisciplinary teams for FMEA and RCA, and facilitating transforming of organizational culture. And therefore, this is a speech that you have prepared for today, your keynote speech, establishing an organizational culture for patient safety. Please, Dr. Farouk, the stage is yours, please.
Thank you, Suzanne, for your wonderful introduction, and it's a pleasure. I thank the organizing committee to have organized such a fantastic conference, and I was with them last year also, and the conference went exceedingly well. And they have been communicating very regularly, very effectively, very efficiently from time to time to see that we need some help, some support. Please communicate to them my thanks and regards. And I think I should get started with my presentation. I'll be speaking today. Yeah, this is one of the key areas of my expertise is culture, and the culture is at the heart of what's happening. Okay, all right. A culture, especially a safety culture, is at the heart of organizational efforts to improve patient safety. Not only patient safety, it's the staff safety and engagement of staff and outcome of patients in terms of their well-being, getting into the hospital with an ailment and leaving the hospital well satisfied with wonderful outcomes in terms of their return to normal work. I don't have anything to disclose, and I don't have any financial interest or commercial interest in any of the slides, which are information which will be presented today. So that goes about the disclosure. And now the journey of my presentation will go towards discussing the definitions of culture, corporate culture, and also basically eventually will be going to safety culture. And I will explain why we need to establish patient safety culture as a key function in an organization, and what's the role at various levels, starting with leadership, middle managers, and the frontline staff. And then I will just quickly go through a couple of video presentations about safety culture and just culture. And I will also explain the tools which are used to promote a safety culture. And then, of course, there are always roadblocks in whatever we do, whether we do a change management or we try to change the culture, or we launch a quality improvement project. There's always a roadblock, and I will just try to highlight some of the strategies which we can use to overcome the roadblocks. And then also I will quickly take the audience through assessment of safety culture maturity. How do we progress from a pathological culture to a learning culture? Because there's still organizations around there which still perhaps are in either in a pathological culture or a generative culture, and things, if they have to achieve total quality management, continuous improvement, they need to build up efforts to go to a safety culture. And then I would appreciate any questions towards the end of the presentation. Basically, science of patient safety has been around since about last 2 decades, and we all agree that we make errors. Errors are happening in many hospitals, many clinics, even now at this moment of time in 21st century, and we are all vulnerable to making errors. And we should always try to focus our efforts on the system and try to improve the system, rather than looking at the perhaps bad apples or bad oranges. The traditional approach was that whosoever made a mistake would say that this doctor, this nurse, this pharmacist doesn't know how to handle patients, doesn't know how to handle their jobs. But we don't go into the details. How have we oriented them? How have we taught them? How are we going to improve them? How are we going to educate them? So it's basically the systems which are broken. Not every healthcare provider who comes to the hospital on a daily basis has no intention of harming a patient. They never come with that intention. But it's a system. except one thing is the reckless behavior. Certain healthcare providers do definitely, even today, have some reckless behavior, which is of course reprimandable, but eventually mistakes happen because of poor system, bad systems. And at the heart of this safety culture is your ability to speak up. When you see a thing, speak up, whether it's a consultant doing something or a specialist doing something. Even if you are a medical student, if you see something is not going well, you have the right to speak. And eventually you will be appreciated for that. And you have to bring up your concern. And people have to accept responsibility for errors. If we made an error, we should admit it, we should report it. And that's how the chain of improvement gets initiated. If we don't report errors, they don't get to the discussion, they don't get to the committee, they don't get to the team, we don't discuss them, we don't know the causal factors or the root cause. And that's why one of the fundamentals of patient culture, one of the fundamentals of improvement is reporting safety events. That is the root cause. Unless we report, we can never improve. We have to identify and report them. And then, of course, this is a concept in psychological safety is critical language. There are certain issues which have to be used while, especially when you are working in high-risk areas like ICU and like neonatal intensive unit or operation theater, where normal language sometimes may not work. You have to be critical. You have to be forceful to get to stop the line. You need to stop the line now, otherwise the patient will have a asphyxiated baby, or otherwise patient will die of hemorrhage, or anything can go wrong and we'll lose a patient. So this is very important as well. Now, what values do we hold? What are our beliefs? How do we act? This is basically all about culture. And you can see how we go through this culture. These are the three basic fundamentals of a culture. And I think most of the audience which is listening to this presentation, they know that culture eats strategy at breakfast, also at lunch. But a time will come, they will put it for the dinner also. Because even if you have the best strategy in the world, even if you have the best tools written in your policies, procedures, or manuals, or whatever, if you don't have a culture, a safety culture, or a just culture, or a learning culture, your strategies are bound to fail. They won't be implemented. And also the same thing happens. They will be eaten at lunch. So culture is very important. If you have to change something in an organization, work on your culture, the strategies will be implemented. Another way of explaining what is culture, the way we do things around here, one person's attitude is an opinion. Everybody's attitude is a culture. So it's a collective effort. When we fail, when a patient dies, we do a root cause analysis. We never find a single individual responsible for the error. We find a collective failure of a system. And we definitely we interview doctors, we interview nurses, we interview pharmacists, and eventually we find out where the defect was, who was responsible. And we don't have to reprimand our healthcare providers. We have to talk to them, we have to educate them, we have to support them. Because at the end of the day, they are defined as they also are feeling the load. They are as of an adverse event. And sometimes, I don't want to go to the details of those things, healthcare providers go to extreme steps because of regret and remorse if they hurt a patient. Never there's an intention to hurt a patient, never. And now we have the hardware and the software in an organization. Because organizations I think are like computers. We have organizational structure, we have policies, we have rewards, system of rewards, and we have compensation and sanctions. And also, unless this hardware work is complemented with software, effective software in terms of values, beliefs, and our behaviors and attitudes, meaning culture, the hardware will not work unless we have a functioning software in an organization. Next, we come to safety culture. Safety culture is the same thing, actually. Values, attitudes, perceptions, competencies are very important, and patterns of behavior are very important. Behavior determines whether our efforts will be successful or not. Because one of the reasons why healthcare, why we couldn't improve organization is something called as authority gradient. It works at work. Authority gradient has been one of the major failures why organizations were slow to implement safety culture, because there's always a scare. She is a director of nursing, she's a nursing supervisor, she's a staff nurse, she's a nursing assistant. How can a nursing assistant bring an attention of a supervisor or a charge nurse? They're scared. So that has to be dismantled at all levels. It has to be dismantled. I have seen in organizations, authority gradient is a roadblock to developing, establishing, and promoting safety culture. Very, very important point to be taken. And leadership, it has to be a leadership top priority. Leaders determine the culture. Leaders establish the priorities. And of course, leaders do it in consultation with the middle managers at the front line. And we should see culture in their symbolic behavior. They have to behave. Leaders have to behave in such a way so that the middle managers and the frontline staff, they basically copy them because they are role models. Let me show this video, which I have shown at many presentations earlier on. It's about safety culture. What's a safety culture? I think it's a video, maybe a couple of minutes, 2.5 minutes. Do I have the permission to open it? Suzanne? Thank you.
It has to be a just culture, not a blame-free culture or a punitive culture, but a culture that has negotiated where to draw the line between unacceptable unsafe acts and acceptable unsafe acts, or honest errors.
We just see that, we just hear it, we don't see it.
Oh, okay, one moment, please.
To tell you about their near misses, about their free lessons, then you begin to have a reporting culture, a culture which enables you to learn the details of the edge between hazard and safety.
Can you see it now?
And once you have a reporting culture, you start to have a memory.
Yes, we can see it.
Has a memory, and it can begin to learn and change and improve its defenses and its safeguards and its barriers. But it also has to be a flexible organization. It also has to change its configurations according to the tempo of the work. All of these things are essential parts of a safe culture.
Any organization can do a simple cultural health check by answering 6 key questions. Do we really understand what error is? A failure of the system, not just individuals. Are we honest? Do we condone shortcuts to save time, money, or effort? Are we informed? Do we really know what's going on? Are we learning? Is there feedback to realign the system? Have we forgotten to be afraid? Is there respect for the hazards we must manage day by day? Do we ask ourselves this kind of question often enough? Are we proactive? Do we have ways of removing the causes of error before harm can occur?
Every person who works in healthcare comes to work every day intending to do good. They're there for the right reasons. And they feel really devastated when things go wrong. So part of our work needs to support them. We're also conscious that when we're more transparent about patient safety, that the public may lose faith in us as a caring, safe organization. And so there's a lot of education we need to do there for the public as well. But I really believe that as part of our accountability to the public, we need to be honest. We need to tell them when things are not the way they should be and what we're doing to improve.
Hello?
Yeah.
Yeah, is it okay?
Yes, absolutely. Are you going back to your presentation?
Yeah, I'll go back to my presentation, yeah.
You okay, or shall we screen the presentation for you?
Yeah, I'm going to screen the presentation. Yeah, here we go. Okay, are we okay?
Yeah.
Okay.
Back home.
Now, let's discuss. There are certain similarities between organization and the forest. Is it clear? Was the video audible?
Yes, absolutely.
Okay.
Just put your presentation on presentation mode, please. That would be great.
Okay, fine.
All these requests.
All right. And now
Perfect.
the ecology of an organization is as delicate as well as vulnerable as that of a forest. Every organization has an ecology because nothing happens without influencing something. So as we discussed, as we saw in the video, the behaviors manifest the way we deal with healthcare providers and the way healthcare providers deal with their patients. A relationship forms one of the basics, one of the fabrics of improvement. These have to be the key to all things within an organization, as with the forest is relationship. Because relationships determine a lot. And once the relationship within the organization is good, is proactive, is cooperative, then we can see good teamwork. And once we see the good teamwork, the culture will be easy to establish and patient outcomes will definitely be improved. And you know, these failures are still happening. Statistics are still in favor that the leading cause of all our sentinel events or adverse events is still the communication failures in 60 to 70% of cases. And as I said initially in my presentation, pathological safety is one of the hallmarks of safety culture. And what is psychological safety? Psychological safety. Psychological safety is an ability of a healthcare provider to raise a concern. They should be free to raise a concern. Even a medical student should be free to raise a concern to a specialist or a consultant that I'm seeing something wrong and we have to do something about it. That's psychological safety. And authority gradient, I've already discussed before, it has to be dismantled if we really need to achieve patient safety. Now you can see this. This is a very tragic situation which happened in Cardiff. A normal kidney was removed from a patient instead of a diseased kidney. And there was a medical student who was observing the surgery. A medical student raised a concern that we are removing a healthy kidney. And the surgeon disregarded his comment, his concern, and they went ahead with the surgery. And the surgeon and the urologist made a disastrous mistake. It was a disastrous mistake. And may God have peace on his soul, this patient, he was a veteran, Korean War veteran. He lost his life after about a few weeks after the surgery, because he was a novel kidney was removed, diseased kidney was kept. So that's why I'm saying, speak up, psychological safety, authority gradient, and critical language. If an attention was provided to medical student, this patient would not have died. This is one of the examples of this thing. So I want to get this point very, very clear to all the healthcare providers, that we should listen to the concerns of every staff when they are raised. Speak up or keep quiet is the option. I would always go with the green one. Speak up when you see something going wrong. Speak up. And always speak up for patient safety. One of the basic fundamentals of patient safety culture. When you see something wrong going, especially in areas of critical care, neonatology, ICU, OT, or whatever, speak up. Don't keep quiet. Always express yourself that I'm concerned. Discuss. I am uncomfortable in this situation. Something is happening. I'm not comfortable. And this is a safety line. This is a safety issue. Stop the line. Once people speak while the surgery is going on or a baby is being delivered, I have done a lot of root cause analysis on asphyxiated babies or neonatal deaths. When I have seen that there was a delay, a junior doctor was struggling to deliver the patient. A junior doctor was frustrated, and she applied forceps, rushed through this thing, and they gave up asphyxiated baby to parents. They didn't call the seniors. Nurses were looking at it. They expressed regret that because of authority gradient, they could not speak. They were scared to speak. So many babies born asphyxiated or they died. So please, this is very important. And how does the evolution of safety culture go from bottom, from the front line up to the leadership level? Report your near misses. Very important. Near misses are free. They are free lessons. If there's a near miss, report it. Don't hide it. You will learn something from it. Get it analyzed. Make a team. Let them look at it. And you can correct a system. You can correct a policy. You can correct a procedure. You can correct a protocol. And also it leads to a proactive assessment of our systems. Because if we don't report, nothing is going to improve. And we are going to harm the patients again and again and again. How do we improve safety culture? These are some of the strategies. First of all, we have to improve our measurements and evaluation process. That's very important. Where do we stand? That's a bottom line. Then we have to establish our educational and training programs. I used to run a training program in Dubai Health Authority myself. And we used to have a quality and patient safety program in one of the hospitals, Latifa Hospital in Dubai. I ran it for about 3 years. And it led to a lot of improvement in patient safety awareness, actually. And slowly, and they're still continuing to do it. And then improve the communication processes. And also improving communication needs continuous reminders, continuous training, especially critical language, very important. Speaking up, very important. And then you have to improve your legal and regulatory processes. Basically, let us start from number 1. Journey to patient safety culture. How do we change our culture? First of all, we have to evaluate it. Where our culture stands. There's a way to establish patient safety culture has to be evaluated there. We have to ask the staff. Surveys have to be done. They have to be logged, they have to be cataloged, and we have to understand, then we have to have an interpretation. Eventually, we need to come up with some recommendations. And we have to encourage patient safety learning at all stages in the organization, at all levels. And we have to identify staff concerns. And we should be telling our staff every now and then, if you have a concern, bring it up. That's the way you are going to contribute to patient safety. If you don't come up with your concern, our safety will never improve. And then you can see these patient safety leadership walkarounds. Actually, last year I presented patient safety leadership walkarounds. This is one of the best tools, I think, available out there through which you can improve the culture of safety in an organization. Leadership walk-arounds, leaders go and walk in the wards, they go to OT, they go to outpatient department, they talk, they invite questions, and those questions are analyzed, assessed, and action plans are developed. We used to do it every month in Dubai Health Authority. Then based on what the staff says, we have to prioritize improvement opportunities, launch quality projects. But everything comes from bottom up. The information is there. There's a lot of problem there. When you open the cracks, you will see a lot of problems. Unless you open those cracks, you won't be able to know what's going on in the front line. You have to encourage them to speak. They are the best teachers for you. So they will tell you what's going on. How are we harming the patients? What do we need to improve communications? How would the next patient be harmed? They will tell you. And then implement improvements, share stories, and disseminate results. Every month, the CEO should call a patient's staff meeting where we should share the results of incident reporting, results of the near misses reported, actions taken, and quality improvement initiatives initiated to improve those gaps in patient safety. Then, of course, again, the cycle goes again. We reevaluate patient safety culture every 2 years or 3 years and see how to improve it. And this cycle is very important if we have to go from the base till the end, and again, keep on improving our safety culture. Now, this is an interesting slide. I was talking to you about certain organizations are still in pathological culture. They say, why waste time on patient safety? We've been doing patient safety since last 50 years. What are we going to change? It's a waste of time. Then people realize gradually then when a lot of patients get hurt or harmed, we need to do something about it. If we have an incident, something has to be done. They started realizing it. And then this is reactive culture. Again, not a good scenario. At least they are doing something. And a lot of organizations are here in many places still. Then is the bureaucratic. Bureaucratic culture is we need to have systems in place to report, manage, and identify risks. Now better, one step ahead of it. Then proactive culture. We would all like to be in this culture, proactive culture. We are always on alert for incidents and risks that might emerge. This is a concept of high reliability organizations. They are always preoccupied with failure. If we are preoccupied with failure, our efficiency will improve, our results will improve, our outcomes will improve. So we have to always report. And the last is generative culture, the last step. We mitigate risks. Risk management is an integral part of everything we do. Everything carries a risk. And if we identify these risks proactively through FEMA, root cause analysis versus FEMA. FEMA is a proactive tool where we identify risks before they happen. A root cause analysis is a reactive thing whereby we understand what went wrong and how to correct it. So these levels of maturity are very important. Organizations gradually, if they work hard, leaders are really interested, they lead well, eventually they can go from pathological to generative cultures. And now look at the difference, how pathological, bureaucratic, and generative cultures process their information. Pathological ones are power-oriented, low cooperation. Messenger is always short. The one who reports they are bad. Why did you report it? There was no need. You are embarrassing your colleagues. Responsibility is always shifted, and then they are discouraged to report things. And they are always looking for scapegoats. Then we go to bureaucratic. At least they do something better. They have an orientation system. There's some cooperation. Messengers are neglected, but still not short. Responsibilities are still blurred. Failure is tolerated to some extent. And generative cultures are performance-oriented, high cooperation. Messengers are trained. Never shoot the messenger, train them. Because maybe they were never oriented. Maybe they don't know about things. And risks are shared and failures are always required. And next we go. I think time may not allow me to go over this video because it's a long video. I'll skip it over. I'll skip it. If we have time, I will share it later on. This is a 10-step approach to improve patient safety culture, but it's a little bit time consuming. So with your permission, I can skip it. Suzanne, if we have time, we can go over it. Thank you. Thank you so much.
Absolutely.
Now you can look at it, if you break this patient safety culture journey or structure or function or operation, look at how many things are involved in it. Teamwork, break it into a fishbone and look how important everything is. It all collects together. Evidence-based interventions, evidence-based protocols, evidence-based policies. Leadership is at the top. Leadership at the top. If leadership is not on board, patient safety culture will never be. It's a dream to achieve it because leaders provide the resources. Leaders provide the motivation. Leaders provide the reward recognition. Okay, so this is very important. Leadership is very important. Something is hiding here. I don't know. Then communication is here. Oh, sorry. Communication is here, and then I think I don't know what's, and patient-centered care is there, communication is there, and all those things. You can see it's in the presentation which I have sent, which the audience can actually go through whenever they have time. We did it in Dubai Health Authority. It took about a couple of months for us to design this, how to develop a patient safety culture. And all these elements are very important. Governance, resources, at-risk behaviors, non-punitive way of dealing things, but non-punitive doesn't mean it should be a blame-free culture. Reckless behaviors have to be reprimanded always. I'll come to that later part of my presentation. I think these were the traditional ways when leaders used to have a clan culture. They used to have their own way of doing things, hierarchy culture. I'm just giving you a historical aspect of what used to happen in the past. But now they used to focus on these traits in their staff. But I think over the years, things have started changing. And I think I won't go much into details of this slide. I'll skip it over. Now, this is a very interesting one. I'll spend some time here. Aim is not blame-free culture. We have to still hold people responsible for their actions. If they did something which was because of their bad behavior, the only way, bad behavior, reckless behavior. They didn't follow a particular protocol, or when they were asked to stop the line, they still went ahead. So high reliability organizations separate blameless errors from blameworthy ones. There will be always some errors. This is very important. Blameless errors from blameworthy ones. Blameworthy ones are because of reckless behavior. So that there has to be a boundary. And there is a boundary. If we do a root cause analysis, you'll get to the boundary. You'll get to the cause. And we have to hold everybody accountable. We may not sanction them. We may not fire them, but we have to actually take some action to stop reckless behavior happening in the organization. Safety culture has to be from boardroom to bedside. It has to be from things discussed in the boardroom, eventually go to the bedside, and while frontline staff are dealing with the patients. So obviously when leadership is on board, middle manager should be there, frontline will always automatically come on board. And I told you patient safety leadership walk-around is one of the best tools for promoting safety culture. You can have a look into it. There's a lot of literature about it. This, if you want to really establish this safety culture, this is going to be very, very helpful. Role of leadership, they provide you the, they keep you preoccupied with the organizational workforce. They give you resources. They tell you this is important. They continuously meet you every month. They re-emphasize the role. Leadership role is very, very important in developing patient safety culture. And again, we come back to the same thing. We should have no blame, non-punitive response to errors. And then, but there should be zero tolerance to one thing, that is conscious disregard of clear risk to patient safety. That is the key. That is where you divide blameless cultures versus blame-free cultures. The errors, conscious disregard. You are told that this patient is still not prepared. You're told that this is a high-risk patient. You're told that some patient is bleeding while we are doing a surgery. Put a pack, stop it, call a senior. You still struggle with your forceps, struggle with this thing, struggle with your hands, and you injure an artery, you injure a vein, and that patient, hemorrhage, blood everywhere, and patient, anesthetist draws your attention. Patient is bleeding, stop. Ask some help, get somebody to look into it. Take a break. You still continue struggling here and there, and you cause the patient's death. Those things are not to be accepted. We have to be fair, but we have to be open. Staff have to report incidents and support caregivers if they are getting involved in it, because they are called as, what do they call it? They are, it's not coming to my mind now. Staff should be free to talk about incidents anywhere, and staff should be treated fairly well when an incident happens, and they should be given off time from work so that they recover, because they also get injured. They are also injured because of an incident. Indirect injury also happens to them psychologically. Engineering of safety culture is that we have to disseminate cultural attributes. It has to be in the roots of our values, and then we have to actually have need to appeal to every individual without threatening an individual's identity. We have to support them if something happens wrong. If the staff know that we won't support them if something goes wrong, they will be hesitant to take high-risk patients, high-risk surgeries. So we have to encourage them to deal with that high-risk patients, high-risk deliveries, high-risk operations, and of course follow protocols, procedures, policies. Call somebody senior if you are in help, but they have to be encouraged. If something goes wrong, you are following a policy, you are following a procedure. We will be on board with you. We will protect you. And the role of champions in disseminating the patient safety culture is very important. We used to also have this in DHA. We designated safety champions in every department, every clinical department, and also administrative departments, because they are a liaison. The safety champions are a liaison between the departments and the quality improvement and the quality council, because they are represented on the quality council. They bridge the gaps between, they bring the concerns of frontline staff to the quality council for discussion. Ownership of safety culture has to be at all levels. Everybody responsible. The board, the leadership, middle managers, and the frontline. Everybody's responsibility is to keep patient safety, is to adhere to patient safety. It's not only managers' responsibility, everyone's responsibility. It's even the responsibility of the patients, of the relatives attending the patient. We have to educate them also. And a time will come and they will be also given an option to report an incident. It's coming, time is coming. And some organizations are already giving patients the chance to report incidents. So things have to change. Engagement, execution, evolution, this is a process which you have to follow. And it all goes like that. Unless we engage and execute and evaluate, things won't change. And then if we have an organization where we think the culture is not good, we have to acknowledge it, that we have gaps, we have problems. That's why we do patient safety culture. We have to assess the culture and then we have to implement. And the best thing is to have, every organization should have a quality and patient safety program. And presentations should be done by the CEO. We had a CEO in our hospital. She used to present every 2 months a topic on patient safety. Then gradually all heads of departments started. Even admin department used to come. Even maintenance, engineering department used to come and present something about risk assessment of their systems. Everybody has to engage in the safety program. That's how we can disseminate patient safety. These are the approaches to promote patient safety, promote the messages by mission values, by goals, and then by rewarding people, listening and responding. Listen to them if they come to you. And a junior nurse may come to the nursing supervisor and tell her, today I harmed a patient. Listen to them. They will tell you why it happened, where it happened, how I could have done better. Then develop on that story and support them. And next time that same scenario may not happen. But if we shut them down, they'll be depressed and they can harm more patients. Model the behaviors, provide training, and then negotiate to reach agreements on contention and reward. We used to reward the people who used to report maximum incidents. It's not a question of numbers. We were not fooled by the numbers. We were fooled by the quality of reporting, especially near misses. And we used to recognize and reward departments, units, which would report their near misses, close calls, which would develop action plans. There used to be a competition for reporting near misses, and they used to be handsomely rewarded on general staff meetings. So that shows the support the CEO used to give to the whole organization. And then tools are same, leadership commitment at all levels. Incident reporting is the key. Leadership walk-arounds, safety briefings and debriefings have to be done. And hurdles is very important. Hurdles is a tool which you can use to promote patient safety culture. Very important. Every day in the morning, 5 minutes hurdles. 5 minutes if staff come together in a corner in a ward or in a corridor or wherever they are. 5 minutes today, what we have, what challenges we have, who is the high risk patient, how are we going to do it, how are we going to deal with it together as a team. It will help a lot. And SBAR and all those things. I added this SBAR, and 2 things to this SBAR. Identify yourself always and allow the other person to ask questions. Situation, background, assessment, and recommendation, I'm sorry, but always ask the other person to ask questions. What we miss in SBAR is introducing ourselves and asking questions. Give them a chance to ask questions. Hurdles is very important. A reward and recognition system is very, very important as well. And what are the roadblocks to transformation? Numbers are not right. These incidents are not right. We are good enough now. At the moment, we are dealing with patients okay. Not many patients are getting harmed. We will never be good enough. These are all, myths. Some people, there are always some bad apples in organizations. Old school, they'll always tell you, this is not my job. Why should I own it? I'm not getting anything more for this. But if you reward them, recognize them, they will come on board. They are laggards, you know, they slowly will come on board, slowly. And lack of commitment, lack of communication. And some of them genuinely complain because we are not being trained. We're not being trained, so train them. A practical approach for everyone, a good example, unsafe acts are like mosquitoes. You can try to swat them at a time, but there will be always others who come and take their place. The only effective remedy is to drain the swamp in which they breed. It's very, very important. Drain the swamp. This is this is a very important tool. This is brought from politics to healthcare. And the best example of safety culture you can get from aviation. Aviation safety is very, very important. We are not still there as effective as aviation safety, but healthcare organizations are slowly catching up, especially if leadership is going to do a great job. And I think I already discussed this thing on behaviors undermine culture of safety. Behaviors are very, very important. We used to have some senior consultants in some organizations whose behavior was terrible for patient safety. They used to discourage their junior staff to report incidents, and then slowly we identified them and we called them. Confidentially we called them and we talked to them. The CEO talked to them directly in my presence. They were explained that they have to stop such behaviors. And I tell you honestly, we have issued warning letters to very, very senior consultants, heads of departments, for intimidating behaviors, for reckless behaviors. And slowly some of them came on board. Some of them left the organization, but most of them came on board. They realized what they are doing is not right, because their behavior was not changed over the years. Their behavior was the same over the years. And when we tried to intervene, they said, they thought that we are impinging on their authority, on their professionalism, on their certificates, on their training. But eventually they understood that we are telling them something right. So behaviors that undermine patients' culture of safety have to be reprimanded. This is one of my favorite things, which I always say wherever I speak. Act firmly when indicated. Word of caution, advice, reminder. Do not leave reckless, careless, negligent behaviors and practices without punishment and sanctions. Even we might speak that just culture, that culture, this culture, you will always find certain areas where these things are happening. So if people do report repeatedly certain things, they have to be shown the door. You can't tolerate them because they will pollute the whole organization. They'll pollute their unit, they'll pollute the department, and they'll pollute the organization. And I think with this thing, I finish my presentation. And if I have some time left, I can go to the video if you allow me, or we can stop here.
I think it depends on how many questions we have. Thank you so much, Dr. Farooq Mehta. We had quite a few very interesting comments, and I think everything was just turning about leadership. And so basically, what are we going to do if we have leadership that doesn't take this on board? I think that is the most concern. How do we change the culture of leadership? I mean, this wonderful example that you conveyed to us with the CEO even standing in for it. How can we change in an organization that is not up to speed? How can we change that?
Yeah, actually, you know, many organizations, what they have done and how they have addressed this issue, this is a very important issue. They develop a training model in quality and patient safety for the leaders. Leaders had no idea, no concept, because they were not trained. Leader in a hospital is, say, a senior gynecologist, senior surgeon, or a senior physician who took the position of a CEO or a medical director. but they were not trained in quality and patient safety. Sometimes they will tell you, I don't know about it. Come and educate me. So a training model, if you develop for them, I mean, with a lot of respect and regard and a little bit of creaming it up and other things, nice words, convince them that you also need to be trained. And that's the best way to take them. And board has to get involved. Board, all hospitals don't, many hospitals have the boards. Board, training of the board is important. If you train the board, leadership will have no excuse than to accept the training. And who is going to train them? Quality and Patient Safety Director, who is authorized, privileged, and licensed to do that. Yeah, that's important.
You also spoke about fear. Now, fear is one of the triggers not to speak up. Now, you gave us quite a few examples on why, but how can we, in terms of training, how can we train staff to overcome this fear, especially if you're a junior nurse, a junior physician? I think this kind of fear is all there, not only just in hospitals, but I think now we have a culture where nobody actually wants to speak up. How can we change this in terms, especially in patient safety?
It's a wonderful question, and I will try to handle it very carefully and very effectively. You know, one of the best tools in modern patient safety culture development is storytelling. Storytelling is a very effective tool. You have to grab from the literature. What we used to do in our organization, we used to collect some stories from literature where patients were harmed. And harm through this broken system, harm through reckless behaviors. And we used to present those stories in a general staff meeting. And we used to break down those stories into the lessons learned and actions to be taken to avoid those things. And when you disseminate these stories every month in your, at least one story should be told every month, or each department should have a story in their department at the time of morning handover every week, one story. Storytelling is an effective tool. Is the best tool. And then all the thing. Tell them that if they report, they won't be reprimanded, they'll be protected, and give them guarantees that they will be definitely, even at the general staff meeting, they will be brought to on the front, on the dais, and they will be rewarded and recognized. And some of them will be promoted. Some of them will be included in the quality council as champions. This will change the whole pattern. Really, storytelling is important. Very, very important. When you see harm happening, after all, we are humans. It does melt you somewhere. Harm which we could prevent. And I think there will be hardly anybody who won't come on board. Storytelling is the most effective thing.
Wonderful. Thank you so much for your speech. It has been very insightful, and I think we learn our lesson that we actually can take that back to our clinicians tomorrow. That's wonderful. Thank you so much. Do you have any other questions for Dr. Farooq Mirza, please? Okay. Otherwise, thank you once again. I guess our participants will enjoy to get in contact with you and ask you some more questions later. Thank you.
And last of all, I would say one thing. Authority gradient is an enemy of patient safety culture. Authority gradient. Who can break the authority gradient in an organization is the senior leadership. Yeah. They can tell them that nobody is going to pinpoint you, reprimand you, or harm you, or hurt you. We are with you. The authority gradient has to be dismantled completely. The curve has to be flattened. If you see a curve which is flattened in terms of authority gradient, presume that your organization is safe. Otherwise, yes, it's not a safe organization. Thank you,
Very
Suzanne. Yeah.
Thank you so much. Okay, thank
Bye-bye.
you.
Have a nice day. Bye-bye. Thank you.
And you.
Thank you.
So now we move on actually to our last keynote speaker for today. It is Professor James Jordan from the US. Hello.
Hello, how are you?
Very well. How are you?
I am good, thank you.
What time is it
It
at your
is-
place?
It's around noontime, which means that our new puppy may be barking for her walk. So if you hear that, I'll apologize in advance.
Oh, not at all. That's wonderful. I think it's just it's lighten up everything, because I think it's so amazing to have all these different time zones. Because yeah, for others it's just like evening, or surely got to be evening soon. So you have the joy of our last keynote, and I'd like to introduce you to our audience. You're the president and CEO of Strategic Incorporation, which enables both Fortune 500 and startup companies to develop their go-to market, commercialization, and business development strategies. You are also a distinguished service professor of healthcare and biotechnology at Carnegie Mellon University's Heinz College, where you have published numerous articles and books on innovation, startups, intellectual property, and health system. And today we have the pleasure on hearing you about digital transformation of the healthcare system. Please, I'll give you the stage.
Thank you very much. Well, first of all, maybe I'll step back a little bit, because what seems to me as I'm listening to this, usually I like to go to conferences and you physically walk around and you get a sense of what people are talking about. And I generally can adjust my presentation to that. And so it feels like I'm bridging both what we're talking to today to what we're talking to over the next few days. And I think as I listened to people talk today, it struck me some of my journey. So I started out on the manufacturing side of healthcare. I worked for Johnson & Johnson and Boston Scientific. And what struck me is in the 80s, we went through this just-in-time crisis in this country. And basically that country was, our manufacturing base was going away because we had no process excellence, that the challenges that we had in our system were very much finance was running it, and the people that were doing the work weren't giving input. And I just listened to all these conversations on lean management, models of care, and value-based care. And it's so much aligned with what went on at that point in time. Even the last dialogue, you would call them quality circles to get feedback at the time in manufacturing, and leadership needing to change their attitude. And there was a whole group of senior executives that needed serious training to be able to listen and have participatory management. And quite frankly, some had to leave the system. And it sounds like, as I listened to this dialogue, there's something very close to that going on in healthcare right now. And I think, the situation is, in a system that's so big, there's no one way of looking at things. There's so many ways of understanding it. And our dialogue has really been that mistakes are our gift to really discovering how to improve the system. And I think this presentation is a little bit out there in the sense of giving you a sense of what a real-time healthcare system should be, and how the information of the health system is going to start going out and grabbing more information. And this has been a dialogue in the United States for really 15 or 20 years. But it's interesting because it's, on one hand, hard to plan during a crisis. And on the other hand, COVID, a crisis can cause us to be motivated to get some of the systems in. And of course, I heard some people talk today in the earlier presentations about SNOMED and the International Classification of Disease 11 coming out, where we're trying to design it so that we have more clinical language in there, that we have more standardization in the systems, which are all things that have to happen before our dialogue here today. So I just wanted to, put that in as a context. And so, when I think about, I'm writing a book on health systems right now, and what strikes me is I always like to go back and start with history. And you can go back and realize that all the great religions, not every single one of them, really contributed to the formation of the healthcare systems that we have today. And I can think even when I was a kid, my grandmother lived with us, Dr. Wally would still come to our house and take care of my grandmother. And so as we started to make bigger systems now, our fragmentation, which at the early days helped with intimacy, right? Dr. Wally knew my grandmother. He knew all her quirks and all her issues, what she was going to comply with, what she wasn't going to comply with. As we roll that up, this fragmentation contributes to really a systemic misalignment and really strong challenges in coordination and innovation allocation of resources. I was talking to a cardiology friend of mine about 10 years ago about what he saw changing in hospital administration. And he said, you know, the power was moving from the clinician to the MBAs. And you hear a little bit of that today in some of the dialogues that we have, that, you know, we need those skills. We need that insight that they can provide. But at the end of the day, it's about a patient and it's about a life. And so, you know, the promise here is a systems approach can actually communicate how these skills can interrelate, and the dynamic parts can come together to improve outcomes. And the fact of the matter, by having a picture view, a systems approach actually encourages us to be non-biased. And so the last dialogue about safety and dialogue about it's not my fault, you know, systems approach has that intellectual curiosity of what in the system led us down to have that issue with the patient that we have, or to have that death that we have. And that's, you know, that's a pretty hard thing to do, and systems can help us do that. So I recently gave a talk in India with a group of MBA students, and I was trying to say, you know, regardless of what industry that you're in, marketing has a role to play. And that might seem like an odd topic here. We think of marketing as growing sales, but in healthcare, we also think about it as reducing costs so we can take the limited dollars that we have and offer more services. And so, you know, what we're really trying to understand is customer requirements for our system. And the reality is, most of the requirements of our system, because they've been fragmented and put together, we haven't had a purposeful design of what those requirements are. So a lot of those requirements are latent requirements. And some of the conversations about crash carts and what we put on them, or conversations for patients speaking up or nurses speaking up, those are all uncovering requirements. And so, you know, once we understand those things, we can design our system appropriately. So, you know, if you think about it from, I have a very industrial engineer mindset here. So if you think of here where we talk about customer requirements, it's really understanding what those requirements are. Now, those requirements can be very strange things. I think of a time when...
Excuse me, Dr. John, do we should see your presentation? I'm awfully sorry to interrupt.
Oh, no, thank you so much. Yes, you should. It says I'm sharing it.
Just
Can you see it now?
Yes. Wonderful.
All right, I'm going to go back for 2 seconds. That was my context. Questions, promise, perspective, right? So fragmentation, systems thinking can have positive outcomes. Our systems approach communicates how the interrelated parts put together. And again, we're trying to get to a non-biased view. And I was speaking about marketing as understanding customer requirements. And we think of that concept as driving sales from an MBA perspective. But as a systems administrator with given fixed resources, I'm thinking about that if I can reduce the non-value added activities, that actually I can increase my services. So I apologize for that. And thank you for interrupting me. I'll pause. Are there any questions? Because I did sort of have to start in the middle there. I don't see any, so I'll keep going.
No,
so this is simply, this is simply a little model that I have used and blowed out a lot of details in it. But if you think about, if you truly understand what the patient needs and you design your system around it, you're going to get the actual results that you want. Those results could be satisfaction, cost, right? So I have a formula to me for outcomes is maximizing availability, maximizing quality, and reducing absolute cost. And I use the word absolute cost because in hospitals, it's really easy to cost trade among departments. I could be selling into a interventional cardiology suite and tell you that I'm saving you cost, but I'm passing it downstream, or I'm passing it, you know, as an input. So that's important. And so when we think of what can go wrong, we have the concept of having bad benchmarks to the customer expectation, meaning it's an expectation that we did not understand, and therefore our system was designed without that input from the very beginning, and that's a problem. And then, of course, we have conformance issues, which could be the service conformance, it could be the process conformance, and again, our nursing folks have talked about this a lot today. But, you know, when we talk about in traditional marketing about generating demand, there's also this concept now of digital vaccines, of how do we communicate on a more consistent level with our patients through all these different traditional methods that have a marketing orientation to it. And we just sort of switch it to healthcare words. How can we create an intimacy so that people understand the implications of things? And also at the same time, how can we appropriately, with the appropriate privacy detection, be able to anticipate things? And so there was an experiment between the University of Pittsburgh Medical Center and Carnegie Mellon University with having some elder folks being released and opting in. So this is would have been a privacy issue without them opting in. Could we monitor their social media and look for certain words? And what we discovered is a real pattern on just mother to daughter, daughter to sister, whatever it is, talking post-procedure, where people could intervene almost 25 to 33% quicker with the words that are being spoken, which gave an indication that something was going to occur before the event occurred. And so there's an example of how these tools can become available and helpful. So, you know, at the end of the day, when we think of our context in the US healthcare system, it's how do we understand these customer requirements, and that we need some intelligence from our community in terms of how to understand how to meet those expectations. And there are business tools that have been well vetted to do that we have to convert into something that has a little more spiritual in it, because healthcare is more spiritual. And what we're trying to do along the way is eliminate all the non-value added activities so that either, you know, you can maximize profit of the system, and, you know, we think of profit as a bad thing, but if you're a nonprofit firm, you can plow it back. And if you're a for-profit firm, as we have in the US, as long as there's boundaries around your quality, there's nothing wrong with motivating people to make profit. Now, probably something that those outside the US wouldn't necessarily know, but prior to healthcare reform in 2010, believe it or not, we did not tie financial performance and quality together. And now it's tied together at various degrees, and there's a whole history on that I could go into, but it's kind of shocking that it didn't exist. And I know in other countries that it's always been, you know, part of it. So if we step back from that sort of context, what's a real-time healthcare system? What are the challenges? What are its benefits? You know, what are we going after? What are our goals, and what are the steps we can do? And so, you know, COVID has emphasized the importance of flexible structures. So I think that our scientists had limited knowledge of the disease, and so we worked on that. Our healthcare system failed to anticipate surges in cases. And so the impact of that is a relevant portion of our early death was really caused by lack of preparedness. And so government and public health coordination was needed to predict these cases, and the best care protocols needed to be shared. Now, of particular note in the US, the healthcare system, the delivery of healthcare and public health have always sort of been very, very different. And this has forced them to sort of come together. And so that, I think, has been a positive outcome. But, you know, the issue on the bottom left here is healthcare system structures have proven to be inflexible and lack real-time knowledge of the changes in volume. And, you know, from a process perspective, I heard someone earlier talking about the intake of protocols and understanding risk assessments. Well, in process management words, I'd be trying to take that risk assessment and align them to what they call a swim lane process, right? Oh, you go here, you go here, you go here. And there's been a significant lack of really having those systems available, and that lag time has inhibited our health systems from changing capacity and solving problems. And so a dialogue has reinitiated that's really a very old dialogue, but we need this sort of real-time patient population intelligence. And for the healthcare system itself, a lot of that actionable data is outside of healthcare delivery, which by its sort of nature is acute, at least in the US. And so we need to work on that. So, what is a real-time healthcare system? It's designed to optimize workflows and have instant access to all the relevant data about patients. And as I said earlier, I think, some of these aspects of what I'm talking about are going to be hard to do until we have ICD-11 institutionalized. And that doesn't mean launched. It takes several years to get it to where it needs to go. And so the main goal of this is to anticipate and change our swim lanes if we have to, or change the capacity of our swim lanes so that we can enhance care. And it creates a patient-centric environment. And so I started to say, before I realized my slides weren't up, is that I tell the Aunt Ola story. And so this would be my father's great aunt. She needed a valve replacement. And at the time, one of the great pleasures of working for Johnson & Johnson, one of these world-class companies, is they will get you the best doctor in the world for your family. It's just I'm having a moment. It's a wonderful thing. It's a real blessing to have that. And my aunt wouldn't go into Boston to get this done. She wanted to go to Bon Secours Hospital down the street. And you say, Auntie, why would you do that? I'll take you in. Like, I really want you to have the best care in the world. Now, her definition of best care, because she was the equivalent of the elderly candy striper in this hospital, she volunteered. She knew the people. She felt it was comfortable. She knew the nurses. She knew the people that would support her. And so her definition of quality was very different from my definition of quality. And so, we have to understand those components systemically, which again is a piece that we've never really been as understanding of. And of course, like with the concept of just-in-time and lean, the word Kaizen, if that means anything to you in Japanese, continuous improvement, it's a never-ending journey. And just when we get something right, we're going to find something else. And so as we were talking about safety and we were talking about risk, the journey of continuous improvement requires input from the workers. And that attitude has to have an open environment. And I think of just violating that trust once takes things back so far. I mean, you can have a quality circle where for months and months and months, everything's going really well, people are opening up, and then the boss says something critical, and that openness just sort of collapses overnight. And so it's so hard. And so a lack of real-time intelligence and flexible structures really has, as I said, accelerated this. And we use this data to become more efficient at delivering our value proposition. We use it for removing activities that aren't benefiting outcome. And we discover these new specifications that enhance or differentiate our product or service. And so this is the US healthcare system on the right. It may be, it's different around the world, but we have our insurers, we have different management organizations in between, and we have the people that supply the products, and the providers are here, and we've got retail here. As I said, it's a amalgamation of players, each with their own incentives. So I could draw boxes around all these folks and tell you how they're incentivized very differently. And so, this is one of our challenges. So payers, they're looking to increase their revenue, which is their premiums, and they're looking to decrease cost, which is benefits, without losing market share. Now, again, I mentioned that prior to 2010, and it was probably more like 15 to 16 before we got into implementation in the US, payers could collect their money, and there was no law on how much had to go back out into the provider network. And so the new laws in the US say that payers can't keep more than 20 cents on the dollar. They're around at 15.1 now. And if you think about, your credit card, you think about an American Express card versus a Visa. Everyone complains the American Express is looking to take 3%. It should be less. Well, these people are taking 15.1% right now. And so the question is, what are they doing with that? And that's, I think we can get off on what I think is going to happen in the future with that. But I think that's important to understand, but that's their motivation. And the suppliers, they're looking to increase their revenue. They're looking to increase their margin. And they want to do it really with as little evidence of value as they can get away with. And that's not to say that they don't care. It's that they are not being on that side of the box, aware of all the system requirements in the healthcare delivery system. And so they're going to take a view that matches their view. For example, I've been in interventional cardiology, I've been in renal, I've been in vascular surgery, and every time we would launch a product to talk about outcomes, we would do it through that purview. We had no ability to step back and say, what does this mean in the entire healthcare system? We never had the ability to say, oh, a AAA stent graft will solve this particular problem for you, but we didn't realize that it increases maybe diabetes 4 years from now. I mean, we wouldn't have that view, right? That's important to know. And certainly if these companies knew that, they would engage in that, but that's their motivation. And finally, the providers themselves are they're mostly reimbursed for acute care. And so really, as it relates to chronic care, it's only relatively recently that we realized that the reduction in the cost of chronic care can have a very significant impact on the system in a whole number of ways. And we heard some talks about that today, but just to give that sort of context. So the benefits of real time is this sort of digitization, which I call perception, allows us to create models of comprehension, to be able to think ahead and create this loop so that we can make decisions. And I think this is really what we hope that our leadership and institutions are really moving towards, is this systemic intellectual curiosity for detail, because that is really what drives the system. It's something our clinicians understand, our nurses understand. It's in their heads, and we have to get it out. We have to, put it in a system. So continuing on, I talked earlier about what should this serve, and I talked about my definition of outcomes. But when you think of access, I want to be able to reduce the uninsured, and this is maybe more of an issue in the US than other countries that have more socialized medicine. I want to increase prevention. I think of an exercise that I was very much involved with McKesson, which is like one of the biggest companies no one knows about. And they had a congestive heart failure model. And don't hold me to these numbers because it was a decade ago, but I'll give you a perspective on it. They started out on the service side, just answering phones for the blues, calling up these patients and checking their water weight and checking their salt content, their diet and their blood pressure and those various details. And because they weren't making a lot of money on that, they decided to try to see if they can optimize the system as best they can. And, McKesson, AmerisourceBergen, Cardinal, these companies have more pharmacists than even our pharmaceutical industry. And so they put the pharmacists to looking at this, and they came back and they said, whoa, wait a minute. The average congestive heart failure patient averages $64,000 a year, with at the time a variance from a low of 49,000 to a high of $250,000. And you guys are doing it consistently for 57. So we can now go bid to the insurance companies. We'll take it for 57. And if you're a finance person, say, this is something in a system where I can't plan, now I can plan, I'll take it. And so that was a conversation really about the phone calls and the prevention. And when they look into what really helped with that prevention, very early on, the nurses recognized that it was about 6 minutes for a phone call. And they recognized that these patients who were relatively immobile would enjoy that call as a visit. And they realized, okay, if I can get it down to 2 minutes to take your vitals, and if you're well behaved, we get to have a 3-minute visit or a 4-minute visit. And if you don't, you're going to hear a lecture from me for 6. That's a little bitty detail that I'll tell you what, there's no CEO that's ever going to get that level of detail, right? It was the nurses getting that level of detail. And the nurses decided that they were going to team up for each patient so that the patient knew the person. So meaning if nurse 1 was out tomorrow, nurse 2 would be known. And they were able to get the 6 minutes down to 4. They were able to keep the prevention up, and just a great result all along, right? And so 2 things were happening with that. Obviously, the visit was good. There was literacy going on in there, right? And so getting literacy out to people and what they mean, and understanding not only literacy in the patient themselves, but literacy in the programs that we create. So for example, There's a project at Carnegie Mellon University that was working with a public health institution where they were going out and they were bringing healthy food to they call them food deserts here, right? The inner city where they have more of the McDonald's and the junk food as opposed to the fresh fruits and vegetables. And so they made this program and they delivered the food. And the first part of the program was to deliver some utensils. And so at the end of the day, two things happened. The people that were delivering the food didn't have a system to know who got utensils and who didn't get utensils. And then those who got utensils that they didn't even know how to use, meaning that these folks maybe had one pot and pan in their house. They didn't know how to do it. And so at the end of the day, the program failed predominantly because of this silly little piece of we didn't track delivery of utensils and we never got a specification for these economically challenged folks, what they had in their kitchens in the first place. And so the program didn't meet its outcome. So the whole goal here, I gave you stories associated with this, but the whole goal is if we have more access, and part of that last part of that access is interoperability. Now, you know, there's been some great progress through multiple presidents on interoperability, and certainly the World Health Organization, as you know, was working on this with ICD-11. But, you know, a lot of the healthcare firms also put their toes on the line of interoperability to keep their competitive advantage, right? So we think about the Epics and some of these, you know, software companies not letting people in. They're going to try to protect their space. And so there's this wonderful balance of, you know, how do you have a competitive environment where, you know, the Epic wants to be the best that Epic can be and be motivated for all the profit they want to be able to get by performing, and having the appropriate policies to make sure that we open up this interoperability. And of course, we talked about quality today. It's error, it's waste, it's measurement. And we talked about cost is really having this understanding of absolute cost in long term and increasing, you know, incentives and penalties. You know, one of the biggest challenges that I see is I understand in my parents' generation that, you know, charging them to smoke was probably it might not be fair. I mean, my mother told a story that she was told as a 16-year-old girl that her doctor told her if she smoked, she'd stay thin and get a husband. I mean, that's how kind of crazy the world was in those days. You know, today we know better, right? So the question is, 20 years from now, if someone decides to you know, abuse themselves, where's the penalty for that? And so it's so hard to sort of understand that. But again, I talked about the progress we've made in the US. And so I asked the question, of course, now this has been blown out with COVID, so this won't be as true at the moment. But the question did, by putting in the healthcare reforms in the US that we did to try to bring the system together, did we see a change in national healthcare expenditures? And so you can see the decade here and the average gross domestic product, because it's not whether national healthcare expenditure is growing, it's really a question of how far is it deviating from gross domestic product, because that's the financial health of our countries, right? And so the long story short is in the US, there seems to be very early signs that this systemic view and these understanding of having quality systems and carrots as rewards and sticks as penalties, that there's some progress that's being made. So let's discuss, you know, really the concept of digitization. And this is very complex, but it starts with sort of understanding the patient's journey. And you know, when you think about, for the far left here, we've got health, and then we've got, you know, monitoring of care on the right. But they go through these journeys, and for the most part, in the gray here is really where we are today. It's sort of, you know, understanding the electronic healthcare record. We're starting to use our medical devices as you know, electronic data capture devices. That's starting to happen. We're starting to see some clinical decision support, maybe a little precision medicine going on in some places. But all these things are in the context of the healthcare system itself. It's not reaching out into other parts of the system. And so here's simply a map, and we don't have a lot of time to go through this. This is from Gardner, who does a fantastic job with this. going through all the things that sort of need to happen to be able to get more and more information. I actually think tomorrow there's a conversation on the health information exchange too. So I think we can see these changes being made. And what's interesting to me is why I love healthcare. I thought as a little kid, I thought it'd be the coolest thing to be the operations person of an airport. Because of its complexity, right? It's just complex that flights can come in and flights cannot come in, and you have to adjust, you have to get everyone where they're going. And now that I'm in healthcare, I thought, wow, that's hard. But at least all of those changes that you were making, the delays are happening from an input perspective, but the processes never change, they're fixed. And in healthcare, our processes, our swim lanes have to change according to the variability of our patients, which again, can be infinite from that perspective. So, step two, what sort of adjunctive technologies can we use so that patients can self-manage, right? And so we do have a lot of social media, a lot of interactive. We saw earlier interactions with phones that are negative, right? Some of that stuff's negative. How can we use it as a positive? I'm worked with some companies that have done, particularly with children, gamification, where they've been able to, teach them diet, or diabetic children, teach them, the impact on glucose levels in the food they take through games. And so, these concepts of using these social tools to be able to create capacity for any individual to understand and process their disease, they call that digital vaccines. I'm going to skip through here, but the next step would be, what do we do with all these mobile apps? And we were just talking about that a little bit. I love now that during COVID, all of my wellness visits have been, from home. And my wife and I were talking about this, and she's like, I used to have to get up an hour early, drive into the city, pay for parking, and go through this whole process that she doesn't have to do anymore. And so the question lies, as my general practitioner, having a general practitioner visit with me is kind of a curious thing, because I go through all this stuff and we talk about healthcare. But he said, at some point I have to touch you and I have to feel you and I have to sort of understand certain things. But University of Pittsburgh Medical Center has done something rather interesting. They've made sort of these tertiary care centers outside of the city, particularly associated with cancer, where it's a building you can go through to get your tests, and you can dial into the city. And there's this wonderful story in the paper about a 86-year-old man, his 80-year-old wife, and coming in for these checkups. For them, it just exhausted them, and quite frankly took a week and a half for them to just not only emotionally and physically recover from the journey. And now they're talking about they can go down to the street, go into this building, there's a nurse in there, there's equipment in there, they take all the vitals and they have a conversation. I think that, we can see some of those things happening. And I think there's a real debate. I was in a board meeting the other day when an insurance company said, all this is going to go away. And I said, I don't think you understand that the patients won't let it go away now. And so I think COVID has brought us, some of that opportunity from that perspective. And again, the cloud, part of the challenges is how do you replace these legacy systems and deployment costs? The cloud really reduces switching costs, and it really changes barriers. And APIs can allow us to integrate to other systems. I'm shocked every time I go to my doctor, and I've got the newest Apple Watch, or I've got the blood ox, because with COVID I wanted to get the blood ox, and I can't get this information into my doctor's medical record. I can print it out and bring it on my visit, but I can't send it to him. And, for those of us who might have, white coat blood pressure issues, I say, oh, you're running high. And I can say, listen, doc, look at the past 6 months. This is what I've been at. And we calibrated, and I brought my home monitor with me, and we calibrated it was to his, right? So wouldn't it just be easier if this information got to him? Finally, it's really about data analytics. And, a funny story, we all have our really smart friends. So growing up, I was the jock, and I had this friend that was, just absolutely brilliant at everything he did. He's always learning, even to this day. And he was the first CIO of eBay, to give you a sense of how smart he is. And he's very well, as you can imagine, done very well for himself. And so he decided about 2 years ago someone asked him to get involved in creating a new insurance company. And I said, Bob, you have no idea that the nomenclatures. And so a few months into it, he called me up and he said, you're absolutely right. How can I do analytics when the terms are so different? And even if I get the terms correctly in this health system, it doesn't apply to the next health system, so I can make benchmarks. And so these are some of the challenges that we have. And so, what we're trying to do is, as healthcare grows and consumes more of our economy, it actually pulls away from our ability to create jobs, to create wealth, help and put money elsewhere. So it's an important initiative to be able to do this. And a real-time healthcare system must realize that it's actually inside of the bigger economy, which is the point I'm trying to take. And the question is, how do we pull in from that outside economy in ways that are appropriate, like the Apple Watch, like maybe having an Amazon Echo in your house? What sort of information do we have? And as we know from, around the world that, some of these third world countries are more wired with phones than we are, because that's how they in Africa, these vast places to run wires. Well, it's easy to have towers, right? And so mobile enablement is really an opportunity there from that perspective. And so we can see that there's many places that this progress of having disruption technology has really helped starting out. And you can see here that healthcare, we're laggard as it relates to adopting technology, and that's not unfounded in risk, right? I mean, the fact of the matter is that a lot of these technologies that go out there, the lean startup tells you just go out there and get a specification out there and just sort of go with it, and the customer will tell you where the problems are. Well, that's well and good, but that's not going to work in healthcare as much. And so it makes sense to me that we're a laggard, but we're just at the beginning, and we need to be able to pull this together as we go. And so I think, what can happen when you have the right attitude is I just look at Elon Musk and SpaceX, right? If you get into the details of this story and you think about what historically would have been the incumbents, he took a different approach to how he puts the product together, whereas other people, that were competing for this journey in the US on who's going to be the privatized people that go to space. Boeing was used to a cost plus environment, and they were used to having a lot of hardware and a lot of switches. And so when they had a change, it wasn't that, something was pushed out overnight over the internet to change the specifications. You had to physically go and change and wire things. And so it's really about a design mentality. Now, at the same time, you have to be cautious about those things. But I think, we're learning that we need to change the way we think of these tools and the benefit of having that change. So one of the things that struck me as I watched my friend go through this, creating a new insurance company, is the biggest challenge they had was the inflexibility of the existing payers to work with them, because their infrastructure was so established and it wasn't worth their return on investment to make a change. And so that's part of the challenge. And so once we have these data structures in place, I'm working with so many companies that are coming to me and saying, we've got these artificial intelligence models and it does these things, and it all works well and fine on a bench. But the fact of the matter, if you don't have the infrastructure to plug into that's stable and predictable and consistent, you can't really go through this artificial intelligence journey as quickly as you can. So we do see artificial intelligence in certain departments because it's a closed loop system. I think of like imaging packs. Those systems are pretty well established and pretty well organized. So you can see some progress being made in there. And so you can see it in some places, but the goal would be that our entire healthcare system is wired in. And there's a lot of work that we have to do to be able to get there. So, that's really my conversation. But I do want to, talk about this slide, which is oriented towards my students. So I apologize, but the question is, how does healthcare industry come together? So I do have an academic website called healthcaredata.center in the lower left, where you can go on and you can see different views. So I've got, we call them macro and micro maps, where you can see where I've got the clinical management, you've got the verticals under there, like clinical documentation and care planning. You can see all the companies, and you click on the blue there, and it'll actually take you to their website. So that's interesting if someone's interested in that. And then I love, again, Gardner is just amazing. And being an academic, I'm fortunate enough to be able to have access to this, but they have these hypercycles where you can see where technology is. So you can see in the far left that, when they talk about an innovation trigger, it really is a long time before it comes to market, versus on the far right is things that are coming to market. And that's an interactive grid. I also have it on my website, but Gardner, if you search this on Gardner, there's a hyperlink in this presentation that will take you to Gardner, where you can actually roll over these dots if that interests you, and you can get some information on that. So I'll leave you with that. But I mean, I think our journey is that COVID has validated the need for this, real-time intelligence and adaptive systems, and that, we have understood through this process that we have fragmented structures and workflows that need work. And we're trying to build a system that anticipates and adapts. And digitization is a way to get there. Now, at the end of the day, I always say digital transformation is a tool, that it's the people that use the tool at the end of the day. So that's where we need to go. And healthcare, Reformed has really sort of talked about bringing these access, quality, and cost aspects together, where we used to be able to sort of manipulate them depending on where you were in the system. And I think that early evidence in the US shows that this is a positive direction. And I think a competitive landscape provides evidence that there's lots of really bright people working at this right now. And so I leave you with that, but I will share that I've just put a blog series together. So you all have this email. It's on my personal website, jfjordan.com. And you can read further on this. But I started out by talking about the system, and then I start blowing through the details of the system. And so that's available to anybody who's interested. That's my story.
Well, thank you very much, Professor Jordan, for this very, very good presentation, especially now we know what your aunt is looking for in the healthcare system. I think that really portrays also what we have been talking about today. One question I'd like to ask you in this context is, especially now in Germany, Switzerland, France even, we are, or basically the government wants to work towards like a patient card, where all the data is basically put on one, like a Visa, MasterCard kind of thing, and it does not get to plan. There's so many obstacles. There's so many obstacles in terms of the technical issues, but also the consumers. They have all different kind of cards, what they're buying in their local supermarket, and all these kind of loyalty cards. But when it comes to actually having these cards with your digital information about your health on it, that's something that blocks it all. What is your explanation, or what is your approach to these issues?
So do you think, so I think a lot of that is, I'm going to stop my screen so I can see you all. I think a lot of that is fear-based, right? That what are they going to do with it? How can I get in there and adjust it? And what's in it for me? And I think that's the piece that, so what is in that card for you? And what's interesting is all of our governments have some sort of, in the United States, the Social Security system, we all have some mechanism of tracking towards our retirements and our monies and all that. We've become very comfortable with that because our grandparents had it and our parents had it, right? And so there's a legacy, and the security is sort of there most of the time. And so there's a benefit to it because it's your retirement. You go in and you check it and you fix it and all that. I think that we have to get that attitude about our healthcare, and the experiments that we're doing in the US. The people that are amazing at going in and engaging in this are mothers. They won't do it for themselves, but they'll go in to make sure that their child has the right record, even if it's a dogged issue. And so in the US right now, one of the challenges is how do you get to that record and how do you repair it? I have some strange thing on my record that I've been trying to get removed for a couple of years. I guess, well, they have me down as a smoker. Never smoked. I think what happened is someone was taking a family intake. My dad was a smoker. And so somehow that's in there, right? So now that wrecks my rating. And it's sort of like, you think of your credit rating. The government had to come back and enforce an adjudication process. So I think, it's probably not a terrible idea. In fact, it's a great idea if you can trust the privacy of it, the security of it. There's so many, my dean at CMU always says that the technology always evolves faster than the policy, right? Because you can do something, it doesn't mean that I'm doing it right or I'm facing it right. So what happens when you're discriminated against because you have two employees and one has a family history of cancer, carries the BRCA gene or something like that, right? So I think society hasn't trusted yet and they don't see the benefit in it.
Yeah, that could well be. Yeah, thank you very much. Do you have any other questions for Professor Jordan?
Downside of the end of the day.
Well, thank you so much for your presentation. Really, really, really informative. Yeah, so I am afraid we're at the end of all our speeches for today, all our keynote speakers, every speaker for today. Thank you once again very much from me as a chairperson for today. And I think we're moving on now to a question and answer session, if there are any regarding the day. Anything that came up as a concern, anything now, as Dr. Farouk Mirza said, we have to speak up. If there is anything that is to our concern or that we would like to discuss more in depth, may I just open the panel now?
Keeping quiet is not the option.
Yeah, exactly.
Well, I would just add that it'd be great to link to everybody on LinkedIn. I found Carol already. I don't know if she I couldn't get everyone's name in there, but everyone's innovating. And I think innovators need to stay connected. And I also think that, innovators can also have to create some chaos in their institutions, and they need to talk to someone about it. And I think a group such as this, it's always nice to talk about someone that's outside of your health system. I think that I find that very valuable.
Absolutely, and benefit from the experience that other people are doing, other countries are doing, and to share that, I think that is always the biggest goal and the biggest benefit from a conference like this. Yeah. If there aren't any more questions, if you're actually happy with today's speech, if you learned a lot, so I hope, if you're really happy, then I think I am actually left to close the session for today. And tomorrow morning, I may inform you that it will start at 8:30 London Standard Time. And the chairperson for tomorrow will be Mrs. Sherifat Kamal. We heard her today as well. So I'm quite glad to give over for the next day to her. And that's all that's from me now. Wishing you a very, very nice afternoon or evening or wherever you are in this time.
Or night.
Or night, exactly. Absolutely. Enjoy the nice weather or the snow, or sleep well wherever you are, and see you tomorrow. Thank you so much to everybody for your time and your participation, and have a wonderful time. Okay.
Thank you.
Thank you
so
Have
much.
a wonderful time. Thank
Same
you.
to all.
Thank you.
Okay,
Thank
bye.
you.
See you tomorrow. Bye-bye.
Thank you to all.
Thank you.
Thank you very much. I'm sorry my camera not working.